hello, hello, check, hello, hello, check, hello, hello, check, hello.
Hello, hello, mic test. Hello. It's okay.
Hello, 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 check, hello, 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 hello. थोड़ा सा इसका वॉल्यूम कम। हेलो, 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 चेक, चेक, हेलो, 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 हेलो। थोड़ा सा बढ़ाइए। एक पॉइंट। हेलो, बस।
Hello, hello.
Hello. Very good morning to everyone. All those who have not completed the registration process are requested to kindly complete the registration process right outside this hall and then be seated so that we can start with today's program. Thank you.
Good morning, ladies and gentlemen. Welcome to 7th National Conference of Indian Society of Kawasaki Disease. And we'll start with the day with workshop on coronary artery imaging in children. And for this, we have the pediatric cardiologist from Kochi, Dr. Saji Philip, and Dr. Arun Prasad. And further to assist this workshop, we have Dr. Rakesh Pilania with us, and Dr. Suprit Archan also will be there. So without much delay, we'll start the program. I invite Dr. Saji Philip to deliver the talk.
Can you off this light? EA light off or stage light off? Good morning. It's my immense pleasure to join with the 7th Indian Society of Kawasaki Disease. And the morning session we will start with the coronary artery evaluation by echocardiography. I'm just showing and displaying our website. Everyone should go through this website, and it is really beneficial and to become a member. Why we are conducting this workshop? Because you should understand that a lot of long-term cardiovascular sequelae of Kawasaki disease happening, including vasculitis, myocarditis, heart failure, valvulitis, coronary ectasia, aneurysm. People are concentrating only on coronary artery by echo. No, you have to see any effusion, global strain echo, valvulitis, any regurgitation. These are all important things. And acute and cardiac complications also related to that. So that is the reason it is very important thing, because late complication, it can occur thrombosis, aneurysm, myocardial infarction, premature atherosclerosis, and the myocardial fibrosis, etc. So the development of coronary artery aneurysm is the most detrimental sequelae of the KD. If it is untreated, around 23 to 25% will get aneurysm changes. So some of the practical points and pitfalls in the evaluation of the Kawasaki coronary artery disease by 2D echocardiogram, I just want to show. Many studies in a different way they published, but as far as my observation, I also found that the most common tertiary segment is involving is left anterior descending. Some publication says that RCA is the first and second is LAD. But for me, my observation, LAD is first, and then subsequently RCA also seen. Combined is different. And third is left main coronary artery, and the junction, fourth is circumflex, and the junction between RCA and PDA, and marginal artery and PDA, etc. Some of the basic understanding that the fusiform, saccular, and ectasia. This is almost like a fusiform and saccular also you can see together. Saccular means both axial and lateral diameter is equal, and fusiform, the lateral diameter will be larger than the axial diameter. As everyone knows that this criteria from the American Heart Association regarding the Z-scores, less than 2 is normal and 2 to 2.5 is dilatation, and small, they classified as small, medium and large. They have not mentioned the giant aneurysm. I myself, little modification I did, means 8 to 10 Z-score I put it as large, and above 10 I put it as giant. Because for us, when you coin that name, giant, people are a little more serious about that condition, and they will give more care for high risk group. So more than 10, definitely make it as a giant aneurysm. And this is the C-score I am using. In the Google Play Store, you get this pediatric calculator, and your weight and height you enter, and then this is the coronary artery, and then you get the C-score. Accordingly, you can mention. The probe selection will be higher frequency, will be more better, but most of the institutions, they have only 3 to 5. That's fine. But the coronary artery flow and the coronary artery delineation better by 5 to 9 millihertz probe. So either you can in a sitting posture, or right lateral decubates, or left lateral decubates, or pacifier, or with sedation you can do that. And so teaching, we have few teaching modules. We created a coronary artery echocardiogram by 7 modules I put it into. The first module 1 is short axis view. Everyone should take, including all pediatricians should learn short axis view. That's what our aim is, to teach even pediatricians also in the ICU. They have usually small portable machine for cranial ultrasound. People used to do by neonatologists and other the pediatricians. So they should learn one short axis view. Entire congenital heart disease, even majority we can identify, including ductal artery, the PDA, PS, PR, tricuspid valve regurgitation, and VSD, ASD, all important parameter from the short axis view. So if you, this short axis view, if you go up, that is a high short axis view, you will get an entire course of the LAD. So this is a one movie clip. Why visually you can see immediately then RCA is playing there. And if you freeze it, sometimes it's difficult to see. So you should have a practice to see. Even in the movie clip, you can observe the edema and the irregularity and the parallel course from that. So the 10 o'clock position is RCA, and 4 o'clock position is the left anterior descending artery. And this is the same view I am showing, that a huge fusiform aneurysm. And high short, module 2 is a high short axis view. What you have to do, first you have to take parasonal long axis view. The probe should be towards the left right shoulder, and then you turn to probe mark towards the left shoulder. Then you move the probe little up towards the suprasternal space. Then you get the high short axis view. There you get the entire LAD. You can see this is a normal LAD, whereas this LAD is a huge fusiform aneurysm. You can see. See, this is the normal one, even including a D1. You can see diagonal. The same one, another case with a huge fusiform aneurysm. And module 3 is parasonal long axis view. There, first you have to take the parasonal long axis view and move the probe towards your side. You get the RVOT view, and opposite side you get a inflow view, tricuspid valve flow. So this is the interventricular septum, and the entire course through the interventricular septum is LAD. So almost nearing the distal portion also, if you can visualize, if you can take up the view. Here you just see that this entire fusiform, this parasonal long axis view, then you modify for the pulmonary valve, and then interventricular septum. You can see the entire LAD is dilated here. And module 4 is little difficult, but not really difficult, because the posterior aspect of posterior descending artery, what you have to do, apical 4-chamber view, apical 5-chamber view, then modify slowly. You just see that. I am going to take the coronary sinus. This is a 5-chamber view. This is the coronary sinus. Then coronary sinus is the posterior aspect of the heart, so that you can easily identify the posterior interventricular septal portion, and there you can see the PDA. You can visualize. So module 5 is module 5 is actually apical 5-chamber view for the RC and the left main. Coronary sinus, if you take, there if you, near the annulus of the anterior tricuspid valve leaflet portion, there if you see a hypoechoic round shadow, most often the aneurysm between the marginal artery and the PDA can be delineated here. And the module 6 is actually subcostal view. Important thing is this is the RVOT view. There you can see the hyperechoic area, that is actually epicardial fat. Many times I mentioned this is a fat protecting the coronary artery. In the echocardiography you see a bright area. Through the bright area, hypoechoic area you see, that is coronary artery. You won't misdiagnose as atrial appendage or etc. So this is the RVOT view in the subcostal view. That hyperechoic area, you see a hypoechoic area, round one, that is a short axis cut of the LAD. So some of the intima you can visualize. What you have to do, some zoom 4 times at least. Then you can see a very thin hyperechoic area, that is the intima. That intima you can measure actually, intimal thickening. This is the pig coronary artery, which I induced coronary artery intimal proliferation by injecting horse serum and producing immune complex vasculitis. So this is the intimal thickening. You can see. As I said, definitely you have to watch for any effusion, and also you have to do the global strain echo. It is very important thing to assess the LV function. Now the M-mode EF is outdated. Kindly remember that, because the Indian Academy of Echocardiography Association also mentioned that M-mode is outdated. Either you have to do Simpson method, that is systolic and diastolic phase, and then you draw the line and you get the EF. That is Simpson method is a second alternative if you cannot do the global strain echo or your machine doesn't have. If you have a global strain, now all the machine is very quickly calculate now. So the machine, little bit variations are there. Philips machine I am taking -25, above is normal. GE machine I am taking below -20. Taken as LV systolic function dysfunction. So around 80% of cases of the Kawasaki disease get myocarditis. So that is the reason I said LV systolic function you should look, and any valvular leak you have to see. That means the indication of the valvulitis, and then the coronary artery you have to see. So thank you so much. Some pitfalls are there, maybe while doing the echo we can say that. So I request the team, Dr. Devata, Pilania, other patient had come.
So basically for the hands-on experience, we will divide at 2 stations. So delegates can come, like half of the delegates can come to the station 1 and half then go to the station 2. And then after 20 minutes we'll interchange, so that you have exposure to the both of the examiners and experts. So may I request to, if some, like delegates are outside also there, they can also come, so that we should start the station as soon as possible.
माइक चाहिए क्या? इधर ही तो है, पहले से वहाँ पे इको विको होगा ना? नहीं होगा? थैंक यू, थैंक यू, थैंक यू. What we need to do is, first of all, good morning everyone. So I'll just demonstrate you how to visualize the coronary arteries. Now, for the first thing you should know is, so coronary arteries are sub-centimetric or millimeters. They are in millimeters, really more than we do not get Kawasaki patients above that age, except that when you are following them up. So the first thing you need to know is to bring the picture and optimize. Just like any basic echocardiogram, there are two parts of echocardiogram. One is to bring out the picture, that is, I show the diagram and this thing. And the second thing is the interpretation. Obviously, as you know, to be very frankly speaking, in IPL nowadays you have not only 2 umpires. In our childhood there used to be 2 umpires. Now there are almost 3 to 4 umpires. Why? Because 2 umpires on the field, they cannot see everything. So now they are taking help of 2 extra umpires. If needed, they will bring more. Because now we have to, because one single out, one single catch, or one single run out costs a lot. That is the so definitely, if 6 umpires are utilized to bring out one single thing, then you can understand a heart which is beating at a rate of, in an infant, it is beating at a rate of approximately 120 to 140. In an older child, it is beating at a rate of approximately 80 to 100, more so if the baby is tachycardic. So that is the reason you have to bring out and optimize the image so that we can figure the things. The second part is the interpretation. That means, as you have heard, so the second thing is interpretation. As you know, we are all common people. We are not art connoisseurs. So if I visit the Louvre Museum, where plenty of Van Gogh paintings and other paintings are there, to me everything is same, isn't it? just like modern art. But at the same time, to an art connoisseur, they are all different. One is potato eater, one is something else. So I would interpret everything as, "Hey, kya hai? Ye to mera bachcha bhi karta hai. My 3-year-old son can also do that one." That's it. So similarly, the interpretation, the second part of the echocardiogram, or the most important part, is the interpretation. What might be normal to you may be abnormal to me. What might be normal to me may be abnormal to you. So there comes the video, the different observers. And remember, at the same time, can a single patient observed at different points of time by two different observers give two different reports? Definitely. More so in case of Kawasaki disease. The reason being, most of the aneurysms, if at all, they do not come within the first week. Sometimes pediatrician colleagues send the patient to us to know whether there is a Kawasaki disease or not. At that time, your clinical evaluation and clinical assessment should be paramount. Otherwise, what happens is, print a number of times that the disease might not be apparent coronary artery disease, or coronary affection might not be the first week. So we have to wait until the second and third weeks to come. But the golden question is, should we wait until the damage is done? No. So the clinical basis would be more. I think I'll take off the mic. Otherwise, it will be
इसको बंद कर मनफूस देख लेना मैं बताता हूँ मनफूस मैं दिखाता हूँ आपको सबसे ज़्यादा मतलब जो कुछ चीज़ें हम एड्रेस करेंगे प्रेजेंटेशन जैसे भी होगा मुझे बता देना ठीक है इस पेपर चेक कर लेते ठीक है ठीक है माइक चल रहा है प्रेजेंटेशन
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Hello. Good morning, ladies and gentlemen. Please be seated. Welcome to Indian Society of Kawasaki Disease 7th National Conference. And now we'll have a discussion on coronary artery imaging by CT angiography. And for this, I will invite Professor Dr. Manful Singhal. Professor Dr. Manful Singhal is a Professor of Radiology at PGIMH Chandigarh. Sir, over to you for the presentation. Slide, please. Slide, please.
Okay. Professor Manful Singh doesn't need any much introduction. He has taken enormous interest in the Kawasaki disease and more in the radiology. So hand over to Dr. Manful Singh.
Thank you so much, and indeed it's a pleasure to be here in Patna. And I feel together all the caregivers for the Kawasaki disease, we can make difference not only to the patient but the family's life. So why I'm here is the contention is the echo, which is the standard of care for management of Kawasaki disease, is enough. And what is the role, current thought process and the current guidelines about the role of CT coronary angiography. So I will begin with the real story. This was just post-COVID in the November of 2022. A 7-month-old infant was referred from the Assam, the northeast area, to our institution. So you know, this patient traveled more than 2,500 kilometers to our institution. That presentation, he had a history of high-grade fever and was treated by oral antipyretics and antimicrobials, but continued to be symptomatic. By third week of illness, he had generalized swelling and echo showed pericardial effusion, moderate MR, and was treated with, which required mechanical ventilation and big support. You know, with this, when the patient had a relentless clinical course and treated by the usual antimicrobials and antipyretics, didn't improve much. And with 10th week of illness, which is already late, somebody from our institution who was trained in PGI saw this case and found giant aneurysm LAD with thrombus, and that's how was referred to us. So this was the echocardiogram as we have shown in the workshop how to image the coronary arteries. This is the standard of care of investigation. You see the left main artery which is showing dilatation, and if you go still further you find a giant aneurysm in the LAD, and this is in thrombus in it, and this again shows an dilated proximal right coronary artery. As per the institutional practice and what we have evolved over 1 decade, any patient who is clinically stabilized we do in CT angiogram to see what is the extent of the disease. So what we see over here is this is the right coronary artery which was dilated on echocardiography but didn't opacify beyond this. So this was interpreted as thrombosed RCA, And if you see these images, these are the axial images in which you see this is giant aneurysm, and this hypodense filling defect is a thrombus. And the RCA, the LED beyond that, if you see in this curved reformatted images, is fusiform. There's a fusiform giant aneurysm. And more importantly, the LCX, which is very difficult to interrogate on echocardiogram, was also dilated in its entire course. So what the lessons that we have learned is that the coronary artery aneurysms and the coronary artery abnormalities can occur in any segment of the coronary arteries, and it may not be that much important during the acute phase. So I will be using 3 or 4 words, so I need to explain them. Acute phase of coronary KD means when the patient has been diagnosed for the first time and on treatment. Convalescence probably is a period when this acute phase has weaned off and patient has become stable, and the longitudinal follow-up will be, the following up this coronary artery abnormality in the long run. So we see, and probably everybody in this hall will agree, the echocardiograph, though it is standard of care and it is the wonderful modality, but probably it is not enough for deleting the extent and morphology of coronary artery abnormalities, and you can easily miss distal CAs. This is during the acute phase as well as during the convalescence, and when the patient we have to follow them, there is no imaging modality for the long-term surveillance, and we'll go into details in the evening when we have a presentation on CT coronary angiogram. So we'll see few case-based things because this is a workshop, so we have taken cases from our archives. So this was an KD patient at presentation. So what we saw over here is a dilated left main artery, very nicely seen, a very nicely done echocardiogram by our team. This is the left anterior descending and the left circumflex, which was probably normal, and this is the RCA, very nicely seen. So the patient was stabilized as per our protocol. We did an CT coronary angiogram. So what you see over here, you see this is a single coronary artery. So this is the left main, left anterior descending, left RCA, and this is the RCA which is having common origin from the or is arising from the left main artery. You can see this on the axial image over here. So when you see all the blood is flowing through a single vessel, it is bound to be dilated. It is bound to have bigger. It will be bigger in size. So this is an anatomical variant which on echocardiogram will be seen as dilated LMCA, but this is just an anatomical variation. So with this, we were reassured that this is not an abnormal coronary arteries, and there's how the intensification of treatment or the treatment pattern or the treatment this has to be modified, and this was reassuring for the parents as well as for the treating team. Another patient, if you see, there's a dilated LED over here, and the RC also shows dilatation. Once the patient stabilized means before the patient went home, we did a CT angiogram, and what you see, this is an anomalous origin of the left main artery from the this is the pulmonary artery. So this is an anomalous origin of what we call as an L kappa. So when there is a shunt from the high to low flow area, the arteries will be dilated. So this is again reassuring that dilatation of the arteries is not a consequence of the disease, but as a consequence of the anatomical variation or the anatomical anomalies. So recently we have collected this data, and it is now under print and publication in World Journal of Clinical Radiology. That will come in the March issue of the same journal. Now this is the problem solving tools is very reassuring. Imagine if these patients had not gone this investigation, they would have been on long-term antiplatelet drugs, or and with this, when we could ascertain very definitely these coronaries are not abnormal. So in fact, the last case which I showed, this patient had a systolic dysfunction. Rakesh, we are right, and this was pursued actively with our CTVS surgeons, and this artery was implanted, and this patient is doing very well. In fact, it's a game changer. Sometimes you get this thing. So when you get, as Dr. Saji Philip was telling, most of the patients having coronary artery abnormalities has myocarditis as well. So you can, erroneously think that myocardial dysfunction is probably due to the disease, but it was, in this case, it was not probably due to disease, just because of the anomalous origin of this coronary artery. Again, we had been seeing what is the role of CT coronary angiogram in evaluation of distal coronary arteries. In fact, one of the reviewers, and many you will agree and have been asking me, how does it matter if you find a distal coronary artery aneurysms? And this was the question pertinent asked by one of the reviewers in one of the manuscripts that we submitted to Archive of Childhood Diseases. At acute phase, it doesn't matter, and we will never recommend doing a CT angiogram during acute phase because child is sick and is under treatment. Why to subject that irritable kid to a CT coronary angiogram, in which chances of doing CT coronary angiogram and getting a good quality images are remote. So once the child stabilizes, and before going home, at least all the patients, this may be a strong statement, should go and CT coronary angiogram for two reasons. One is to find the comprehensive evaluation of the coronary arteries, and third thing, if there are no abnormalities, you are reassured that you know how to follow these patients and you can manage the further longitudinal management. So this concept was published in the Rheumatology Oxford and is getting widely cited nowadays. I will show you some examples. You see this echocardiogram image. This is 6 years old at presentation. What you see over here is the dilated, fusiformly dilated LAD. This is an RCA, which is proximal RCA appears normal. However, just beyond that, you see there is an aneurysm, and this is an aneurysm that you could easily miss out in the proximal LCX. So what you saw on CTCA is this in proximal RCA is normal, which is syncing with the echocardiogram images. The aneurysm you can see on the proximal artery very nicely, but there are 3 aneurysms in the RCA which were discontinuous. This can easily be missed on echocardiogram, at least not maybe in the unexperienced hands. And in the LAD you see there is a large fusiform aneurysm, and so was in the LCX. So the CTCA will give you not about the number, morphology, their extension into their branches. Another one such case is a dumbbell-belled fusiform aneurysm in the proximal LAD, and you see one large aneurysm in the RCA, and usually you will find this aneurysm at the branching points. This is in the distal RCA, which though can be seen on echocardiogram but may not be always possible. So this is another patient. This was on follow-up. Actually, this patient had undergone echocardiogram n number of times but continues to be symptomatic, and was referred us for CT angiogram, and we find an isolated aneurysm, fusiform aneurysm in the mid part of the RCA, which was never picked up. And this is how you make difference to the patient life, and patient was started on appropriate antiplatelet therapy. Then again, problematic area that you see on echocardiogram is in evaluation of LCX. I was listening very carefully about Dr. Saji Philip. He was telling me which is the arteries which are most commonly involved. If I had to put together in one basket, it is probably the proximal segments of the left antedescending and the RCA. In some population, if you have to, maybe some says it is only the LAD is more common or the RCA more common. Let's say proximal segments of these arteries are involved. And if you see the normal Z score, they are not available for LCX. Probably it is not very well visualized on echocardiograms. It makes sense. So recently, we collected our data, and this is now on publication. If you want, I can share this full text. It is published in Lancet Regional Health Southeast Asia. I will show some examples. You see all arteries are dilated, that's fine. But you see the LCX is dilated, so is obtuse marginal one branch. You will never see this in an echocardiogram, and more importantly, you can see the other abnormalities like the pericardial effusions, pleural effusions very nicely on the CT coronary angiogram. This patient having grape-like appearance in one of the obtuse marginal branch of LCX. Maybe another 2-3 minutes. Another patient having a giant aneurysm in the LAD going into the LCX, and you see one obtuse marginal branch going and the LCX is thrombosed. Another one patient, this is an echocardiogram at presentation. You see a fusiform aneurysm in the left main going into the LAD, And when you do a coronary angiogram, you see a small hypodense filling defect, very easily missed on echocardiogram and very nicely picked on CT coronary angiograms. You know, another patient, you can see the holistic picture of the coronary arteries. You can see the proximal arteries on echocardiogram very well, but the distal and the branch vessel involvement may be very difficult. You see the beaded appearance of the right coronary LAD as with the LCX. LCX proximal though appears normal, but distal is dilated. I'll show you another patient. This is the same patient on follow-up. So what you see over here, you can see only, because as a child grows, you have a limited acoustic window, so we could see only the proximal or the left main. But you see on CTCA, what you see this aneurysm has remodeled, and you find two areas of stenosis, one the proximal LAD as well as the mid LAD, and tight stenosis in one of its diagonal one branch, and you see calcifications as well. And this patient recently had a CT angiogram, and during his vigorous exercises he expired. That tells us how to integrate the myocardial perfusion imaging. That's again a separate topic. Again, thrombus seen in one of the aneurysm in the proximal LAD. This on follow-up, you see this in heavily calcified aneurysm. By no way, air and calcification are the enemies of ultrasound. You cannot see them. And if you see on CT coronary angiogram, this is thrombosed calcified aneurysm. No way we can detect it other than either the catheter angiogram or the coronary angiogram. And you see then another aneurysm sitting in the RCA which is showing calcifications. We know that the Kawasaki disease though primarily involves the coronary arteries, but CT angio gives you a chance to evaluate the other systemic arteries provided there is a clinical suspicion, but this should not be a matter of routine. So this is one such patient who had anomalous RCA and the large aneurysm in the proximal LAD, and on clinical evaluation they found some swellings along the axilla, and what you find the multiple aneurysms in the left subclavian vein and the this is the left subclavian, right subclavian arteries, and so were the dilated distal aorta and the common iliac arteries. So CT angiogram in those phases is a problem solver and give you the holistic and the comprehensive evaluation of coronary arteries. If the time permits, there were some questions which CT scanner is appropriate for doing these scans. Usually if you have to see the evaluation of CT scanners, it was only after the advent of volumetric data acquisition by 64 multi-detector CT angiogram became reality in the year 2004. After that there had been remarkable progress, and we got higher detectors, CT scanners, maybe 1000 or more, and we got dual source CT scanners which are very fast scanners and have multiple detectors, so they physiologically freeze the beating heart to give this pristine and clear images. So as of now, if you have to do a CT coronary angiogram, you can at least start if you have a minimum 128 slice scanner or a dual source CT scanners in your institutions. And from this podium I can assure you of our full support if you wish to start your program. And more importantly, we will not require or ask for any support. We will support ourselves, we will support our travel, we will support our stay, and we will be more than happy to establish these facilities in your institutions, in your city, provided people are interested in doing that. I tell you, this is a great service which can make a large impact on not only the patient but the patient families, and it is very, very satisfying, very, very satisfying in the end. If there are any questions, we can discuss at this moment. Yes, ma'am.
I'm Dr. Anuspandana, Professor Pediatrics and Pediatric Cardiology Fellow. Actually, everything is well, okay, we go with CT, but the main issue arises when we go for the anesthesia part. The parents, when we counsel that we need an anesthesia, so how do you manage with the CT angio without So you must be giving
You know,
anesthesia.
that's a brilliant question. I think Rakesh is
Yes.
sitting, he can answer you that we don't use anesthesia.
So that is a very important question, ma'am, because whenever we are doing CT coronary angiography in children, in more than 5 years, we hardly require any sedation. And so in less than 5 years, we use the sedation as a midazolam injection, and we never use a general anesthesia as a requirement for CT coronary angiography in our patients. So that's where we use triclofos, that is a pedicloryl, and followed by midazolam in most of the patients, 99%, and that's how because this is a very short procedure and the midazolam will work here. So I don't recall any patients where we have used general anesthesia in any of the patients, and that is we have reported in all the studies also.
And ma'am, will you believe this procedure is scanning time is only 3 seconds. So we give midazolam when everything is set right on the table. We give a short dose of midazolam, and there's dedicated team. In fact, no anesthesiologist is involved during the procedure. It is only the pediatric fellows who come and give sedation, and it works very well.
And the most important component is the teamwork, because basically our senior residents, 2 of our senior residents will be accompanying one patient, and junior residents, and along with resuscitation team. So that's how we maintain. So because it's a procedure is only for 2 minutes, but we maintain like that. We maintain a protocol for that, so that that patient consent and everything will be getting for a day prior, and then we explain all the procedure, and then -2 hours, 0 hours, and at the time of event what we have to be done, everything is documented in the protocol. So but most important component is our senior resident who are on the toe at the time, and they manages everything.
So,
Sir, so our cohort, the entry criterion is those who had an aneurysm in the echo. So what do you feel if the patient has a normal coronary by echo assessment? Do you still feel they may have some distal aneurysms? Because we didn't assess in that manner.
You know, brilliant, many people will ask me the same. As far as my individual and my inconsiderate view, all patients, once clinically stabilized, should go and comprehensive evaluation, and that is probably the CT coronary angiogram. It will give you many answers.
So probably that may give the answer.
Yes. Distal may occur in isolation, but it's very rare. But if you ask me, we don't want to miss even a single patient. So I think doing CT coronary angiogram in all the patients, the sentiments are going in this field. Maybe in the years to come, it will become a Sagar.
Basically, sir, in coronary, in echocardiograms, many times we see that there are transient dilatations which kind of resolve after 6 weeks. So even if we recommend a CT angio, will it be the best time? Will it be? Is it a time to decide the best time to do a CT angio? Is what I want to ask, because after 6 weeks, many patients may have complete resolution on echocardiogram, and maybe 3 to 6 months down the line, if I do a CT angio, will it add more value than doing it at 1 month of the illness? Because we may pick up abnormalities which may be transient.
That answers come from the recent THA guidelines. If you see any coronary artery abnormality having Z score more than 2.5, they say you consider CTCA once the child goes home. Yeah, there may be difference of opinion when it should be done. So if you see, read those guidelines, they are silent on this. So as far as I am concerned, it is better to do once before the patient goes home, and then you can follow them up. Or if you feel like everything is going fine, you can do at any time. I think with the time, these guidelines will also come up.
Okay, sir. Thank you.
Progressive involvement of coronary artery changes. So I really personally prefer convalescent stage will be the time for CT.
Yes,
Maybe
I agree.
the opinion may have difference.
Convalescence means when the acute phase has weaned off.
Because progressive they show the coronary artery
Yes.
little bit later also.
Yes,
so
yes.
Immediately acute phase immediately after the admission, if I do, sometimes I miss again. So again, one more repeat CT may not be used.
No,
good
that's
for
fine. You have to do one only CT angiogram at presentation. Maybe during convalescence, maybe after 6 weeks, or sometimes, it all depends.
Yeah.
Say in patients, lot of things we have to consider. Say patient, we are sitting in Chandigarh, patient is coming from 500 kilometers. So we tell their parents, would you like to get it done now, or you would like to come after 2 months? If they feel, they say, we want to get it done now, so we do at that time. People will say, we'll come after 2 months or 3 months, then we'll do at that time. So, we are flexible in that approach. But definitely we try to do CT and angiogram nowadays in all the patients. I think we should go into the next session then. So we will have more such cases in the afternoon. We will see what is the expanding role of it and what are the recent guidelines. Okay, then thank you.
Good morning, everyone. We'll take a small break for tea. So I request everyone to come back at 10:30. It's 10:15 right now. And one more announcement, all those who have their e-posters, they're requested to kindly go outside the hall. There's a system there, so you can connect your pen drive and have it displayed on the screen. Thank you very much. सर का पेन ड्राइव ले लीजिएगा इनका टैग है इसके बाद जो पहला टॉप होगा Everyone is requested to go to the behind the hall. Tea is this side. It's served in the hall behind the screen. सर एक ही Hello? Hello?
Good morning, everyone. Hello. Good morning, everyone. We'll be conducting the quiz for the postgraduates. I request the postgraduates to take the answer sheet. So the sheet has to mark the options for 50 questions. You have to write your name, institute name, and your mobile number on that. Please don't forget to write your name, mobile number, and institute name. So,
Requesting all those delegates who are interested to participate in the quiz to just raise their hand so that we can start giving the answer sheets. Thank you very much. Anyone in this table interested for the quiz? Kaji. Ma'am, all delegates can participate. Yeah, all those who are interested can participate. Ma'am.
on the answer sheets, please write your name, institute name, and your phone number.
Anyone who's interested to participate in the quiz and has not received the answer sheet, kindly raise your hand. You'll be getting the answer sheet.
Good morning. I'm Dr. Puneet. So we'll be starting the quiz. So there are 50 questions. Write the correct option in the answer sheet which has been provided to you. So we'll give 30 seconds for each question. Question will be displayed only once and we will not go back to the questions. Each question has only one correct answer. You have to write the correct option in front of the number which has in the sheet which has been provided. And don't forget to write your name, institute name, and phone number on the answer sheet. Shall we start? So, here's the first question. Kawasaki disease most commonly occurs in children in which age group? Options are less than 4 months, 1 to 5 years, 5 to 9 years, and more than 9 years. Sure, sir. Yes. Okay, we'll move to the next question. Dr. Tomasho Kawasaki first reported the eponymous disease in the year, which year? 1964, 1965, 1966 or 1967? Next question. The utility of IVIG in the management of KD was first reported by A. Kawasaki, B. Purusho, T. Kobayashi, D. Hamada. We'll move to the next question. Which of the following is part of the WHO case definition for MISC? Bilateral purulent conjunctivitis, hypertension, pericarditis, or dysentery? Move to the next question. Sorry. According to AHA, which is one of the 5 principal clinical features of KD? A. Diarrhea, B. Bulbar conjunctival injection, C. Aortic root enlargement, or D. Bilateral cervical lymphadenopathy. Question number 6. Which of the following is the most accurate? Platelet count are within the reference by day 7. CA frequently involves proximal LED, then distal RCA. Lymphocyte predominance support diagnosis of KD. Or D. CT angiography is preferred over echocardiography as initial imaging modality. We'll move to question number 7. According to AHA 2017 guidelines, which of the following is recommended? Patients with complete or incomplete KD should be treated with IVIG. B. IVIG is contraindicated in patients with KD who present after 10th day of illness. C. Aspirin should be continued for 5 to 10 days after the patient is afebrile. Or D. ESR should be used to assess the response to IVIG. We'll move to the question number 8. IVIG resistance in KD is seen in how much percentage of children? A. Less than 5%, B. 10 to 20%, C. 30 to 35%, or D. 40 to 45%. We'll move to question number 9. Prompt initiation of IVIG reduces the incidence of CA in KD from 25% to how much? A. 15%, B. 10%, C. 5%, or D. 1%. We'll move to question number 10. Recurrent KD is seen in less than 1%, 3%, 6%, or 9%. We'll move to question number 11. Which of the following statements is true? The highest incidence of KD is in Taiwan. The incidence of CA in recurrent KD is low. The risk of concordance in identical twins with KD is 13%. And D. None of the above. We'll move to question number 12. Worldwide epidemiological data suggests the male to female ratio in KD is 1.5 is to 1, 2 is to 1, 3.1 is to 1, or 3.5 is to 1. We'll move to question number 13. The case fatality rate of KD in Japan is less than 1%, less than 0.1%, less than 0.01%, or less than 0.001%. Question number 14. All of the following genes have been implicated in KD except FCGR2A, Cas3, IPTKC, CD21. Question number 15. Which of the following statements with regard to pathology of KD is true? Systemic inflammation in all small size arteries occurs during the acute phase. Necrotizing arthritis starts by 3rd week of illness. Luminal myofibroblastic proliferation ends by 4th week of illness. Or intracytoplasmic inclusion bodies have been observed in bronchial epithelium. Next question. Clinical trials targeting the following cytokines have been conducted in KD except IL-1, anti-TNF alpha, IL-6, IL-8. Next question. Which of the following type of rash has not been reported in KD? Vesicular, morbilliform, scarlatiniform, or erythema multiforme? We'll move to question number 18. Which of the following statements is false in KD? Bilateral non-exudative conjunctival injection usually involves the limbus. Anterior uveitis is seen during the 1st week of fever. Strawberry tongue involves fungiform papillae. Or D, cervical lymphadenopathy is the least common of the principal features. We'll move to question number 19. All of the following are landmark trials in KD except RAISE, KAIKA, KidCare, or none of the above. We'll move to question number 20. Which was the first score formulated to describe likelihood of developing CA in KD? Harada score, Kobayashi score, Agami score, or Sano score? We'll move to question number 21. The cutoff of 36 hours for IVIG resistance was given by AHA 2017, Share 2019, Japanese Ministry of Health 2020, or none of the above. Japanese guidelines 2020 recommend initiation of IVIG within 5 days of illness, 7 days of illness, 9 days of illness, or 11 days of illness. We'll move to question number 23. All of the following are potential risk factors for developing CAA except male sex, IVIG resistance, age 2 to 5 years, or macrophage activation syndrome. We'll move to question number 24. Which of the following is true with regard to Kawasaki disease shock syndrome? KDSS was first defined in 1999. The reported prevalence of KDSS varies between 8 to 10%. KDSS constitutes systolic hypotension or clinical manifestations of poor perfusion, or KDSS often does not require treatment intensification. We'll move to question number 25. When will you give MMR vaccine in a 11-month-old boy treated for KD? 14 months, 17 months, 23 months, or 30 months? We'll move to question number 26. When was mucocutaneous lymph node syndrome described? 1962, 1964, 1965, or 1968? We'll move to question number 27. All of the following are scoring system for KD except Kobayashi, Sano, Dallaire, or Egami. Question number 28. All are components of Kobayashi scoring system except serum sodium more than 133, 4 days or fewer of illness at diagnosis, AST more than 100, or polymorphs more than 70%. Option A is serum sodium more than 133. Question number 29. Kaika trial is for which drug? Cyclosporin, infliximab, steroids, or anakinra? Question number 30. What are the high-risk criteria mentioned in the new updated guidelines for Kawasaki disease? 6 months of age, male gender, LED Z-score 2.5 on the baseline echo, or RCA Z-score 2.5 on baseline echo? Question number 31. All of the drugs were recommended for intensification therapy in new updated guidelines except methylprednisolone, infliximab, etanercept, or cyclosporin. Question number 32. Which is the commonest echo view used for coronary artery assessment? PSEX, plaques, apical, or subcostal? Next question. All of the features are mentioned in the diagnosis of incomplete KD in new updated guidelines except anemia for age, platelets 4 lakh, albumin 3 gram per deciliter, or LED RCZ score 2.5. We'll move to 34. According to new updated AHA guidelines, primary intensification is recommended in all except 6 months of age, male gender, baseline CA more than 2.5 Z score, or high risk category using SON risk score. We move to 35. In patients with initial CAF 5Z score, later regress to dilation, all of the following are recommended except assessment of stress test every 5 years. Consider coronary CA at 1 year as at baseline. May consider if there is inducible ischemia. Consider coronary CT at 1 year as baseline. May consider every 3 to 5 years, or echocardiography within 1 week to 6 weeks. We'll move to question number 36. Which diagnostic test confirms Kawasaki disease? Blood culture, echocardiogram. There is no definitive test or C-reactive protein. Next question. What percentage of untreated Kawasaki disease patients develop coronary artery dilation or aneurysms? 10%, 25%, 50%, or 70%? We'll move to question number 38. In which geographic region is the incidence of Kawasaki disease significantly higher? Europe, South America, Northeast Asia, or Africa? We'll move to next question. Which of the following is not a clinical feature of Kawasaki disease? Bilateral non-exudative conjunctival injection, unilateral lymphadenopathy, vesicular rash, or strawberry tongue? We move to question number 40. Which coronary artery segment are most frequently affected in Kawasaki disease? Distal right coronary artery, left main coronary artery, proximal left anterior descending artery and proximal right coronary artery, or posterior descending artery? We'll move to question number 41. Which laboratory finding is associated with IVIG resistance in Kawasaki disease? Low platelet count, elevated CRP, low hemoglobin levels, or decreased white blood cell count? Question number 42. What is the purpose of low dose aspirin in the management of Kawasaki disease? Antipyretic effect, anti-inflammatory effect, antiplatelet effect, or anticoagulant effect? Question number 43. What imaging modality is preferred for visualizing distal coronary artery aneurysms in Kawasaki disease? MRI, coronary CT angiography, transthoracic echocardiography, or stress test? We'll move to question number 44. How does the incidence of Kawasaki disease in Northeast Asian countries compare to the United States? It is similar, 10 to 30 times higher, 5 times higher, or 50% higher. Question number 45. What is the typical dose of IVIG administered to Kawasaki disease patients? 1 gram per kg over 4 hours, 2 gram per kg over 8 to 12 hours, 0.5 gram per kg over 6 hours, or 3 gram per kg over 24 hours? We'll move to question number 46. Which feature in MISC is more prominent compared to Kawasaki disease? Coronary artery abnormalities, gastrointestinal symptoms such as abdominal pain and vomiting, strawberry tongue, or non-exudative conjunctival injection? Move to question number 47. What percentage of infants under 6 months with Kawasaki disease have a baseline coronary artery Z score more than 2.5? 10%, 25%, 50%, or 75%? We'll move to question number 48. Which blood group is associated with a higher risk of hemolytic anemia from IVIG therapy? O, A, B, or AB? RH negative only, or all blood groups equally? We'll move to question number 49. What is the recommended post-IVIG waiting period for live vaccinations in Kawasaki disease patients? 3 months, 6 months, 9 months, or 11 months? We'll move to the last question. Which coronary artery is least commonly affected by Kawasaki disease? Proximal right coronary artery, proximal left anterior descending artery, posterior descending artery, or left main coronary artery? Thank you for your participation. Please hand over the answer sheets. Thank you.
Thank you, Puneet sir, for that wonderful set of 50 questions. I think anyone who thought that they knew this disease will rethink about that. And the answers for these questions will be mailed to all the delegates, and the winners will be announced tomorrow. Now let's move on to the first talk of today's scientific program.
Our next session for the day would be about the diagnosis of a typical case of Kawasaki disease by Dr. Prabal Barman sir, Assistant Professor, Guwahati Medical College. The session will be chaired by Dr. Chandramohan sir, Professor and Head, Department of Pediatrics, AIMS Patna, Dr. Jayant Prakashan sir, Professor and HOD, IGIMS.
So, first of all, I'll welcome Dr. Prabal Burman. Prabal is assistant professor in Guwahati Medical College, and he has got a scholarship for a young rheumatologist awarded by the Korean College of Rheumatology in the year 23-24, and young primary immunodeficiency investigator winner awarded at International Primary Immunodeficiencies Congress, Rotterdam, Netherlands. So, welcome to Patna. And you are the first taking the strike, so we invite you for your lecture.
Thank you, sir, for the kind introduction. I'd like to thank the organizers, especially Dr. Pratap, sir, for giving me this opportunity to be the opening batsman of today's session. So it's a very important topic, especially for our budding pediatricians. So I'll be discussing about the diagnosis of a typical case of Kawasaki disease. So just to start off, it's the medium vessel vasculitis with a predilection for the coronary arteries. It predominantly, but not always, affects the children less than 5 years of age. I'll be discussing about how to go about diagnosing this patient just from the clinical point of view. So let's go back to the man himself, Dr. Tomisaku Kawasaki. So from the year 1961 to 1966, he identified around 50 patients which have not been described previously. So these are some of his original pictures which he hand drew in his original paper published in 1967. He published it in an obscure journal called Arerugi, Japanese Journal of Allergy. Why he published in that journal is a topic entirely. So this is a busy slide. So these were his initial observations. So he noted that in almost all of his patients, there was fever for more than 38 degrees centigrade for more than 6 days. Almost a majority of these patients had bulbar conjunctival injection, edematous rash. In his first paper itself, he had mentioned that there were no vesicles. He also mentioned about the oral mucosa and the strawberry tongue changes. There was lymphadenopathy, there was edema, desquamation. So his initial observations forms the basis of the subsequent diagnostic guidelines that have been formulated over the next several decades. Just a few points, there were some differences. Some was the point of the recurrence, and at that time, since people were not aware of the devastating cardiac complications, so he had observed that in his cohort at least there were no sequelae. So this was the original case definition of Kawasaki disease, published in 1974 in Japan, in 1978 in the US. So it's 5 of the following 6 criteria: fever for more than 5 days and unresponsiveness to antibiotics, conjunctival injection, oromucosal changes, changes in the peripheral extremities, polymorphous rash, and lymphadenopathy, which I'll be discussing subsequently. Over the next several years, authors in Japan and in America have devised several updates and guidelines. So till November this year, we mostly followed the 2017 AHA guidelines and the 6th revision of the diagnostic guidelines from Japan. So it's a brief overview of the AHA 2017. So this is what it is mentioned: fever for at least 5 days and at least 4 of the following 5 criteria, that is the oromucosal changes, bilateral bulbar conjunctival injection without exudate. Each word is important, especially for the pediatricians, the budding pediatricians. The rash can be protein. There will be erythema and edema of the hands and feet in the acute phase and desquamation in the subacute phase, and cervical lymphadenopathy, usually unilateral. The only major change in the 2024 guidelines is the number of days. From 5, they have changed it to 4 days. So if you go to Japan, the 5th revision was in 2005. More or less, each of the points are similar. However, they do not consider fever to be a mandatory criteria. It's considered as one of the criteria for diagnosis of Kawasaki disease. So in 2020, in the revision, so they actually totally removed the specific duration of fever for diagnosis of Kawasaki disease. And in the paragraph on rash, they also included the BCG site reactivation. They also made a remark that although cervical lymphadenopathy is probably the least common amongst all the principal criteria, however, in older children, it is seen in nearly 90% of children, and they may actually have just lymphadenopathy and fever. So this is how the clinical phenotype in Kawasaki disease progresses over the next 4 to 6 weeks. So let me go into detail with each of the clinical features. So fever is the first clinical symptom. It's high grade, often more than 104 degrees Fahrenheit, persistent, minimally responsive to antipyretics. The median duration of fever has been reported to vary between 10 to 14 days, may last as high as up to 3 to 4 weeks. Infants, especially if they're less than 6 months, may only present with fever. So the picture on the left is one of the pictures in the first original manuscript. So as you can see, these patients will have bilateral bulbar conjunctival injection and the limbus would be spared. The cornea is not involved and there won't be any exudate. That is how you differentiate from other viral infections. It usually begins after the onset of fever and may last up to 2 weeks. So these are the various changes in the lips and the oral cavity. The peculiar finding is the vertical cracking of lips and erythema and fissuring. So the strawberry tongue is because of the prominent fungiform papilla. So these changes usually resolve by 1 to 2 weeks. So the rash is protean. Except for vesicular rash, almost all types of rash has been described in KD. So the rash usually appears by day 5 of illness, usually involves the trunk first, but the various parts of the body can be involved. And both in the acute as well as in the subacute phase, various authors have reported the commonest findings to be morbilliform, scarletiniform, and urticarial. Some unusual manifestations include psoriasiform rash, pustular rash, erythema multiforme-like eruptions, and a very characteristic findings called perineal and perineal rash and desquamation. If a child with fever has these findings, there's virtually no other differential diagnosis. So this is something that I want to highlight. BCG site reactivation. A child with fever and BCG site reactivation, there is no other differential diagnosis. So as far as the latest Japanese guidelines, they have actually included in as a part of the principal criteria. So the BCG side, the left ones are the ones in Indian children, and the one in the lower half is the ones which you see in Japan, because that's how they give the BCG vaccine. So when I was a resident at PGI, we had also observed some unusual rashes like heliotrope rash as well as malar rash, as you can see in these photos. So the peripheral changes, a peculiarity of these findings is that although they are very characteristic of KD, by the time the patient comes to you, these findings usually resolve. So it's very important to ask the mother whether you notice some swelling in the hands. So most mothers will identify this clinical symptom. So the peripheral changes in the subacute phases include desquamation that occurs after 10 days of start of fever. As you can see in the original pictures by Dr. Kawasaki, he also noted the same findings that happens after 10 days of the illness. It characteristically begins at the tips of the fingers, less commonly in the toes, just below the distal edge of the nails. I also want to highlight some of the nail changes that happens in Kawasaki disease. Although not part of the original criteria, is very important because it can give a clue to the diagnosis of KD. So the nail changes can be seen in the acute and in the convalescent phase. The common changes in the acute and subacute phase include the orange-brown chromonychia, which appears by 5 to 9 days after fever onset and usually begins to fade by 10 days. Leukonychia, which may occur independently of the orange-brown chromonychia. In the convalescent phase, various nail changes have been described, including Muir's lines, Bew's lines, pincer nail deformity, splinter hemorrhages, onychometasis, as well as nail pitting, which we published from PGI last year. As far as the lymph nodes are concerned, the anterior cervical lymph nodes are most commonly involved in the acute phase of the disease, usually unilateral, associated with parapharyngeal and retropharyngeal edema. And as I mentioned previously, in older children, this may be the only clinical manifestation. So there are a variety of other organ systems that can be involved in KD because of its multisystemic nature. Since we have discussions on the incomplete and atypical KD in the subsequent sessions, I'll not be going much into detail. So till date, I've been focusing mainly on the clinical aspect of Kawasaki disease, and even after 57 years of its first description, the diagnosis of KD remains clinical. So the investigations only have an ancillary additional help. So if you do a routine complete blood count, we might find anemia, thrombocytosis. If a patient has thrombocytopenia, especially less than 7 days of illness, that's a sign of macrophage activation syndrome, and which suggests intensification of therapy. And patients may also have neutrophilic leukocytosis. On biochemistry, there might be elevated transaminases, hyponatremia, and hypoalbuminemia. On routine urine microscopy, this is a very peculiar finding, what we find known as sterile pyuria, without any organism. So some, children, especially infants, may just have features of fever, and because their sterile pyuria remain, they continue to be treated with subsequent antibiotics, but later on turn out to actually have KD. On ultrasound abdomen, there might be gallbladder hydrops. The inflammatory parameters, that is ESR and CRP, will be elevated. There might be pleocytosis on CSF analysis, and the cardiac biomarker, that is N-terminal pro-B type BNP, might be elevated. So the cardiac imaging is the two-dimensional echo. However, I want to highlight that the initiation of treatment should not be delayed. So there will be subsequent topic on cardiac imaging, so I will not be going much into detail. I just want to highlight that the normal echo does not rule out the diagnosis. We have newer imagings on coronary angio and CMRI, which will be discussed today in the later sessions. So I don't think I have a lot of time. Just discuss a short case. So we have Miss A, a 4-month-old infant presenting with an acute febrile illness and diarrhea. So she was taken to a local private practitioner. Because of persistence of fever, she was given multiple antibiotics. On urine culture, she grew E. coli and there was some pyuria. However, she did not respond to even upgradation of high-grade antibiotics. Only on day 10, the physician thought of KD, and when he asked the parents, they actually give history of conjunctival injection, red and cracked lips, strawberry tongue. And these were the findings which this baby had. So why I want to highlight is, on day 10 you did diagnose, but a young baby not responding to fever, at the first go itself, a diagnosis of KD should have been considered. Why I'm stressing on this is, this particular child unfortunately developed giant aneurysms, and by the time she came to the doctor, we had already missed the bus. So these are some of the common pitfalls in diagnosis of KD, especially in infants who may present just with fever and irritability. Sometimes they might have pyuria. Lymphadenitis can be diagnosed as bacterial adenitis, etc., etc. So as physicians and pediatricians, our job is not to diagnose when they develop aneurysms. It's at this point of time. At this point of time, when we initiate treatment, only then can we improve the morbidities associated with KD. So in conclusion, despite thousands of reports published in literature, the original paper by Dr. Kawasaki remains the gold standard for the diagnosis of KD. Children with prolonged unexplained fever think of KD. The clinical symptoms often do not follow a set sequence, and as much as it is a science, the diagnosis of KD remains clinical, and it's an art. Thank you.
Thank you, Prabal. Excellent talk to set the tone for further proceedings. And we would love to have few, questions or comments. They are welcome. So it's, yes. Keep it very brief.
In situations such as macrophage activation, we are talking about high triglycerides. I don't think it's mentioned anywhere about triglycerides. There are some reports that at long-term follow-up, there might be hypertriglyceridemia, but the exact clinical implication is not yet known. As far as I know, I'm not sure about any reports on that. Maybe I can ask one of my seniors about importance of triglycerides in the acute phase of Kawasaki. Yes, that is the only situation. Otherwise, I'm not sure of any clinical significance.
how do we proceed in this?
Yeah, thank you. That's a very good question. So that is what we is known as something called spontaneous defervescence of Kawasaki disease. So we don't have exact guidelines how to go about it, but there are some reports from PGI Chandigarh. We have some long-term data, about 3.8 years on CTCA on patients who were not treated with IVIG, who defervesced spontaneously, and none of them had any cardiac anomalies, at least till now. So possibly it's benign, but if a patient has fever and has some features, we have to treat. But if a patient has become afebrile, there is no coronary artery aneurysms, and if the ESR, CRP, and other parameters have settled down, then perhaps we can just wait and watch.
Can I have one more question? Sidnath?
Inflammatory markers. If the initial TLC leukocyte counts were high with the high inflammatory markers, and at that point the fever was not there, they followed them up with the second week echo and 6th week echo. Few of them had aneurysms in the follow-up. So better if they had a leukocytosis with high inflammatory markers, though they are having a afebrile phase at the time that we see, we give the option of giving IVIG to the parents. So mostly we will explain them for the benefits of giving a IVIG rather than keeping them without the thing, because the risk is there up to 6th week.
I just want to add to that. I think that paper, they have actually defined it as indolent Kawasaki disease. There are two terms. One is spontaneous defervescence, the other is indolent. In the indolent form of Kawasaki disease, they may become afebrile, but they may continue to have persistence of inflammatory parameters. In that situation, perhaps the risk versus benefit ratio in IVIG should be explained to the parents.
I think thank you for the few comments. It was an excellent talk, and still as a pediatrician I find it very challenging to pick up or suspect KD when they come with fever and lymphadenitis. So that is for me the biggest challenge. I don't know when I'll be able to pick up, this is KD and nothing else. And the only thing helps me is CBC, which if I order and the patient gets it done, then the thrombocytosis helps. Thank you. Thank you.
Thank you.
So with this, we close the session.
Thank you, Prabal sir. Thank you, Chandramohan sir, Jain sir. I would like to request all three of you to come to the right side of the stage for a small felicitation, a memento from our side.
Now that we have learned about the diagnosis of a typical case of KD, our next session would be about the treatment of a typical case of Kawasaki disease. The speaker for which would be Dr. Archan Sil, Assistant Professor of Pediatrics, BMMC, New Delhi. The session will be chaired by Dr. Shrikant Bharti, Additional Professor, AIMS Patna, and Dr. Ghazi Ahmed, Professor and Head, Katihar Medical College.
So the next speaker is Dr. Archan Sil. He is Assistant Professor of Pediatrics and in charge Pediatric Clinical Immunology and Rheumatology Clinic from Bardhaman Medical College and Hospital. He has got a very good experience in this field and he has achieved so many things. Young Investigation Meeting 2023 award winner, and he is one of the future of the pediatrics and particularly the immunology and immunological diseases. You can proceed with your.
Thank you, sir, for the kind introduction. Good morning, one and all. At the onset, I would like to thank the organizers for giving me this opportunity to present in this forum. So after diagnosis of a typical case of KD, I am here to discuss about treatment of a typical case of KD. So there is no conflict of interest to disclose, and I have divided my topics in the following points. So as we all know, Kawasaki disease is common childhood vasculitis, and it was initially described in Japanese population in the early 1960s by Dr. Tomisaku Kawasaki, and coronary involvement is seen in 20 to 25% of the untreated cases, and KD has already replaced rheumatic heart disease as the commonest cause of acquired heart disease in US and Japan and in most part of the world. And this is the famous slide where Kawasaki disease easily beats all the other vasculitis, HSP and other vasculitis, and it is the commonest vasculitis in children, as we are seeing day in and day out, and it is the commonest cause of acquired heart disease also in children in many countries. Although in all the countries the data is not being maintained, there is no registry, but the incidence of Kawasaki disease tells all. So previously we used to follow the American Heart Association 2017 guideline. Recently we have the updated version on diagnosis and management of Kawasaki disease, that is AHA 2024 guideline, and there are a few subtle changes, few changes that I will discuss in the previous slides. So what is typical Kawasaki disease? So in AHA 2017, it was described as a classical case of Kawasaki disease, and the diagnostic criteria has already been elaborately discussed by my colleague Dr. Prabal. So here the fever duration was at least 5 days with any 4 of the following 5 criteria. I will not go into the details, but in AHA 2024 they have reduced the duration of fever from 5 days to 4 days with 4 of the 5 of principal clinical features at any point of time. So they may not necessarily be concurrent. Careful history taking is the catch. And the changes, I have made it bold. So polymorphous rash, here they have used this specific term. The bilateral conjunctival injection without exudate, oral changes, palmar and plantar erythema. In AHA 2017, they mentioned palmar and plantar erythema and edema. But here, subtle changes in language. Palmar and plantar erythema usually accompanied by swelling and resolves subsequently with periangular desquamation in the subacute phase. Cervical lymphadenopathy, in 2017 they mentioned unilateral, but here they also mentioned cluster of nodes with more than equal to 1.5 centimeter in diameter. So it is, there is a publication from PGI by Dr. Akib, that bunch of grapes. So here they have mentioned cluster of nodes. And the number 5, most important, illness not explained by known alternative disease process. So treatment of a typical KD is pretty simple. As we all know, intravenous immunoglobulin, a dose of 2 gram per kg over 8 to 12 hours. So they have reduced the duration also from previous AHA guideline. Previously it was mentioned as 12 to 14 hours. Now they have further reduced the duration 8 to 12 hours. Although they have mentioned that there may be dose related complications like Coombs positive hemolytic anemia. Aspirin, initially anti-inflammatory dose followed by antiplatelet dose, and this antiplatelet dose of aspirin should be continued till 6 to 8 weeks of age if there is no coronary artery involvement throughout the course of the disease. But there are controversies regarding the doses of aspirin that I will discuss in further slides. But the treatment of a typical case of KD is not that simple. There are several caveats, and there is IVIG resistance, there is initial intensification, and there are additional therapies. So this is the flow chart from AHA 2024 guideline, where this is the treatment that we can see. The initial case, first line treatment is IVIG 2 gram per kg and aspirin. But if there is persistence or recrudescence of fever 36 hours after completion of initial dose of IVIG, then it should be treated as IVIG resistance. And if there are certain high risk features specifically mentioned in the AHA guideline as infants of less than 6 months of age and coronary artery Z score at baseline more than 2.5, these are the 2 high risk features that has been described in the AHA guideline, then we should go for initial intensification. What are the agents that I will briefly touch upon because there are separate sessions on the so initial therapy. I will start with initial therapy in acute Kawasaki disease. This was the first published literature on IVIG in KD by Furusho et al. So there was a question in the quiz. So they here high dose intravenous gamma globulin for Kawasaki disease. Here high dose, that didn't mean 2 gram or 1 gram per kg. Here high dose means 400 milligram per kg for 4 consecutive days. And what they found is that coronary artery lesions had developed in 42% of the cases in the aspirin group as compared to only 15% of the cases in the IV gamma globulin group. IV gamma globulin means IV gamma globulin plus aspirin. So aspirin was the standard of care before that, before the IVIG came into the picture. Aspirin and prednisolone they used to use, but in 1979 there was an article which talked against prednisolone. So they stopped using prednisolone, aspirin was the care, then IV gamma globulin come into the picture. So they concluded that high dose IV gamma globulin reduces the frequency of coronary artery abnormalities in patients with Kawasaki disease. Then from Jane Burns and Jane Neuberger group, this study was conducted in 1986. Here also the conclusion was same. High dose intravenous gamma globulin is safe and effective in reducing the prevalence of coronary artery abnormalities when administered early in the course of Kawasaki disease. So now the question of dosing comes. Now they started to think that whether 400 milligram per kg for 4 consecutive days was sufficient. So they tried higher dose and then they compared 2 dosage regimes. So patients in this study from Baron et al., patients were randomly assigned to receive IVIG either at 400 milligram per kg daily for 4 days and 1 gram per kg as a single dose. And what they found that higher dose was more effective. 1 gram per kg dose is associated with a more rapid clinical improvement and a shorter hospital stay. And there are other studies that further increased the dose. This study was by Jane Neuberger group. This was a multicentric RCT, and the children were assigned to receive IV gamma globulin either as a single infusion 2 gram per kg over 10 hours or as daily infusions 400 milligram over 4 consecutive days. And they found that a single large dose of IV gamma globulin is more effective than the conventional regime of 4 consecutive doses of 400 milligram per kg daily. So this was a meta-analysis, Cochrane-Rifferty meta-analysis, where they included 59 RCTs and ultimately 16 of them met inclusion criteria. And the conclusion was that 2 gram per kg, that is the higher dose as compared to 400 milligram per kg for 4 consecutive days, shows statistically significant reduction in coronary artery aneurysm at 30 days. And duration of fever was there was significant reduction in the duration of fever also in the higher dose group. Now IVIG concentration. So IVIG is available in 5% and 10% concentration, and this is one of the latest publication where they compared these two concentration. However, they didn't find any significant difference in the coronary artery aneurysm occurrence in the 5% group versus 10% group. So as per AHA 2024 guideline, any child diagnosed with complete or incomplete KD should be treated with high dose IVIG, that is 2 gram per kg over 8 to 12 hours. There is no confusion in that as far as evidence is concerned. Within 10 days of illness, that is important. So, or as soon as possible. And there was discussion, there was questions regarding if fever subsides, then whether to treat or not. So patient presenting after 10th day of illness, if fever is persistent without any other explanation, then you should treat. Or if there is coronary artery abnormalities with ongoing systemic inflammation as evident by increased ESR or CRP, then also you should treat. Whether to treat if spontaneous defervations occurs. So guideline says that if there is persistent fever or raised inflammatory parameters with coronary artery involvement, you should treat. But if within 10 days there is spontaneous defervations, better to treat because of this study. They showed 293 patients with KD. One group were treated in spite of spontaneous defervations. One group was not treated in spite of spontaneous defervations. And the result was that at 1 month, the group which was treated by IVIG had only 5% coronary artery aneurysms as compared to the group which was not treated showed almost 20% coronary artery aneurysm in 20% of the cases. So there are different brands, indigenous brands and FDA approved brand. Yeah, indigenous brands will cost around 7,500 per 5 gram, and FDA approved brands, the cost is just double. Now coming to aspirin, aspirin is given during the acute phase of KD. Traditionally, the book teaching is that initially higher dose was recommended, 80 to 100 milligram per kg, till the fever and inflammatory parameter normalizes, then antiplatelet dose. Then they shifted to medium dose, that is 30 to 50 milligram per kg, initially in the acute phase anti-inflammatory dose, and then low dose. But this is controversial. This acute management with aspirin remains controversial. Now there are more and more articles are coming up, medium dose aspirin versus low dose aspirin in the acute phase of Kawasaki disease, because there are some risks, there are some adverse effects with aspirin, GI adverse effects, there is chance of bleeding, sensory neural hearing loss, and last but not the least, increased risk of Ray's syndrome. So there are studies, is high dose aspirin actually necessary in the acute phase of Kawasaki disease? But the results of these studies tell that it may not be beneficial in reducing the rate of coronary artery aneurysm, as well as the duration of fever, as well as the marker of inflammations. So this was a multicentric retrospective non-randomized cohort study which included 5 institutions. They compared low dose aspirin and high dose aspirin group, and the conclusion was that there was no difference in the risk of coronary artery abnormalities in the low dose group compared with the high dose aspirin group in the acute phase. So this is a meta-analysis which included 12,176 patients. The result was same. No significant difference was found in the incidence of coronary artery aneurysm between the high and low dose group. So the conclusion was that low dose aspirin plus IVIG might be as effective as high dose aspirin plus IVIG in the acute phase of Kawasaki disease. So this is the summary of studies. We are also conducting one study from our institute, medium dose versus low dose, and these are all retrospective cohort studies, and the result is same, that there is no significant difference in the incidence of coronary artery abnormalities between the low dose and high dose group. So the evidence is accumulating for low dose aspirin in the acute phase of KD. So what does AHA 2024 guideline says? There is increasing evidence that medium dose or high dose aspirin in the acute phase is likely not associated with improved coronary artery outcomes, and aspirin related adverse events are more without any definite benefit. So future data will tell us. Now, treatment of IVIG resistance, I will briefly touch upon. Even after treatment with IVIG, 20% of the patients will develop transient coronary artery abnormalities, 5% will develop persistent coronary artery abnormalities, and 1% may develop giant coronary artery aneurysm. So IVIG alone may not be sufficient. There is a definite need for additional therapy. And so these are the agents that will be elaborately discussed by Dr. Akib. And intensification mainly required for infants less than 6 months, because there are higher chance of coronary artery aneurysm in infants less than 6 months. This is a study by Dr. J.N. Burns group where they showed that the chance of coronary artery aneurysm in infant less than 6 months was 43.4% as compared to almost 20% in infants more than 6 months. So this was a study from PGI Chandigarh where they concluded that IVIG alone may not be enough to prevent coronary artery abnormalities in KD in young infants. So preemptive adjunctive therapy should be offered up front. Now additional therapies, statins, they are mainly used in coronary artery involvement, and due to their antioxidant and anti-inflammatory effect. So this is a large trial where they use statin in patients with coronary artery Z score more than 2.5, and they use statin for 6 weeks. They concluded that atorvastatin was safe and well tolerated with no adverse effects on brain cholesterol at 6 weeks period. Thromboprophylaxis in giant coronary aneurysm, there is flow stasis. So that's where the question of thromboprophylaxis come. And in the latest guideline of AHA, that is 2024, they did mention about the direct oral anticoagulants like edoxaban or epixaban in addition as an alternative to warfarin or low molecular heparin, because here the therapeutic monitoring is not that stringent. So this is the group where we should use the anticoagulant, the giant coronary artery aneurysm group. Now, to sum up the differences between AHA 2017 and AHA 2024 guideline as far as the treatment is concerned, IVIG infusion duration they shortened 8 to 12 hours. Previously it was mentioned at 12 to 14 hours. Aspirin doses, previously they mentioned that medium dose may be used instead of high dose, Now they have mentioned low dose may be used instead of high dose. So aspirin doses in acute phase of KD, gradually we are coming down. Infliximab dose, previously they have mentioned that 5 milligram per kg over 2 hours. Now they have mentioned 10 milligram per kg, the dose of KitKat trial over 2 hours. And direct oral anticoagulants, previously there was no mention. Now there is mention of direct oral anticoagulants in children with giant or large coronary artery aneurysm with Z score of more than 10.
Dr. Archan,
So,
please.
I'm almost at the end. So treatment of KD is challenging and intriguing, and thank you.
I think in the best interest of time, we will take one question, if at all, from the audience, maybe.
Yeah. So that was the study was conducted when there were spontaneous deformations within 10 days of illness. And in AHA guideline, even after 10 days, when the fever has subsided, then you'll have to consider either coronary artery abnormalities or ongoing elevated parameters of systemic inflammation.
Why I am asking is on a practical note.
Yes.
10th day a child comes to me, there is no fever from the 8th day onwards. So will you give IVIG or will you base your treatment on the echocardiogram and the inflammatory parameters?
So as per guideline, you should take into consideration echocardiogram, but if IVIG is easily available, better to give depending on that study where they found in spite of spontaneous deformations within 10 days, there was no fever, inflammatory parameters were normal, they treated in one group and in one group they didn't treat, and at 4 weeks of age, they found almost 40% of the cases they had coronary artery aneurysm as 20% as compared to 5% in the group which was not treated. So there are still controversies which have to be addressed by future studies, but better.
Thank you.
I'd just like to add my experience to it. We had two patients who were completely afebrile and they had low inflammatory markers presenting to us at 3 weeks of age. Gave history of having this kind of a typical fever with red eyes and all 3 weeks prior to it. But was not, they came to us at 3 weeks and then we admitted them, explained it to the parents and gave IVIG. There were coronary dilatations over there at 3 weeks, and then we, after giving the IVIG, we found significant decrease in the size of the coronaries within say 5 to 7 days.
So thank you. I think we close this session now. Thank you, Dr. Sel, for excellent presentation.
Thank you, Arshan sir. Thank you, Ghazi sir. Thank you, Shrikant sir. I'd like to request Patra sir to present our speakers and moderators with a memento.
For our next session, I would like to call Dr. Priyankar Pal, Professor, ICH Kolkata, and who is also the President of KD Society of India. The session will be chaired by Dr. Anil Kumar, Professor and Head, GMC Betia, Dr. B.K. Singh, Professor and MS, NMCH.
Good afternoon. Now we are going to start a very new session, a very important session. That is the Kawasaki disease, the Indian perspective. The speaker of this session is a very learned academician, Dr. Priyankar Pal, Professor in HOD Pediatrics, Unit Head Pediatrics Rheumatology, Affiliation Institute of Child Health, Kolkata. Major achievement is past President Pediatrics Rheumatology, Society of India, and President Indian Society of Kawasaki disease. So I request Dr. Sir, the speaker sir, to please start your deliberation.
Thank you, sir. So at the outset, I want to thank the organizers and especially Dr. Pratap Patro for organizing a wonderful conference. And I have been asked to speak the journey, the KD journey over the last 50 years or so in our subcontinent. So we have already heard that Kawasaki disease was first published in an original article in Japan, 1967, infantile acute febrile mucocutaneous lymph node syndrome, a clinical observation of 50 cases. So it took almost 10 years for, in those days without internet, so it took 10 years for that knowledge to percolate to our country. 1977, exactly after 10 years, we have our first publication by Dr. Arvind Taneja, mucocutaneous lymph node syndrome, which was published in Indian Pediatrics. And then again, there was a hiatus of another 10 years before we have two subsequent publications in 1988 and 1989. So I would just, over the next 5 years, 91 to 95, I would read an excerpt written by Dr. Kawasaki and Professor Surjit Singh in Kawasaki Disease in India, Lessons Learned over the last 20 years, published in Indian Pediatrics. So Dr. Kawasaki himself recalls an incident at the Asian Congress of Pediatrics, which was held in New Delhi in 1994. So there was a session on pediatric vasculitis, and he happened to be present over there, and he asked the chairperson how common in KD is in this country. And he mentions that I was told in no uncertain terms that this condition does not occur in India. So he was a little taken aback. He was unhappy because by that time a lot of countries were describing Kawasaki disease, and he thought that a country as populous as India should be seeing Kawasaki disease. My disappointment was fortunately short-lived, as events in the later half of the decade were to show later. So that is how he mentions. So 1996 to 2000, we have two series of Kawasaki disease, one published from Chandigarh and the other from Kochi, South. And I will mention again in Professor Singh's word that it was around this time that KD gradually started being discussed at various pediatric fora, including annual conferences of the Indian Academy of Pediatrics. And he recalls that several national conferences and meetings, heated debates used to take place. And the proponents of KD, as anyone who proposes something new in the scientific community, is looked upon as with disdain. There's a lot of criticism, and this also happened with KD. So the proponents of KD often had to face ridicule, criticism, and sarcasm in these meetings. To add to our woes, there was a dilemma of the incomplete KD, which entities appeared very nebulous at that time. So exactly the words of Professor Singh. We have seen that 1983, the first use of IVIG in KD, and in 1996, we have an article from Professor Singh, treatment with IVIG during acute stage, published in Indian Pediatrics. So my personal journey in KD started while I was doing my MD 97-98. So there was a clinical meeting organized by the BC Rai, which is a big pediatric hospital in Kolkata, and they had presented a patient with Kawasaki disease. So that was something new for us. We all gathered to look upon that patient, and this was the first publication from Kolkata itself, the millennial year 2000, when we had two publications from Kolkata. One was this patient that we had seen in BC Rai, and another was atypical Kawasaki disease from the Institute of Child Health, which is my present workplace. So atypical KD, Professor Apurva Ghosh and his colleagues published a child with palatal pulses. 2001 to 2005, so gradually KD was being recognized by the pediatric community. The landmark year in Kawasaki disease awareness was 2005, when Dr. Kawasaki himself came to Chandigarh, and interested people from different parts of India flocked to see him presenting his paper. So you had all the celebrities over there. You can see Professor Kato, Professor Kawasaki, Dr. Kawasaki himself, and of course Dr. Surjit Singh, the host of the event. And we can see Dr. Kawasaki said, "We came back convinced that KD in India was at last being given the importance that it deserved. It was gratifying to know that KD as a spectrum of disease was firmly established in the diagnostic armamentarium of pediatricians in India." And so this is Team Bengal. I just happened to get this picture a couple of days back. You can see Dr. Sabui, myself, and some other pediatricians, senior pediatricians actually, so in 2005. And you can see the number of KD publications in India from prior to 2005. So I put a line over there, and now till 2018, this graph says just multiple times. So our journey also started, and this was a baby fresh from the KD conference in 2007, a 23-day-old baby who presented with fever for 7 days, red lips, red eyes, and you can see the remarkable edema of the extremities. So I suggested, can it be KD? The child additionally had thrombocytopenia, and again, of course, I was a very junior faculty. I was rebuked, looked down upon, disdained, and a lot of criticism. But I happened, somehow or the other, managed to get the echocardiography done, and there were aneurysms. And this was published. This happens to be one of the earliest neonatal KDs described. So KD, we know, is a dermatologist's delight. And in somewhere around 2010, we chanced upon this finding in Kawasaki disease, the orange-brown chromonoikia. So orange coloration of the nails, you can see this nails changes. So we published initially a case series and subsequently another big case series in Rheumatology International. And presently there was a publication from different countries, ethnicities, Mexico, European countries, Japan. So it's a valid sign in Kawasaki disease in children from different ethnicities. So our quest for KD continued. We had the annual event, the pediatric cardiology CME, the pediatric rheumatology CME in Kolkata from 2008-2009, and we had named CMEs. So 2015, we had a day with Kawasaki disease, and you can see Professor Singh was present. In fact, Dr. Manful was also present at that time. So this was Dr. Sudha delivering the first oration of the West Bengal Pediatric Rheumatology Society in 2017. So moving ahead of IVIG, infliximab. So again, a paper from PGI, infliximab, the new kid on the block in Kawasaki disease, and you can see the indications as major indications as IVIG resistance as well as coronary artery aneurysms. 2016 they had published with their experience from 2007 to 2015. The Kawasaki disease foundation was laid down by Dr. Saji Philippe in 2010, and the first conference was in Perumala, Kerala. But the most important conference, I think, that time was in 2014 in PGI Chandigarh. So all the who's who of Professor Burns, Professor Newberger, all of them, they attended this conference. So it was a big conference. In 2019, so we had our society registered. So this was the birth of the Indian Society of Kawasaki Disease. We had the society registered in Kolkata. But of course, the idea started sometime in 2018 when the first conference of the society was again in Chandigarh. 2019, we had it in Kolkata, and this was a position paper on Kawasaki disease from the IAP, and now we are in 2020. So the times, they are changing. 2021, the onset of something pandemic, the pandemic years, and we encounter something which is known as a MISC, looking a little like KD. So this was our first patient in 2020. This child actually had a small little aneurysm. We published it, and there are some overlapping features, including a retropharyngeal phlegmon that has been described in Kawasaki disease. But subsequently, of course, we came to know that MISC and KD are two separate entities. This was a paper where we tried to look at the IL-6 CRP and NT-proBNP levels in Kawasaki disease and MISC, and this still happens to be one of the most downloaded articles from IGRD. Summit 2021-20, we had online conferences. And the quest for the risk, the IVIG resistance scoring continued, and we had a scoring system done, a proposed scoring system. It's based on the Kobayashi scoring system, but there are some changes with the sensitivity and specificity more than the original score, because we saw that the Japanese scoring systems were not really working in our population. And now we look at some of the important papers again. So this is Rakesh's paper, who published, I think this is the biggest cohort, KD children with MAS, and then Dr. Manful's innovative work on CT angiography described over the years. Looking at the epidemiology, you can see definitely the numbers have really increased. These are the papers from Chandigarh, and if you look at our own data from 2009, the numbers have more than doubled. But the ongoing challenges still remain that the literacy still remains suboptimal. Even in teaching hospitals and medical colleges, it's very disheartening to see that complete KDs are still missed. There is still a lot of cynicism amongst pediatricians, especially the senior colleagues, about the diagnosis. Well, and we have to face some devastating consequences. A lot of the country still do not report much of KD. So are we missing out on something? So these are some of the how to increase the awareness. So include in undergraduate teaching, and definitely in the infectious disease conferences, because the closest mimic is the infectious disease. So we should have a dedicated session in all infectious disease conferences so as that KDs are not missed. And long term, definitely one of the biggest challenges is the pediatric cardiologist. The KD graph, you can see the percentage of CA patients, the patients presenting with coronary artery aneurysms have also increased, and this is our data. Almost 37 to 40% of patients have aneurysms at onset, and one of the most important challenging things is the fate of this coronary artery aneurysms. So the 2024 AHA scientific paper says that we know that patients with small CAs, the small aneurysms, they have universal normalization of the CA internal diameter over follow-up and near zero risk of adverse cardiac events. We have done some study with infliximab where we have seen that the medium aneurysms regress, and even some of the giant aneurysms had also regressed over years. And this is just a paper which came out in October 2024, the long-term vascular and myocardial outcomes in selected KD patients. They had taken 5 patients with giant coronary aneurysms, and they have seen the patients over years, and they have shown that these patients illustrate that regression of giant aneurysms is possible with no detectable calcium, normal biomarkers of inflammation and fibrosis, and normal myocardial function. But yes, so still we have hope, and I think these posters give us some hope that yes, even giant aneurysms have some chances. So the most important, there was a question in quiz, what is the most important diagnostic marker? There are no diagnostic markers. It's you have to think of Kawasaki disease. It should be in your brain. Think of Kawasaki disease, and if in doubt, treat and call a friend maybe. We have lots of trained pediatric cardiologists available throughout the country. I think you can call your friend and ask for an opinion. Thank you.
Any questions?
Hello.
So thank you, Dr. Pal, for your excellent presentation. I must confess that being the professor of pediatrics, I was missing all cases of KDs 10 years back. Few of our students are also sitting in the audience, but we never met the diagnosis of KD 10 years back. But we are happy that every month we are making diagnosis of KDs now. This is because of the awareness. And as the initial person of our country thought that it is not a disease of India, but it is quite prevalent, and you truly said that if any fever is present, is there for more than 5 years with the features of KD, you are not finding the infective cause, you should always suspect and make the diagnosis of KDs. The outcome is better once you treat the case very early. And late treatment will lead to disastrous result. So thank you for this explaining the journey of KD in our country and making us aware about this disease prevalence in our country. So if any question or query is there from the audience, please.
Dr. Priyankar, this is not a question, this is just a rather appeal to the Indian Society of Kawasaki Disease, that the cost of immunoglobulin, IVIG, available in the market is something around, a person buys from a pharmacy, it's around 16,500. But the same thing the pharmacy is buying for around 9,000 or something. So there's a huge margin of around 6,000-7,000 per vial. And because of this, many of the patients are unable to do the private sector, those who do not have any insurance or the paying capacity. And many of these do not want to go to the government sector, even if it is available free of cost because of the whatever conditions. So as the office bearers of Kawasaki disease, maybe an appeal can be given to the government to cut down the cost, because it's abnormally high. They are buying for 9,000 and selling for 16,500. Why so much gap? And that at the cost, we do diagnose, but many patients run away because they are not able to pay it. And then they land up in the wrong hands, they say, kuch nahi, ghar chale jao. And maybe we don't know what happens to those patients who do not come back for follow-up. So something, a suggestion, maybe something can be done about it. Thank you. Sir, corporate hospitals don't allow. They will tell us, aap nikal jaiye.
So that's a different story altogether.
No,
yes,
sir.
Sagar,
Corporate
yes.
hospitals do not allow. Sorry.
There are some brands where they use maltose as a preservative or a stabilizer. So those are giving more side effects. That's our observation. They are giving more side effects like high fever, rash, aseptic meningitis. So, but the other ones who are not using maltose, they are not having those side effects, and they're a bit more expensive. So, sir, any views for that?
So thank you for the because of conclude the session, and we invite this organizer to go ahead. So thank you very much.
Thank you, Anil Kumar sir, BK Singh sir, and Priyankar Pal sir. Requesting Patra sir to just present the mementos.
Now, as we have known the journey of the disease, our next session would be about the epidemiology of KD in India. It would be presented by Dr. Anu Maheshwari, Professor, LHMC. The session will be chaired by Dr. Neeta Kevlani, Senior Consultant, Maternal and Child Healthcare Hospital, Patna, and Dr. Sagar Bhattad, Consultant Rheumatologist and Immunologist, Aster CMI, Bangalore.
Good afternoon, one and all. For the next session on epidemiology of KD, we have Dr. Anu Maheshwari Gulati. As you can see, she is the professor of pediatrics at LHMC New Delhi. She is ULAR certified in pediatric rheumatology and has over 50 publications in various reputed journals. Over to Dr. Gulati.
Thank you, Dr. Sagar, for the kind introduction. First of all, I'd like to thank the organizers for giving me this opportunity to present my talk. So I think Dr. Priyankar sir has beautifully outlined the struggle of the senior pediatricians, and we are thankful here that maybe sometimes, 50-60% of the time, maybe our colleagues do listen to us and we are not missing that many Kawasaki's, but still a lot of work needs to be done. And in India, KD is mainly underdiagnosed because of overlapping symptoms with many tropical infections, especially measles, dengue, scrub, and other viral infections. And more importantly, they may not come to you. They may come to different specialities. You go to the ICU, you go to the emergencies, you'll find these children, in one corner. They might present with aseptic meningitis, acute abdomen, maybe gangrene. So you'll have different kind of presentations in these children. So it's kind of difficult to compile a registry if you're not aware of the disease. And the diagnosis, most importantly, is clinical. So somebody can agree, okay, there's a rash, there's not a rash. So a lot of times, a lot of conflicts, a lot of arguments regarding the disease. That does happen, as Priyankar sir has rightly told. And more importantly, I'd like to say here is that all the clinical features, I think in the session one very senior sir said that it's very difficult to make a diagnosis when you have lymph node and fever. So where do you go from there? Are you talking about maybe tuberculosis, the other viral infections? So here the history is very important. You have to take the history of any of the symptoms, because the symptoms may be fleeting. They may occur for a very short duration of time. And 2017 guidelines very much said that even if the history of eye redness is there, you have to take it as a criteria. You cannot count one feature, two features. So even if the history is there, you have to take it. You have to remember most of the features are fleeting and may disappear by the time the patient comes to you. So a very strong history-taking skills are required to make a diagnosis in these children. Okay, so it's a disease. I would not go into demographic profile. I think all of us have heard from the previous speakers. And so why is Kawasaki disease uncommon in older children and adults? Is it really less, or is the manifestations different, or are we missing them altogether? Because in the last CME that we had, I had included a talk on KD in adults, and believe me, the talk was very enlightening. And even the medicine people, they told me, why are you keeping a talk on adult KD? But a lot of them were very happy that we had the talk, and a lot of maybe awareness occurred because of that. It might be because KD is basically thought to be of infectious origin, and most infections occur in the first 5 years of age group, and later on you develop, maybe your immune system matures, so you're not getting the exact features that you're seeing. So most of these adults present with adenopathy and arthralgia. They're not presenting with the classical features. So global epidemiology, as we all know, Japan leads in the number of cases, about 12,000 cases a year. And updated, the national incidence is around 322 per 100,000. In the Far East countries like Japan, Korea, the rates are more than 50. While in United States and Europe, it's around 4 to 25. So there's a lot of variability. And this variability cannot only be explained by lack of awareness. So there might be something genetic or some infectious etiology. And in KD in India, it was difficult for me to, compile this, but thanks to Dr. Surjit Singh sir's team, we have many articles, including articles from the South and Bengal. So I was able to compile a little epidemiology profile. So like sir already said that only 3 published case reports before 1997. We did a PubMed search of KD in India, and there were 161 results. And sadly enough, only 8 of them were before 2000. So in 2000, I think our KD Society and the Chandigarh group, the South group, and the Bengal group have been doing a lot of work, creating a lot of awareness. So I guess the presentations are increasing, and so probably awareness is improving. So epidemiological results that we'll get now would be more accurate. So first reports were from Trivandrum and Chandigarh, and then KD has been recognized in all parts of the country. And I think COVID did a lot of service to pediatric rheumatologists, that it sensitized the general pediatricians to the occurrence of KD. Like they still label it as MISC, but there was still an awareness that was created during COVID for Kawasaki disease. So many senior pediatricians like Dr. Priyankar Par already said that they said that KD doesn't exist. But there has been some increased incidence in 1990s with the air pollution increasing, the industrialization. Whether this is a causation or an association, we really can't say. And Kerala, which is one of the most developed states of India, has also reported a large number of KDs. Many physicians and pediatricians are also of the view that KD has increased with the reduction in infectious diseases like diarrhea and better vaccination coverage. Again, like most of my talk would be talking about work from Chandigarh, because they are the leading publishers in this category. So hospital group study, our own chairperson, Dr. Sagar's paper, we had the incidence was around 0.51% in less than 15 years of age group, with increased. So here I'm not talking about the real numbers. You don't need to remember the numbers, but you do need to remember the incidence is rising. Whether this rise is because of actual rise or because of awareness, that remains to be seen. But yes, there seems to be an undercurrent of increased incidence in the coming years. And the papers are from PGI Chandigarh, and some of them are from South as well. So this was another one, which 2015, this has been published in Lancet in September with Dr. Surjit sir's team. And the incidence that they have found is that there's a 53%, about 50% rise from the last paper that was published by our chairperson. So the median age, we all know it's around 2 years. Why we don't have a younger age group probably is because we miss a lot of KDs in the infant age group, because it's very, very difficult to diagnose and sometimes difficult to convince people that this is not sepsis, this is not fungal sepsis or something else. So comparison between, I did some clinical profile. I wanted to see whether children above and below 5 years. So what I found was that desquamation and musculoskeletal symptoms, especially arthralgia and arthritis, were more common in older kids. And then again, I would like to say that missed KD, like pediatric cardiologists are very passionate about, primary augmentation and coronary artery, salvaging the coronary artery abnormalities. So adult patients, adult cardiologists might be able to shed more light. When they do a coronary angio in patients who come with acute coronary syndrome, maybe they can compile a data regarding atypical findings, something that is not matching with the atherosclerotic or diabetic. So if they are able to provide some data to us, these many adults had probably a missed KD diagnosis, so we can work ourselves back, and with the AI and the statistical method, we'll be able to get a more accurate epidemiological rates. So seasonality, very interestingly, I think we had a wonderful debate in one of the KD conferences. Is KD an infection or not an infection? So infections are seasonal, so is KD. And interestingly enough, there's some papers from Japan that say that IVIG responsiveness also has a seasonality to it. So risk factors of KD, coronary artery aneurysms. This was again a group from Trivandrum, I think South, and they said that the older children, pyuria, and delayed diagnosis. It makes sense. If you delay the diagnosis, you'll have more incidences of coronary artery problems, so you need to watch out for that. Mortality is basically either in the acute phase, if you don't recognize the myocarditis, mass, and the other complications, then the child would die. And of course, later on, the death may be because of the coronary artery abnormality. Case fatality rate in Japan is very less, 0.015, and hospital mortality in US is 10 times more, that is 0.17. And peak mortality is usually in the second or the third week. And many cases of MIs in adults, by a lot of work by adult cardiologists, say that it might be a missed Kawasaki disease. So we are still missing, we have not reached where we want to be. Oh, there's been some formatting error from my laptop here. So mortality of KD, again, nothing said to be done. Well, basically all papers are from PGI Chandigarh, again from Surjit Singh sir's group. So mortality data is around 0.87 in this cohort of 460 patients. This is data from 1994 to 2017. And they said that the majority of the mortality was because of late referrals and late recognition of the disease. So Indian scenario, we can say that coronary arteries and macrophage activation syndrome can be the leading cause of death. Data from the Chandigarh reported a mass incidence of 1.3%, but this was pre-COVID. We also did a study where we made a AI modeling of prediction of mass using clinical features, that is fever, albumin levels, SGPT, and we came up with a model to predict mass in children with KD even before the 5 days the illness is complete. So this was from ours, this thing. So we had this study during COVID, and it was difficult for us to tease out the KD from the MISC. So what we did was, we had the children who basically conformed to the diagnosis of KD, and the serology of COVID was negative. So we took those children and we took this opportunity to study any risk factors, or we can make some model. So we came up with an AI model. And recurrent KD is very interesting. The recurrence rate of KD is, in Japan it's the highest, and US, the Canada and the Asia and Pacific, it's still higher. And the incidence is higher in the first 2 years of life. And in India, the recurrent KD Indian experience, again work from PGI Chandigarh, overall rate was less than 1%. And incomplete KD was more common during a recurrence. And it would be interesting to see whether these children who are having recurrent KD, are they actually having recurrent KD, or they have some underlying immune deficiency or disorders of basically IEI, any underlying IEI that is predisposing them to it. Because we had a child with recurrent KD, which we are presenting as a poster as well, that turned out to be an auto-inflammatory syndrome. So very interesting to see what these recurrent KDs are, whether there's any underlying genetic. So what is the way forward? I think Priyanka sir already said that we need to increase awareness. So how do we increase awareness? Teach our undergrads, teach our postgrads, keep teaching, keep having conferences. And then in the era of AI and era of telemedicine, maybe we can have a network where rural doctors can contact us. And but of course, diagnosis, it doesn't end at the diagnosis. Then the therapy. They're saying IVIG is very, very expensive, and I agree. Like in my hospital, if you get, sometimes when we run out of it, then it's very expensive. Otherwise, the government supply is there. But I would request our seniors, senior members of this society to, can we give infliximab as first line? Because infliximab is cheaper. So that also remains to be answered by seniors. And then government support. We need to subsidize these drugs, especially infliximab, especially IVIG, and of course establish a national KD registry. This is a collage of my patients that we've treated over the years. Thank you very much. I would like to thank, just 1 minute, I'd like to thank Dr. Deonath Mahato and all my PGs and Dr. Janvi Srivastav for helping me run our clinic very successfully. Thank you so much.
Everybody can hear me now? Okay. So thank you, Dr. Anu, for such an enlightening talk. I completely agree that history taking is really important in Kawasaki disease because, yes, we have the tick boxes, this should be present, but then they can present late and all might be absent. And one thing personally that I have learned from my seniors is if you see a child with high fever and they are not sick, but miserable, irritable. Think Kawasaki. And I think so far, I kind of used to take pictures, with parents' permission, that this is a miserable, febrile child with IVIG and, aspirin, and then after pictures as well. So something that I kind of personally follow. So thank you very much. Any questions? You want to add something?
I think it's been very well presented. I think the only thing we can highlight is definitely in northern India and in southern India there is awareness. We need to do something about central India and maybe organize more meetings in central India is what I would propose, as was highlighted by Dr. Priyankar as well. Because even in southern India, especially thanks to COVID in some sense, the awareness definitely has gone up and more pediatricians are more comfortable even in giving IVIG post-COVID because it was used so rampantly during COVID days. That would be my take. Thank you.
Thank you for your wonderful insights, ma'am. Next, we'll have the inaugural function. For the lighting of lamp, I would like to request the following dignitaries to come on the stage. Professor Dr. Mamoru Ayusawa, Faculty of Health and Medical Sciences, Kanagawa Institute of Technology, Japan. Ms. Subura Kawasaki, daughter of Dr. Tomisaku Kawasaki. Dr. Surjit Singh, Professor and Head, Department of Pediatrics, PGI Chandigarh. Dr. Priyankar Pal, Professor, ICH Kolkata. Dr. Saji Philip, Pediatric Cardiologist, Kochi. Dr. Ruchi Sinha, Dean Academics, AIMS Patna. Dr. Tapas Sabui, Professor, Kolkata. Dr. Chandramohan Kumar, Professor and Head, Department of Pediatrics, AIMS Patna. Dr. Pratap Patra Sir, Additional Professor, Department of Pediatrics, AIMS Patna. I'd like to take this pride and honor that I welcome all of you guests and delegates to the 7th National Conference of the Indian Society of Kawasaki Disease on behalf of the Department of Pediatrics, AIMS Patna. Today, we gather here as a community of healthcare professionals, researchers, policymakers, and caregivers united by a shared commitment to understanding, addressing, and ultimately improving the lives of children affected by Kawasaki disease. Kawasaki disease, first described just over 50 years ago by Dr. Tomisaku Kawasaki, has now found its place as the most common cause of acquired heart disease in the pediatric age group, and its timely diagnosis and treatment are critical to preventing life-threatening complications. As we embark on this journey over the next 2 days, unraveling the mysteries of Kawasaki disease from diagnosis to recovery, highlighting the importance of the disease, I would like to request the dignitaries to join us on the stage. Professor Dr. Mamoru Ayusawa, Ms. Subura Kawasaki, Dr. Ruchi Sinha, Dr. Priyankar Pal, Dr. Surjit Singh, Dr. Shaji Philip, Dr. Tapas Sabui, Dr. Chandramohan Kumar, Dr. Pratap Patra. Requesting Professor Dr. Mamoru Ayasawa to join us on the stage. I would like to request all the dignitaries to proceed with the lighting of the lamp. Thank you to all the dignitaries. To set the tone for our conference today, I would like to request Dr. Chandramohan sir, Professor and Head, Department of Pediatrics, AIMS Patna, to deliver the welcome speech.
Respected Dr. Mamoru Ayasawa, respected Ms. Subura Kawasaki, respected Dean AIMS Patna, respected Professor Surjit Singh sir, Professor Priyankar Pal sir, Professor Tapas Subey sir, and Dr. Saji Philip sir, and my friend and colleague, Dr. Pratap Patra. Distinguished speakers, delegates, friends from media, ladies and gentlemen. This is my honor and privilege to welcome you all for the National Conference of Kawasaki Disease. That's the 7th National Conference of the Indian Society of Kawasaki Disease, and the first time it's being organized in any of the AIIMS and in Patna. So all are welcome. I extend a warm welcome for each and every one of you. As we all know, Kawasaki disease is a complex and multifaceted condition, and that affects children worldwide. As healthcare professionals, researchers, and advocates, we recognize the importance of staying updated on the latest updates in diagnosis, treatment, and management of the Kawasaki disease. And this conference brings together the experts across the globe and the country to share their knowledge, experience, and research findings. Over the next 2 days, we will engage in thought-provoking discussions, debates, and we will also have networking opportunities that will enrich our understanding about the Kawasaki disease. This conference features an impressive lineup of speakers. Earlier 3 speakers we have heard, they were all fantastic, and that we have experts in the field of pediatric cardiology, pediatric rheumatology, and infectious diseases. So we will also have poster presentations and panel discussions, and that will provide a platform for sharing the best practices, challenges, and innovative solutions. I would like to express my sincere gratitude to all our speakers, session chairpersons, and the presenters for their contribution to this program. I also appreciate the support of the sponsors, exhibitors, and the partners. As we gather here, let's reaffirm our commitment to improving the lives of children affected by Kawasaki disease, and we should do our best for the prevention of Kawasaki disease complications. Let us share our knowledge, expertise, and experiences to advance our understanding of this complex condition. Before I conclude, I would like to invite all of you to explore and visit Patna, which is famous for the river Ganges. We have a Gurudwara where the Guru Gobind Singh was born, as well as we have a nearby places, Bodh Gaya, Rajgir. Bodh Gaya is a place where Gautam Buddha had his enlightenment, and we are the oldest cultural civilization that is surviving. So I will invite all of you to enjoy Patna. Thank you.
Thank you, sir. Next, I would like to request Dr. Priyankar Pal, President of KD Society of India, to share his thoughts.
So, big thanks to all the delegates and the faculties who are present over here, who are sharing our thoughts and our journey in raising Kawasaki disease awareness throughout the country. So, so the Indian Society of Kawasaki Disease last year in Chandigarh, we decided to have a module, sort of a easy module, a practical module that will address the issues of Kawasaki disease. And over the last 1 year, following a lot of online discussions, heated arguments, so we have come up with this module. So the clinical features were done by Dr. Bhaskar Shenoy. Incomplete or atypical KD was done by Dr. Pratap Kumar Patro. Role of lab investigations and imaging by Dr. Ankul Jindal from PGI. And the treatment was done by myself. So we will share this online module. We will upload in the Kawasaki disease website. So there are a deck of slides actually. So if it's for a ready reference, or if you want to present, if you want to conduct a CME, I think the slides will be available to you. Thank you.
Thank you, sir. Now I'd like to request Dr. Ruchi Sinha, Dean Academics, AIIMS Patna, to address the gathering.
Warm good afternoon to all present here, especially Dr. Mamoru Ayusawa, Madam Subura Kawasaki, Dr. Priyankar Pal, Dr. Surjit Singh, Dr. Saji Philip, and are from AIMS Patna, the HOD of Pediatrics, Dr. CM Kumar, and our in-house pediatric rheumatologist at AIMS Patna, Dr. Patra, and all the dignitaries assembled here on the dais and off the dais. A very warm welcome to the 7th National Conference for Kawasaki Disease, and I feel immensely proud that AIMS Patna is the first among all the AIMS, including AIMS New Delhi, who is hosting and organizing this conference here. And a lot of other firsts also. I've been told that this is the first time that a 2-day conference is being conducted on this topic. And I was fortunate enough to listen to a few of the talks in the morning, and Kawasaki diagnosis and the management of this disease has come a long way forward from where in 1994 it was point blank said that this disease does not exist in India, and now so many of them have been diagnosed. So this has come up as an entity on its own, it has come into being on its own here. And Dr. Patra told me that we too have quite a few numbers of KD referred and as well as primarily diagnosed in our institute. So what I feel is what the mind does not know, the eyes don't pick it up. And I wish that more and more conferences like these will be organized in the future also, and so that this disease does not remain unrecognized, and so that the children, because most of these are small children less than 5 years of age, and it has undiagnosed, unmanaged cases are associated with high mortality. So wishing everyone here a happy journey of knowledge and enlightenment. As Dr. CM Kumar said, this is the land of enlightenment. And I hope the organizers take you around in and around Patna, and wishing a successful 2-day journey of learning to everybody here. Thank you so much.
Thank you, ma'am. Now we'll proceed with the felicitation of our dignitaries. I would like to request Dr. Surjit Singh to felicitate Professor Dr. Mamoru Ayusawa. Thank you, sir. Now I'd like to request Dr. Priyankar Pal to felicitate Ms. Suboru Kawasaki. Thank you, sir. Now I'd like to request Dr. Pratap Patra to felicitate Dr. Surjit Singh. Thank you, sir. Now I'd like to request Dr. Chandramohan sir to felicitate Dr. Priyankar Pal sir. Now I'd like to request Dr. Pratap Patra sir to felicitate Dr. Tapas Saboi. Thank you, sir. Now I'd like to request Dr. Chandramohan to felicitate Dr. Saji Philip. Now I'd like to request Dr. Pratap Patra to felicitate Dr. Ruchi Sinha. Now I'd like to request Dr. Chandramohan sir to felicitate Dr. Pratap Patra sir. Now I'd like to request Dr. Pratap Patra sir to felicitate Dr. Chandramohan sir. Thank you to all the dignitaries. Now I request Dr. Pratap Patra sir to deliver the vote of thanks.
Good afternoon, everyone. On behalf of the organizing committee and the Indian Society of Kawasaki Disease, it is my privilege to deliver the vote of thanks at the inauguration of the 7th National Conference of the Indian Society of Kawasaki Disease. First and foremost, I extend my heartfelt gratitude to Professor Mamoru Ayusawa and Subura Kawasaki for their gracious presence at this conference. Ma'am and sir, we are deeply honored to have you with us, sharing your invaluable insights and inspiring us to elevate our efforts to combating this condition. I also take this opportunity to express my sincere thanks to my teacher, Professor Sujit Singh. And so it was 2002. Sir used to say in round, no disease is more fascinating than Kawasaki disease. And Sir has spent his entire life on treatment and improvement of care of patients with Kawasaki disease. Sir, your leadership and commitment to the advancing the care of children with Kawasaki disease and research have been instrumental in fostering a robust academic environment that supports such important discussions. A special note of appreciation goes to Priyankar Pal sir, the President of the Indian Society of Kawasaki Disease. Sir, under your vision and guidance, the Society has made a remarkable stride in creating awareness, promoting research, and improving clinical care for children with Kawasaki disease across the country. A special thanks to Dr. Saji Phillips sir, Dr. Tapas Sabu sir for gracing us on this occasion. I would also like to acknowledge and thank our Dean Academics whose support and encouragement have been pivotal in organizing this prestigious event. I also extend my thanks to Dr. Chandramohan Kumar sir for his constant guidance and support for this conference. Lastly, I extend my gratitude to the organizing team, the participants, distinguished faculties from all over the countries, and making this event possible. Once again, thank you all for gracing this occasion. Let us look forward to a fruitful and enriching conference ahead. Thank you. Jai Hind.
Thank you, sir. Now I'd like to request all the delegates to move to the hall outside where the posters have been displayed and look at the posters. Following which, we'll break for a lunch of around 45 minutes. I'd like to request everyone to gather back in the hall by 2 p.m. for the further sessions. Thank you.
Hello, chick, chick. नहीं देख हेलो छोड़ रहा है
transfer this to the pen drive?
एक मिनट सर नहीं हुआ that is not support.
Yeah, all of this team.
Not
Yeah,
support,
all support. Maybe Harvard.
Yeah, like
Harvard using this ratio.
yeah
Like this.
I changed I changed
Oh. Or I already have
requesting all the delegates to be seated so that we can start with our events post-lunch. To discuss regarding the recent updates on the pathogenesis of Kawasaki disease, we have Dr. Manpreet Dhaliwal, Assistant Professor, Pediatric Rheumatologist and Immunologist from PGI Chandigarh. Welcome, ma'am. And this session will be chaired by Dr. Manoj Kumar sir, Associate Professor at AIIMS Patna, and Dr. Rashmi Agarwal ma'am, Associate Professor at NMCH.
So, a very warm good afternoon to all. I welcome you all after a sumptuous lunch, and let us proceed with the sessions for today, for which we have a very interesting topic: pathogenesis, etiopathogenesis of KD is an enigma. We all know that there is a lot of shift. Thinking of the age of the child, that is, it happens more in less than 5 years. We are tempted to move it on to an infectious etiology, Streptococcus, Staphylococcus, looking at the pattern of lymphadenitis coupled with fever and the other things. But yes, when we look for evidence, we do not really find evidence or isolates of virus or bacterial origin. So with those things and an immunological background also, I welcome Dr. Manpreet Dhaliwal, who's a PhD, and she's from PGI Chandigarh. She has a very, very illustrious character, and we are very, very glad to have you here, Dr. Manpreet.
Thank you.
You would be enlightening us on this topic, and you have done your MSc and BSc from PU University, and after that you have been serving and working at PGI Chandigarh. Dr. Sujit Singh and our very own Dr. Professor Rawat, they are instrumental in you being here. So welcome, and you may proceed.
Good afternoon, everyone. Thank you, ma'am, for the really kind words, and the organizers for inviting me to this really interesting conference. So today I've been tasked to update on the pathogenesis of Kawasaki disease. So I'll simply start with the first slide, in which this process is familiar to most of you. So I'll briefly touch upon the three main phases in which a coronary artery aneurysm can occur. So since this is the main reason why we are studying KD, I just thought it's appropriate to spend a couple of minutes on this. So this can be divided into three phases. The first phase is the necrotizing arthritis, in which you can have which can either lead to a thrombus formation, or it can even lead to rupture and subsequently MI. In the second phase, which can start from 2 weeks onwards and can last up to months, we have the subacute chronic arthritis phase. In this phase, you can have an infiltration of the lymphocytes, eosinophils, in the lumen of your arteries, and can again lead to progressive ischemia or MI. The most interesting phase is the luminal myofibroblastic proliferation phase. In this phase, the cells which have infiltrated can actually lead up to the adventitia and can cause damage. So with this brief reason of why we studied KD, I'll move on to the proposed events in the evolution of vasculitis. So again, as we know, in a genetically predisposed host, an inflammatory stimulus can lead to the activated monocytes and the platelets to reach the site of the lumen of the endothelium. In this case, as you can see, that these monocytes and the platelets have been can go and bind to the ICAM and the VGF1. Now this VGF can increase the vessel permeability, which in turn leads to the accumulation of more of these monocytes and the neutrophils into the lumen. So the important point to note here is the role of the neutrophils. I'll come to this in my subsequent slides. So once this process is started, then the platelets can go and bind to the endothelium. After this, there can be release of these pro-inflammatory mediators like the IL-8, IL-1 and IL-6, which can lead to the infiltration of the more neutrophils, breakdown of the structure of the artery, and this can happen through the different enzymes such as the neutrophil elastase, MMP9, and the TNF-alpha. So this process is mediated by the pro-inflammatory cytokines. So since this is what we do know, let's come to what is new in KD. So this is a recent study from our paper, so where we've tried to highlight that Kawasaki disease is not, since we do not know the etiology, other factors can contribute to the pathogenesis. There can be multiple factors. So an important would be, which is really coming into picture now, is the gut microbiome. So in a study funded by DBT to Dr. Rakesh Pillania, we have tried to look at the role of the gut microbiota on the Th17 and the Treg cell. So what we do find is that there is an increase in these cells, but how it correlates with the gut microbiota, that analysis is still in process. So this is one interesting finding and an update on the pathogenesis of KD. Other than this, I'll briefly touch upon the genetics of KD. It does show a skewed epidemiology, and with an increase in the people of the Japanese origin. So this points towards, is a strong pointer toward a genetic problem being happening in the background, which leads to this disease process. So as I highlighted earlier also, in a genetically predisposed individual, the commonly accepted paradigm is an infectious trigger can lead to the activation of the immune system. So the major players here are the neutrophils, the monocytes, the pro-inflammatory milieu generated by the IL-6, 8 and the TNF-alpha, and this can also then again kick up the adaptive immune responses such as these cells. So to understand what truly happens in KD, we used a bioinformatic approach to identify the differentially expressed genes. This was recently published in Frontiers in Genetics. So this study was all done in silico, and to our, not really to our surprise, but to what we were suspecting, we saw this cluster of genes which are actually majorly expressed in the neutrophils, along with IL-1 beta. So these are the genes which will again and again, show up in this presentation. And 5 of these genes were found to be involved in neutrophil degranulation. From this study, we then decided to again verify this data set in the lab. So this work was done by our DM candidate, Dr. Abarna. So she shorted out these genes from our big data set and performed the real-time assay experiments to look at the genes which would be expressed in a KD patient versus the healthy control. Again, we found the upregulation of IL-1 beta and some neutrophil implicated genes. So the interesting thing about her study is this part. So she also recruited some IVIG patients who were on IVIG treatment, and post-therapy she saw that these genes were restored. So IVIG basically, indirectly, it's telling us that IVIG can help to reverse the damage by regulating the gene expression of the neutrophils. From this study, we realized that these neutrophils are an important cell type which are not to be ignored. So to this end, we have these two candidates, Dr. Reva and Dr. Ayush. They are the DM. One is the DM candidate, another is the MD candidate from our unit. And so Dr. Reva looked at the role played by the neutrophil subset called the low-density neutrophils. This is a very interesting and a controversial topic because many people do not really believe in the existence of these cells, but more and more data is coming up that these cells can have an important role to play in any inflammatory process. So she could find that in patients with KD, the number of these cells was higher than those in healthy controls, although due to the short study period, the statistical significance was not achieved. So again, Dr. Ayush decided to look at the different subsets of the neutrophils. So in this case, mainly the immature, mature, and the aged neutrophils. So to our surprise, we found that there is an increase in the mature and the aged neutrophils in the KD patients as compared to healthy controls and febrile controls. So we found very significantly increased numbers of these cells in our patient cohort. And this was again corroborated by a recent study which has just been published, in which they have shown that the mechanism of IVIG, the way IVIG can protect a patient from endothelial injury is because it can actually negate the effect of the neutrophil extracellular traps. So in our study also, we had previously also looked at the neutrophil extracellular traps in KD patients. So what you can see, these are two panels. This is from the KD patient and these are our controls. So we have used this confocal microscopy to visualize the nets from our patient samples, and we have found dramatically increased nets, both stimulated and unstimulated, in our patient group as compared to healthy controls. So I'll just briefly run you through what these beautiful pictures mean. So this basically DAPI, this will stain the DNA because the neutrophil extracellular trap is produced by the neutrophils. We have to be sure that this is coming from the neutrophil. So this will stain the nucleus. This cytox is a dye which actually binds to the dead cells and the nucleus. So this shows that this is from the neutrophil, and MPO is a confirmator because MPO is a granule granules are enzyme which are released by the neutrophil granules. So an overlay can show you these beautiful nets which we could visualize. So in the interest of time, I'll probably skip this. Then we also carried out some cluster analysis to see how the nets correlate with our patient clinical profile. We also then did this very interesting analysis called the T-distributed stochastic neighbor embedded thing. It's a technique for dimensionality reduction. So basically, when you have large data sets, to make it understandable, we use this dimensionally reduction technique. So probably I'll discuss this tomorrow in my another talk, in the oral talk, but here you can see we found this a subset of neutrophils which are negative for the activation markers, but it is actually a neutrophil. This is a typo. Actually, this is CD11B. So yes, this can help you to identify new subsets, and we are currently looking at this data sets in more detail in our lab. So as I told earlier, platelets also have an important role, and they can form complexes with neutrophils and monocytes to form these aggregates, which can again drive the inflammation via the inflammasomes. So another update on pathogenesis is on the complete and the incomplete KD. The patient profiles, when these patients were immunophenotype, we could see that there is an increase in the incomplete KD, there is an enhancement of the innate responses and a downregulation of the T effector subsets. I'll probably skip this. And other than that, currently this is the work which has been published on the genetics on Kawasaki disease from Chandigarh, and we have looked at the different polymorphisms which can increase the risk of having Kawasaki disease. This is another study from our group which is on the single nucleotide polymorphisms of TGF-beta in Kawasaki disease. This work was performed by Dr. Manish Arora. He's a DM resident in our unit, and we could find association of these two SNPs, and this work is soon to be published. So I'll just end at this and acknowledge the children of Kawasaki disease and their families for enabling us to use their samples in these studies, and obviously my unit, which is the allergy immunology unit, and the different funding agencies which have really helped us with funds and have enabled us to carry out this study. And obviously my mentors, Professor Sujit Singh and Professor Amit Rawat, my colleague Dr. Sanya, they are the lab consultants and who've been the backbone on which we can really do this work. So these are our collaborators from Derma and from Punjab University. So thank you everyone. I'm glad to take questions.
Any question from audience? So understanding the pathophysiology and pathogenesis is very important for understanding a disease and for better management of the patients. So doctor, she has very nicely explained these pathogenesis, which she has explained it here very nicely and enlightened us. So thank you.
Thank you. Thank you.
It's
Thank
a
you,
nice
sir.
presentation.
So, thank you so much to Dr. Manpreet Dhaliwal, an immunologist and belonging to the unit of immunology and rheumatology. So, you have really made it threadbare, and I think we really have no questions. So, you will take it forward from there tomorrow, I'm sure. We look forward to it. Thank you.
To delve into the controversies regarding incomplete and atypical KD, we have our next speaker, Dr. Satish Loknathan, Associate Professor at CMC Vellore. I request the chairpersons of this session, Dr. Rakesh Kumar, Professor at IGIMS, and Dr. Rakesh Sharma, Assistant Professor at PMCH, to join us on stage.
Good afternoon, everyone. The next topic is really an interesting one, where we will be going to learn about those cases of Kawasaki disease where the diagnostic criteria are not fulfilled. So, as a pediatrician, we often get stuck in those cases where we find fever is present for 5 or more days, and the diagnostic, the mucocutaneous inflammation signs are only 2 or 3. So, all these puzzles are going to be solved by our speaker, Dr. Satish Kumar, and over to you, sir.
Thank you, sir. Thank you, sir, for the nice introduction. Thanks to the organizer, and I thank Dr. Pratap Patra. When Pratap Patra sir called me with this topic, controversies in incomplete and atypical Kawasaki disease, I was wondering why he chose me. So, because speaking in front of the sir with the controversy is very, very difficult. And currently I am attached with the infectious disease clinic. I thought so Dr. Pratap Patra thought me I might be the ideal person to talk about the controversies. So, when he gave the topic, I first Googled seeing the dictionary meaning what is controversy. They said the public discussion and argument about something that many people strongly disagree about and think is bad or shocked. So most of the time when you tell the diagnosis something people may not aware, they might be shocked and disagree, and sometimes they think I am a very bad person. So when you face such difficult cases, or sometimes if you don't get answers, first what you will do, you take a people's opinion. Next what you do, you make yourself 50-50 decision whether we have to go for take a call or we have to call an expert or somebody is like a friend of you. So Dr. Priyankar Paul was telling you call a friend. I used to get multiple calls like this. I am going to reverberating whatever the calls I got in the past for so many years, this almost 3-4 years. What was the people's opinion regarding a difficult diagnosis when they suspected a KD, like a atypical KD or like an incomplete KD. So I start with the JCS 2020 guideline when they published in the circulation journal. So the way it was started and the high-dose IVIG was initiated at the 2004, and it was started at the 9.8% the incomplete KD. Slowly the incomplete KD was slowly rising, and the frequency of the incomplete cases increasing trend, and in 2018 it is almost 20.6% was there. So the recent circulation guidelines, that updated guidelines, and the atypical Kawasaki, they suspected incomplete diagnostic criteria is prolonged unexplained fever and 2 to 3 criteria with the 5, and unexplained fever for 7 days, and the compatible laboratory or echocardiographic diagnosis. That is, starts with the CRP more than 3 and the ESR more than 40 and plus 3 of the following. That is anemia for age, platelets more than 4.5 lakhs, albumin less than 3, and the elevated ALT and the elevated WBCs and the urine WBCs more than 10 per high power field, and the Z score, the LAD or RCA more than 2.5. And there are other three suggestive features when you do the echo. There is a decreased left ventricular function, mitral regurgitation, and the pericardial effusion, or Z scores in the LAD or RCA 2 to 2.5. So I'm going to deal one by one like this, all this diagnostic criteria in the incomplete KD, how it is going to impact like when you make a diagnosis. So the incidence starts like from 2012, like it was initially 15 to 36.2%, and it was slowly rising to 37.6%. And currently it is now almost like 54% of the incomplete KD is there in the literature. So incomplete KD is really like always incomplete. When the people develop symptoms, sometimes the signs may go off. So the incomplete KD is always not really incomplete. So the incomplete and the atypical KD is more common in infants and the young children, and the signs and symptoms is very non-specific, and it overlap with the many conditions when you have like infectious disease, and the atypical presentations will really give a tough time to you to diagnose this atypical KD. So people consider atypical KD as a mild KD. It was not like a mild KD, but the way the impact in the coronaries, the coronary dilatations with the atypical KD, it is not a mild KD. So the clinical features, first prolonged unexplained fever, and the 2 to 3 clinical criteria are if the patient develops with unexplained fever for 7 days, what is the common thought they have? The mimicus, when they call you, the mimicus only they will discuss, whether it is a measles, whether it is adenovirus. Because the prodrome starts 2 to 4 days, the 3C is very important for a measles, that is cough, coryza, and conjunctivitis. And the incubation period extends to 10 to 12 days, and the adenovirus incubation period is 12 to 14 days. And the bacterial causes, the scarlet fever is the one of the most common differential diagnosis. Whenever any Kawasaki disease is admitted, the other spectrum of the people always discusses the scarlet fever. And the staphylococcal toxic shock syndrome is like one of the differentials will be there always, even in the latest criteria, like when they discuss, this was the one of the differential was like mentioned in the article. The acute phase reactants, the people who are doing acute phase reactants for all the fever evaluation, it is a great concern. When people is having CRP more than 3 with the ESR 40, they said positive reactant. When you go and tell like with these patients, you evaluate for incomplete KD, always they have a concern. They start discussing with any other infection also will have the same thing. And the same like the negative phase reactant albumin, if it is less than 3, that also gives like the same discussion. These two CRP and the ESR, the phase reactants, the discussion, and whenever they are evaluating the fever, these two investigations will be there always in all the panels. So the supporting lab evidences like anemia for the age and the platelets more than 4.5 lakhs and the albumin less than 3, elevated ALT and the WBC 15,000 and the urine WBC is more than 10. These are all the supportive lab evidences for your incomplete KD. So when I had a chat with one of my friend, he said like, when you say like anemia for the age, the National Family Health Survey, they said less than the aged children 6 to 15 months who are anemic like 11%, they are already 67% is there in the India. And the adolescent girls 15 to 90% and 15 to 90 years, they are 59%, and the adolescent boys 31 to 1.1%. So when the anemia for age, when they are talking for like a developing countries, this anemia for the age, it's a great concern. So when I Googled it, like this article I found like the incompleteness of the incomplete Kawasaki disease. Is it a customized definition is needed for Indian children? They mention compared to Western cohorts, these criteria should be carefully defined in a low and middle income settings like India because there is a high prevalence of iron deficiency anemia associated with the thrombocytosis. At the same time, the current definition likely to overestimate the burden of the incomplete KD in Indian children, risking they are potentially delaying the diagnosis of underlying infections. So this is the comment, like controversial statements when you get discuss with the consultants, like with the other spectrum when they have dealing with incomplete KD. So thrombocytosis, we know like it supports the incomplete KD. When it is associated with the iron deficiency anemia, always the discussion and the debate builds up. When the patient presents with the thrombocytopenia and the call list like goes to the hematologist, and the hematologist always concerned it may be like something else, not like a Kawasaki disease. So we'll go with the clinical vignette, like 11-month-old girl child presented with fever for 10 days with no other foci, and the systemic examination is not contributory. So they asked me, will you consider KD? So what is the opinion? So we'll go with it. So I told them, you go run some blood investigation. I suggested, okay, you do some blood investigation. They did. Hemoglobin is 12 milligram per deciliter and the TLC is 17,340 and the ESR is 16, CRP is 32, ALT is 25, albumin is 2.8 and the urine routine is 15 and blood urine culture negativity, urine culture is negative, echo is normal. And when I showed this criteria, it fulfills like your albumin is low and your TLC is like 17,340 and there is urine is 15. So what next? So they asked me like over the phone, what you are going to do next? Sir, you asked me some investigation. I have done the investigation. Yes. Platelets is also having some, platelet is normal. It's not thrombocytosis. So sometimes when the new Nelson comes, we forget to read the new Nelson. But the residents are very active. He went and shown this entity, occult UTI. Sir, this is there in the Nelson 22nd edition. Sir, what is your opinion? You shown me the definition. Occult UTI should be considered if 3 of the following risk factors are present. That is age less than 1 year, fever more than 39 degrees Celsius, and more than 48 hours of the fever. And if there is no source of fever, sir, this is there in the Nelson. Will you consider this? I can't able to explain him what it is. And the next, the elevated WBC, if it is more than 15,000, if any patients like more than 7 days fever workup, always they come with the entity called occult bacteremia. So this occult bacteremia is there in the definition in the Nelson. They said like you do the blood culture, and one of the safe strategy they said like you IV ceftriaxone, and you have to do the blood culture. But the blood culture when you do like after giving antibiotics, oral antibiotics, the sensitivity of the blood culture is quite low. The technique the technique they are doing for the blood culture and the method what we are doing, all this going to impact to make a diagnosis occult bacteremia. So when the people are more and more convinced it is occult bacteremia, it is very, very difficult to convince them the patient is having a atypical Kawasaki disease. The next scenario is a 4.5 years old boy presented with fever for 7 days. He is having a maculopapular rash over extremities for 4 days and the swelling of dorsum of hands for 2 days. And the child had a pallor and no lymphadenopathy, hepatosplenomegaly. So what will you do? Will you consider KD? I said like again you go for do some blood investigations. They did the blood. HP is 9.8, total count is 22,000, ESR is 110, CRP 98, ALT is 220, albumin is 2.8, blood urine culture negative, echo is normal. So what next? Again they'll ask you what next. So they did a scrub IgM, that was positive. So they asked me, that particular consultant, junior consultant asked me, sir, it is a scrub typhus, or you are going to call it is like infection disease, infectious scrub typhus triggered incomplete KD with normal coronaries. So what happened to the child? Child responded to the doxy, we have repeated the echo, then there is normal coronaries, we are keep following the child. The message, unlike Western countries, there are huge load of tropical diseases we have in India. So this always give a tough time to the people who are going to explain this incomplete KD. The echocardiography again, there is LAD, CA, coronary aneurysms, and the RCA is more than 2.5. The other cardiac findings already they mentioned, and the pericardial effusion, mitral regurgitation, and the decreased left ventricular function. If there is more than 3 cardiac finding is there, that also fulfills for the incomplete KD. But echocardiography in prolonged fever in a clinical setting, what are all the situations we do echo? If it's a congenital heart disease, the known congenital heart disease comes with a fever to rule out infective endocarditis, we do. Otherwise, rheumatic heart disease. If there is a concern for rheumatic heart disease, we'll do the echo. But in incomplete KD, the normal echocardiography in the initial period, there is operator dependency, and the infants and children, it is very difficult to do. And there is other findings like coronary ectasia, dilatation, and there is a tapering of the coronary arteries, myocardial dysfunction. These are all the things we have to explain to the people who are doing the echo and convince them to kindly screen for these particular features for the incomplete KD. And again, the concern is treatment strategy when incomplete KD. Only if the presence with fever and followed by if the fever is having with the children with having high risk criteria, what to do? That is a question. There are few signs are very interesting and it was not included in the criteria as a perineal desquamation because this appears very early compared to the periangular appearance desquamation. It appears very early. It provides the initial clue that was not included in the main criteria, and there is a BCG reactivation. This is a very useful sign in BCG vaccinated countries. So why can't we consider this as to be included in the criteria? So morning, Dr. Prabal mentioned this rash. In the rash, the BCG site inoculation reactivation was included. When after adding this criteria, there is much more patients they can pick up. Even this was there in the main criteria. They can consider as a complete KD. And the incomplete KD was very well correctly mentioned in the Japanese society. And the associations, when the patient is having associations, if any patient comes with the peripheral gangrene, if you go and tell them kindly screen for the Kawasaki disease, it is very, very difficult to convince the people to screen for this particular condition, especially when they come with the pneumonia, the gallbladder hydrops. It is one of the very common finding in the ultrasound. But whenever the gallbladder hydrops is there, the call goes to the pediatric surgery rather than the pediatrician. Especially when I faced this particular child, the child presented with the facial palsy. I diagnosed this child Kawasaki disease. To convince the people to treat for Kawasaki disease, it was a very tough time for me. So the special groups, when they have the less than 6 months older children and adolescents with the KD with the shock syndrome and the mass, when they have these particular patients also present with the atypical features or in an incomplete way, it is very, very difficult and a nightmare to the people who are managing these patients. So I feel the complete KD is like here. The incomplete KD and the atypical KD is like not there. We are not picking up that, only we are seeing the tip of the iceberg. So I acknowledge patients, teachers and organizers, and I thank both my teachers who made me, the person speaking incomplete made me complete. I thank both these teachers. Thank you.
So any questions from the audience?
I'm Dr. Anuspanda from Orissa. We get a lot of scrub patients. Your patient scrub. So is it not scrub myocarditis? If you have seen, how can you exclude incomplete KD with scrub and only scrub? Can you tell me some?
Ma'am, this scrub always like the palmar plantar rash. When maculopapular rash involving the palms and the soles. That is the one thing you usually teach all the postgraduates also. So when the multi-system involvement is there, like after 5 days, 7 days, always the multi-system involvement is there. It is very difficult. That's why like always we'll take a debate, and the infectious disease people will never convince when you tell them it is a Kawasaki disease.
Because scrub usually they come after fever for 10 days. Fever
Yes.
is not subsiding and then they come. Okay, thank you.
I had two comments to make. Firstly, the scenario which sir presented, that thrombocytosis, when we had a similar experience just last month. 1.5-year-old child had a short duration of fever, was evaluated outside, and somebody outside had picked up the thrombocytosis, referred to our center for further evaluation, was seen in the emergency. That time somebody just thought it is iron deficiency anemia, started the child on supplements, sent the child back. Then a week later the child ended up again with fever. This time the rheumatology opinion was taken, echo was done, that showed giant aneurysms.
Yes.
So this has...
Yes, so when the situation, if it is like, I used to catch this sort of scenarios, and whenever the patient develops, I used to call that particular person who always having a debate with me, and I will show them, you see this thrombocytosis is also having a coronary aneurysms. So the best way to teach and convince people is like always you give them the real life scenarios. Like last time, recently we had one child, the echo was normal. So the considered KD, echo was normal, not treated, and the child developed aneurysm, and that was the best way to explain them, this is the Kawasaki disease threshold. So then they will realize, and next time they call you immediately, at least when you tell something, they will listen.
I totally agree. And so the second comment was this occult UTI and occult bacteremia. That seems like a very loosely defined term. Everything under the sun can fit inside that. So
yes,
it further adds to the confusion only.
Yes, so but when the people, when a resident reading a new textbook of Nelson, like we cannot stop them. When I tell them, like occult bacteremia is a very lucid definition, but he said, like, sir, it is published in the Nelson. So he's debating with me, sir, it is published in the Nelson. Why they publish? If it is not an entity, you should not publish. So then we have to respond, and I have to convince them, and I have to teach him slowly. Then this is the way we should, like, when I joined before DM, I also was like in the same page, the occult bacteremia, occult UTI. Now, after completing the DM, the 3 years, the way of the patients I am seeing, the people they are not recognizing the KD, I am the best person to teach them.
One question is from my side. Especially in less than 6 months of age group, somewhere I have read that only fever for more than 7 days duration should also be, and the cause is not being identified. So KD should be kept in mind.
Yes. So this particular, whenever asked this, yes sir, it's a very interesting question. I learned from Sujit Singh sir, like after 5 days, if nobody is responding to the antibiotics, if the fever is persisting, kindly consider KD. This is like this, I proved this particular statement when in my institute, many times I told them, I proved this is the way you should screen patients for the Kawasaki disease.
Any other question? So this brings the end to this session. Excellent presentation. Thank you.
Our next session is a much awaited one. To pay tribute to Dr. Tomisaku Kawasaki, the renowned Japanese scientist who first described this disease way back in 1967, we have his very own daughter, Miss Subura Kawasaki. Let's extend a very warm welcome to ma'am, who's come all the way from Japan to share her anecdote. Thank you, ma'am. This very emotional session will be chaired by Dr. Surjit Singh, Professor and HOD, Department of Pediatrics at PGI Chandigarh, and Dr. Nigam Prakash, retired HOD of PMCH Patna.
Before she starts the epic, emotional output, a daughter's tribute, I think we have to acknowledge that this disease entity came in the 90s, and in our, you see, undergraduate days, we didn't know that. You see, I have graduated way back 75, so we didn't know about this. And then on, this entity is so commonly found. I mean, it is not that rare. And now I think you should acknowledge that any child who is having a fever more than 5 days, you should start thinking about something like Kawasaki. Please, madam. Thank you very much. Your comment, sir.
Thank you very much. Good afternoon, everyone. Namaste. I am Tsubura Kawasaki, the second daughter of Tomisaku Kawasaki. It is a great honor to be here in Patna, India, a place of tradition and deep wisdom, to talk about my beloved father. This is my second visit to India, following last year's invitation to Chandigarh. During my first visit, I became a big fan of India. I was impressed by the deep compassion shown by the Indian medical workers towards children. I was impressed, and my personal appreciation and interest in Kawasaki disease deepened through interaction with Indian doctors, especially the young researchers who made a strong impression on me. This experience inspired me to think about my contribution to Kawasaki disease research and patients. Whenever I prepare to talk about my father, I reflect on the countless stories and lessons he left behind. Today, I would like to share a personal anecdote and reflect on the broader impact of my father's work and what it means to be his daughter. This photo shows me with my father when I was about 2 years old. My father was perhaps in his late 30s, and When I was born, he had already encountered the first and second cases of Kawasaki disease. I still remember when we took this photo together. It was when he went to take his ID picture at the photo studio near our house, and I accompanied him. After taking his own photo, I begged him, "Papa, I want mine as well. I want to take a photo with you." So it was an unnecessary photo to take, but now it has become one of my greatest treasures. Looking back, my father was working hard at the time on a paper that would later be recognized around the world. He was not only a pioneer in medicine, but also a pioneer in fatherhood for his generation in Japan. He was deeply involved in our daily lives, breaking the traditional mode of fathers in Japan at the time. One vivid memory I hold dear is from this period. At night, after putting all three of us children to sleep, my father would work tirelessly at a small kotatsu room. kotatsu room? そう、こたつルーム。ちょっと待ってね。こたつルーム。at a small kotatsu table in the corner of our tatami room. Yet, no matter how engrossed he was in his research, if I woke up and needed him for something as simple as going to the bathroom, he would immediately stop his work and help me. His presence was constant and comforting, even during the busiest phase of his career. I would say my father was an original ikumen, in Japanese term, who took care of his children more than a typical Japanese father of his generation. For example, when we were babies and cried a lot at night, he would take us for midnight drives to Asakusa until we calmed down and fell asleep. When my brother and I were little, we would wake up early and begged him to take us for walks around the neighborhood. Despite his demanding work environment, he always made time for us, taking us for early morning walks before heading to work. Besides our morning walks, there was another special place where I spent time alone with my father. My father worked at the Japan Red Cross Hospital and enrolled me in a spend time alone with my father. My father worked at the Japan Red Cross Hospital and enrolled me in a nearby nursery school. Before dropping me off, we would spend time together in Arisugawa Park. Sometimes he bought me ice cream and we would walk in the park enjoying ice cream together. Those moments were precious, having him all to myself. As I grew up, my father published the Kawasaki disease paper and became busier with the hospital, research, conferences, and writing papers. Many researchers and doctors visited him, and he was invited to present his work both in Japan and abroad. When visitors came from inland and abroad, he would take them around his hometown Asakusa and other places. He was a great host and enjoyed having visitors. On those occasions, he would take me with him, giving me the opportunity to meet doctors from different countries. These experiences shaped my worldview and taught me the importance of building bridges between cultures. India, in particular, he held a special place in his heart. He admired the warmth and hospitality of Indian doctors and researchers, and often spoke about the importance of collaboration across borders. Growing up as the daughter of a famous doctor wasn't always easy. I struggled with my studies and often felt I couldn't meet the expectations that came with being Dr. Kawasaki's child. But my father always reassured me. He would say, "It's okay if you are not good at studying. Just be unique and follow your own path." This lesson stayed with me and continues to guide me. It reminds me that success is not defined by titles or grades, but by being true to oneself. My father's journey wasn't just about discovering Kawasaki disease. It was about building a community of researchers, doctors, and families united by a shared mission. He worked tirelessly until the very end, dedicating his retirement to establish the Japan Kawasaki Disease Research Center. It was his way of ensuring that the fight against this disease would continue even beyond his lifetime. As I stand here in India, I feel my father's spirit with me. He would have been honored to see the strides being made in pediatric care and Kawasaki disease research. Indians' dedication to medical advancement and compassion for children align deeply with his values. He believed in the power of global collaboration, and I hope his story inspires us to continue working together. This was when my father in India. My father worked tirelessly at the Japan Red Cross Hospital for 40 years before retiring at the age of 65. After retiring, he established the Japan Kawasaki Disease Research Center in Kanda. He devoted the rest of his life to research, meeting people, and supporting parents. He also would give lectures at the medical schools and attend annual health checkups at my alma mater's elementary schools. Going to the center was my parents' research for living in their later years. as I accompanied them to the center every Tuesday. I felt their passion for Kawasaki disease. Since their passing, I have been helping with the center's activities since 2020. My mother passed away on June 12, 2019, just 1 year after IKDS in Yokohama, 2018, leaving my father alone. He moved to an elderly care house in Asakusa, and I visited him every day, often taking him for walks in his wheelchair around Asakusa when the weather was nice to keep his spirit up. This is walking in Asakusa. It was just like when I was small, but now it was my turn to take him around. We ate ice cream by the river, sang as we watched the Sumida River, and passed by the Asakusa temple where we used to walk when I was little. These moments were precious, having him all to myself again. In his final years, I had the privilege to caring for my father, just as he had cared for me as a child. We shared walks around Asakusa, reminiscing and cherishing our time together. In those quiet moments, I realized the profound impacts he had, not just as a doctor, but as a father, mentor, and human being. Today, I stand here not just as his daughter, but as someone deeply proud of his legacy and committed to carrying it forward. His late days in the hospital. This is their grave. And Dr. Singh came to visit their grave this year. So thank you to all the doctors and researchers here for your dedication to the health and happiness of children. On behalf of late father Tomisaki Kawasaki and my family, I would like to express my sincere gratitude for your work and the tribute you have shown to my father. Let us continue to work together, striving for a world in which all children affected by Kawasaki disease can grow up healthy and happy. Thank you very much.
Requesting Sujit Singh sir and Nigam sir to just present a memento to ma'am. Thank you, ma'am. Thank you, sir. Our next session is on the 7th, Dr. Tomisaku Kawasaki oration, for which I would like to request Dr. Mamoru Ayusawa, Professor and Faculty of Health and Medical Sciences, Kanagawa Institute of Technology, Japan, to join us on stage. Our chairpersons for the session are Dr. Priyankar Pal, Professor ICH Kolkata, and Dr. Rakesh Pilani, Assistant Professor at PGI Chandigarh.
The most prestigious session of the conference is the oration. So we welcome everyone to the 7th Dr. Tomisaku Kawasaki oration of the Indian Society of Kawasaki Disease. 57 years have passed since the first publication of this unique disease. Dr. Kawasaki diagnosed the first case in 1961, a 4-year-old boy who presented with a febrile exanthem. Dr. Kawasaki described the clinical features and proffered the diagnosis in this child as unknown. This unknown diagnosis later became an important step in his serendipitous discovery of a new disease entity that now bears his name. In the words of Professor Kato, this discovery was based on deep insight into astute clinical observation and scientific consideration. He reported his cases as a possible new disease, but met with a lot of opposition from the scientific community and his academic peers. He had to defend his new observations against many skeptics in the academic community. However, he had the courage of conviction to stand by his initial observations, and he was convinced that this was indeed a new disease entity. He collated data on 50 such cases, and in 1967 published an article in the Japanese Journal of Allergy covering 44 pages. This original publication is still considered to be a masterpiece of accurate clinical observations and continues to be cited over 50 years, even 50 years after its publication. The first set of diagnostic criteria of the disease, published in 1970, was mainly based on this article. The cardiac symptoms or findings were not described in this article. In 1970, the first nationwide survey in Japan reported 10 fatal cases, and the pathological findings of all autopsy cases demonstrated the same findings as a vasculitis in the medium-sized arteries, particularly with coronary aneurysms, thrombotic occlusion, and sudden death. In 1978, this disease was described in Nelson's textbook of pediatrics as mucocutaneous lymph node syndrome or Kawasaki disease. By this time, KD had attracted a lot of attention in pediatric units worldwide, especially in the USA. During 1980 to 2000, Dr. Kawasaki was invited to give lectures at many international congresses and conducted grand rounds at children's hospitals and universities the world over. In 1989, he delivered the prestigious T. Duckett Jones Memorial Lecture by the American Heart Association, which is an honored lectureship for outstanding pediatric cardiologists in the world. He received many distinctions in Japan and elsewhere, such as the Takeda Medical Prize in 87, the Medical Award of the Japanese Medical Association in 1988, Asahi Prize in 89, and the Japan Academy Award in 1991. The Japan Pediatric Association Award and Special Award for Lifetime Achievement for Contributions to Pediatric Research and Child Health, awarded by the Asiatic Society for Pediatric Research and Pediatric Academic Societies in 2007. In 1984, he established the Japan Kawasaki Research Foundation, which supported nationwide KD surveillance. The foundation also organizes and supports the International Kawasaki Disease Symposium, which started in 1984 and is held in Japan and the USA every 3 years. And we hope that someday we will be able to host a symposium in India. The prestigious Dr. Tomisaku Kawasaki Oration of the Indian Society of KD was started at the first Congress of the Society at Chandigarh in 2018. Dr. Yoshihiro Unuchi delivered the first oration, and subsequent orations have all been delivered by Japanese doctors. So I will now request Dr. Rakesh Pilania, the Joint Secretary of the Indian Society of the Kawasaki Disease, to introduce the speaker.
Thank you, sir. It's a proud privilege to introduce the orator of the day, and on the behalf of Indian Society of Kawasaki Disease, we welcome you and we thankful Professor Mamoru Ayosoma for considering the invitation for oration. So Dr. Mamoru Ayosoma is a professor at Department of Nutrition and Life Sciences, Faculty of Health and Medical Sciences, Kanagawa Institute of Technology. He is a visiting professor at Department of Pediatrics and Child Health, Nihon University School of Medicine. He is currently having several hats, like he was the president of 13th International Kawasaki Disease Symposium. He was ex-vice president of Japanese Society of Kawasaki Disease, professional member of the American Heart Association, faculty and board of the Japanese Society of Pediatric Cardiology and Cardiac Surgery. He is a faculty and board of the Japan Pediatric Society, fellow of the Japanese College of Cardiology, and board of the Japan Circulation Society. Dr. Mamoru Ayosama was graduated in 1984 from the Nihon University School of Medicines. In 1991, he enrolled in MD and he obtained in PhD by the study of the color Doppler echocardiogram in pediatric patients with mitral regurgitation. In 1997-98, he went to abroad for the studying at Heart Center Children's Hospital, Los Angeles, University of Southern California, United States. He has more than 40 years of experience. He joined as a clinical work as a pediatrician since 1984. He joined as a pediatric cardiologist since 1988, and he is working in Nihon University of School of Medicine, Itabashi Hospital since several years. He is titled as an American Heart Association membership and reviewer since 2015, which is a great honor, and he is part of committees in Japan Sports Council School Safety Department since 2013. His interests are in pediatric cardiology and special interest in Kawasaki disease, and out of that, the special interest is in sudden cardiac arrest or death in children with Kawasaki disease. He had several publications and he is part of the several guidelines of the Kawasaki disease in Japan, and name a few is that recent revision of the diagnostic guidelines for Kawasaki disease, 6th revision. He is the co-first and corresponding author of that guidelines. He has written several book chapters in Kawasaki disease, and he is a part of several committee members who decide the treatment of the Kawasaki disease in Japan. So again, I am thankful to the Professor Ayosama for accepting this invitation. The stage is yours, and as a part of tradition of oration, we don't take any questions after that oration.
Hello everyone.
Thank you very much for your introducing me. Maybe it's too much for me, but I'm very glad and very honored of being invited in this great meeting, 7th Indian National Society of Kawasaki Disease. So today, especially for me, it's all the 7th Dr. Tomisa Kawasaki oration. I'm maybe I don't think I can do so well, but I do my best. So let's start about the diagnosis of Kawasaki disease, history and the contemporary style in Japan. So for precise communication, I will read my script. Sorry. Okay. I appreciate and congratulate Professor Paul, Professor Sharma, Dr. Patra, and Dr. Kumar, and other every organized committee members, and especially thank to Professor Singh. And you invited me 2 years ago to this meeting, but that was timing for my career change to the current University of Kanagawa Atsugishi Institute. So I asked to Dr. Miura to act for this oration. So this meeting is very good, very nice meeting and very passionate. I know. Last year, Dr. Hamada is also a friend of mine. Very good. He said very good and passionate, and especially he likes to talk with medical students or trainees, and that was his pleasure. So I heard and looking forward to coming here. Okay, so let's start about my talking. Okay. Where? Okay. I don't have any COI. Since here. Thank you. Okay. Today I will talk to you how Dr. Kawasaki was aware of this disease by watching a video in which he talked by himself. Then the history of original diagnostic guidelines and their revision will let us know the improvement of the clinical practice and management of the patients in Japan, and I will confirm each clinical sign. Then I need to compare them with AHA statement in 2017. It's just revised recently, and the fever duration becoming 4 days is necessary, but almost of the same, I think. I don't have any COI. And we are very sorry that Dr. Kawasaki passed 4 years ago, but we have to care many patients with his namesake disease with respect. At first, please let me talk about Dr. Tomisa Kawasaki. In 1925, Dr. Tomisa Kawasaki was born in Asakusa City, a historical downtown in Tokyo. I heard that he wanted to be a biologist because he likes to observe small insects or animals. After he graduated Chiba Medical School, he began to work in Red Cross Hospital in Tokyo because he wanted to work as a clinical practitioner. Picture A and D on this slide are of Japan Red Cross Hospital around the 1960s. Dr. Kawasaki was a chief fellow of the Department of Pediatrics in this hospital. On January 5th, 1961, he met the first patient, and until 1966, he experienced 50 cases with this unique and characteristic syndrome. Picture C is a part of his note, as you know. I want to introduce a video in which Dr. Kawasaki talked about his experience of his first encounter with patient. Mainly, I would like young doctors who have not met Dr. Kawasaki to watch and listen to his speech and feel his humble and gentle and role model as a pediatrician, I think, because we cannot meet him anymore. So let's start video. Okay. At the medical meeting before his publishment, a famous professor criticized and never agreed with Dr. Kawasaki's presentation of this disease. The professor said this phenomenon is a kind of Stevens-Johnson syndrome, but Dr. Kawasaki never surrendered and explained that clinical findings in both diseases are much different. He decided to submit his article to the Journal of Japanese Society of Allergology, allergy, we call it in Japanese. Acute febrile mucocutaneous lymph node syndrome in young children with unique digital disclamation clinical observation of 50 cases observed at our institution. So this paper became a historical article. Not a few pieces of information began to be informed from the clinical pediatricians of many places in Japan. Later, Dr. Kawasaki published an English translated version in 1974, and most pediatricians in the United States were attracted and interested in experiencing MC areas, which reviewer of the pediatrics asked to change MLNS. But gradually, this disease became to be called as Kawasaki disease, with full of respect from most pediatricians and patients' family in the world. In 1981, Professor Marian Melish reported the first report at Hawaii University. This is the first case in the United States, I think. A splendid observation and science sentences in Dr. Kawasaki's article made the American Heart Association praise this article as one of the most excellent case series in the 20th century. These are typical findings of Kawasaki disease in Japan. Dr. Kawasaki was aware of and tidied up these unique clinical signs of febrile patient. After publishing the first article, the pediatricians gradually began to support this new entity. Then Dr. Tomisaka Kawasaki asked Dr. Itsuzo Shigematsu, a professor of public health at Jichi Medical University, to plan the first nationwide surveillance, which they carried out in 1970. This surveillance has been succeeded to the next Professor Hiroshi Yanagawa, then Yoshikazu Nakamura, and finally from 2024, Professor Ryusuke Ae has just begun a new series of the new method, but possible to continue with the conventional style. For the surveillance, they need diagnostic criteria or guidelines. These are the original diagnostic guidelines in Japanese. We have called our diagnostic guidelines Shindan no Tebiki in Japanese. For today's talk, I translated the original diagnostic guidelines into English. Acute febrile mucocutaneous lymph node syndrome was used as the diagnostic term, which was the title of Dr. Kawasaki's article. Characteristic clinical signs are summarized as indispensable signs, and additional referential findings were lining up. For the case definition, we could diagnose KD when the patient shows 4 signs, including fever, among 5 indispensable signs. Although cervical lymph node swelling was not included in the original guidelines, in the second revision, 4 years later, it became one principal sign, and to diagnose KD, it became necessary to fulfill any 5 or 6 principal signs. The most significant difference from later guidelines in this original version is that they wrote this disease has no sequelae and also no occurring in siblings. But Dr. Kawasaki and colleagues were astonished by getting the first surveillance data from all over Japan, because they could receive more than 1,800 patients, including 26 death cases reported. The cause of death was reported as myocarditis or acute myocardial infarction, and coronary aneurysm and its obstruction by thrombus were revealed in almost all autopsied cases. After the first surveillance, diagnostic guidelines need to revise along with the result of the surveillance and progress of medical practice. Guidelines were rapidly revised as this disease has serious and very characteristic cardiac complications such as coronary artery aneurysm, myocarditis, and mitral regurgitation, and its mortality is 1.5%. We have revised it 6 times ever. Concerning cardiac complications, on the second revision in 1974, cardiovascular complication was noted in the first line in the referential findings. When the fourth revision was discussed, it became possible that the patient with 4 principal signs and coronary aneurysm could be diagnosed as KD, Kawasaki disease. In the fifth revision, the description about incomplete case noted that there are incomplete cases which do not fulfill the principal signs, and about 10% of them complicate coronary aneurysm. And in the most recent sixth revision, definition of incomplete KD is detected by number of signs and coronary aneurysm, which is recommended to detect by G-score of echocardiography. Cardiac complications have had the most substantial impact on KD patients' prognosis. Along with these revisions and clinical experience, the epidemiology of Japanese KD patients has been changing like this graph. The number of patients is shown by the blue and the orange color bars, and they have been gradually increased since 1990 for an unknown disease and for unknown reason. But the mortality shown by the red line has rapidly decreasing. Cardiac complications are shown by the red line, mainly coronary aneurysm, decreased to 2 to 3% of the patient, but there are a few deaths in a year even recently. Another attention is that the number of incomplete KD, IKD, shown by the purple line from 1992 has been increasing. It became about 20% recently. The reason is unknown. It may be because of the diagnosis is made earlier before the number of principal signs does not fulfill the criteria, or really IKD patients who do not have enough principal signs until recovery is increasing. I don't know. After the 1990s, intravenous immunoglobulin IVIG improved coronary artery complications markedly. However, IVIG resistance and later diagnosis of misdiagnosis of incomplete KD were necessary to solve. In Japan, the scoring system can predict IVIG resistance, making us decide the need for additional therapy. The diagnostic guideline needs to revise the early diagnosis of incomplete case about fever or other clinical signs before about incomplete case. I will talk about the change in the definition of fever in the guidelines in Japan. Originally, the fever of KD is defined by 2 features. One is resistant to antibiotics, and another is to continue for 5 days or longer. However, these conditions are revised to omit because many exceptional cases have increased. 4 years later, from the original guidelines, the third revision documented fever as continuing 5 days or longer and with unknown origin, but the condition of resistant to antibiotics is deleted. Some patient was effective to the antibiotics. Then, as the fourth revision was deleted with unknown origin, the fever continued for 5 days or longer. In the fifth revision, because the single high-dose treatment of IVIG began to generalize, cases are regarded as fulfilling the fever criteria when the fever subsided before the fifth day by treatment. As the definition became very confusing, the most recent sixth revision documented that fever does not need any condition. By this revision, we can diagnose the patient as KD and can start IVIG before the fifth day if the patient has other principal signs enough. However, we always need a sufficient differential diagnosis. Other principal signs are also revised to diagnose KD or incomplete KD earlier. From the second revision, cervical lymphadenopathy was included to principal signs, and because of its incidence was a little lower, the title indispensable signs was altered to principal signs until now. In the fourth revision, case with 4 principal signs and coronary artery aneurysm can be diagnosed as Kawasaki disease. In the fifth, incomplete Kawasaki disease is written in the footnote. As the proportion of it has been increased about 20%, IKD is increasing about 20%. The sixth revision defined IKD as the cases with 3 signs and coronary abnormality, or 4 signs even without coronary abnormality if an adequate differential diagnosis was made. We can use the IVIG for such patient. Aiming for earlier diagnosis, in the sixth revision, we added the BCG inoculation change into the principal signs, and the definition of incomplete KD is detected by number of signs and coronary aneurysm. With the experience after 50 years history of KD, we are using the 6th revised version of diagnostic guidelines. Most of the audience today are interested in KD and know the primary findings still, because today is a seminar. Today's meeting, I would like to confirm the feature of each clinical sign together with everyone. Concerning fever, we do not need to wait until 5th day if the patient has a significant fever, even with 2 or 3 other principal signs and some referential examinations. The signs of eyes is bilateral conjunctival congestion, as it is not an infection. There is no or little exudate, equal to both conjunctivitis, equal to both conjunctivas. Often we can see each small vessel reddened separately, or sometimes we can see pinky conjunctiva as a whole. The sign of the lips and oral cavity diffusely reddened, easily cracked and bleeding, and change to cluster formation like this picture. Tongue often change to strawberry-like. Rash usually appears on the whole body, diffuse erythema multiform-like and non-specific to any virus or bacteria. KD patient living in the area where BCG vaccination is obligatory, inoculation site often turn red and swollen and exudative or ulcerative. From the 6th revision, we regard this sign to be included as one sign of the skin rash. This findings is limited to the age within 1 or 2 years after BCG vaccination. However, this sign appears very early, such as the first or second day from onset. So this sign is possible to be an adequate sign for earlier diagnosis. In the left picture, hands and feet are swollen and erythema spread from fingers to palms and toes in the acute phase. Dr. Kawasaki expressed this hand as shining and almost burst. In the right picture, desquamation from the border of skin and nail on the top of the finger after the fever resolved in the subacute phase. This phenomenon is specific to Kawasaki disease, but recently its incidence has become low as 80% and around 60% from 80 to 60% in older children. Cervical lymph node swelling is typically larger than 1.5 centimeter in diameter and unilateral, very painful. Although a few patients develop torticollis and its prolongation most improve spontaneously with physical and mental care for the couple of months. The lymph node sign has several features. One is the echo finding. It shows that the swollen lymph node consists of multicysts called grape sign. It is similar to that of EB virus infection. And another feature of lymph node swelling is the difference of incidence by age. Patient 2 years or younger show lymph node signs in less than 70%. But patients older than 3 years old show it is more than 80%. Sometimes older patients, such as those 5 to 10 years old, show only 2 signs, fever and lymph node. They appear for 5 to 7 days before the appearance of other principal signs, and the diagnosis becomes too late. This case is called node first KD, which Dr. Kanegaya in UC San Diego published. We proposed diagnostic guidelines, including incomplete KD at the 6th revision. We categorize incomplete KD by the number of principal signs and the presence or absence of the coronary aneurysm. In the near future, we wish the proper diagnostic method to detect the cause of this disease will be discovered. Besides principal clinical signs, referential findings are important, particularly when we are hesitating to decide the diagnosis. There are many biomarkers or characteristic lab data were studied ever. We raised 7 examinations shown here. These are partly common with the item for evaluating IKD in the AH statement. Description of the fourth item of elevation of BNP or NT-proBNP is a new clinically practical marker, and the sixth item of enlargement of gallbladder is a classical sign of KD. However, patient may not be examined, but it is easily defined by checking by the echo. The gallbladder swelling is often recognized as a specific finding for KD. However, the criteria of swelling is not written ever. Here is the referential data. If gallbladder is enlarged than these normal ranges, we need to observe and treat the patient as possible KD. Short axis, more than 3 centimeter. Sorry. Oh, yeah. Long axis, over 5 centimeter. So it is always discussing difference between diagnostic guidelines in Japan and AHA. So at first, diagnosis, therapy for acute phase, long-term management of sequelae. Guidelines in Japan is separated for these 3 parts. AHA is unified. It's good, I think. Second, how to counter-assign fever. In Japan, fever is 1 item in 6 signs. And AHA, fever is essential, indispensable, and other 3 or 4 signs mean the Kawasaki disease. 3, BCG inoculation site readiness is, of course, in Japan, it's included in principal sign, as I said. But AHA is, of course, it's not used. For the diagnosis of incomplete KD is Japan is depending on the number of signs and coronary aneurysm. And AHA makes good algorithm, but it's always discussing algorithm. So I'd like to detect any quantification of many examination data and to use some diagnostic guideline. But it's very difficult, especially for this Kawasaki. I always think the diagnosis of Kawasaki disease is essential by the clinical signs still. So we wait a much better method to diagnose by the young doctors. Okay. So this is the AHA algorithm. The AHA statement partly resembling items are raised for the incomplete KD diagnosis. They are proposing 1 criterion of CRP elevation more than 3.0 milligrams per deciliter. It will be studied from now on. Here is a summary of today's talk. Japanese diagnostic guidelines have been revised 6 times. Aiming for better prognosis of the coronary artery, earlier diagnosis is emphasized. Fever is countable as 1 principal sign before the 5th day. Redness of BCG inoculation site is included in the principal sign. 3 principal signs and CAL can be diagnosed as incomplete KD. 3 or 4 principal signs without CAL may be diagnosed as IKD. At last, let's see Dr. Kawasaki and his motto, be warm-hearted to care for patient and be strict to study medicine. I deeply appreciate if there was some participant in the 13th International Kawasaki Disease Symposium I managed with Dr. Nakamura, and also to the participant the last September in Montreal, the 14th IKDS. Thank you very much. And this is last slide for us. Thank you very much.
We'll be having a short tea break now. Would like to request everyone to go to the snack area.
I think tea break is not, is it?
No, sir. Requesting Chandmohan sir to present the memento to the chairpersons. Requesting everyone to return back to the hall by 4 o'clock. We will start the session at sharp 4 o'clock. Thank you. requesting the delegates to sit down so that we can resume the session. To delve into the treatment aspects of resistant Kawasaki disease, we have our next speaker, Dr. Akib Zafar Bande, Assistant Professor, GMCH Srinagar, and requesting the chairpersons for this session, Dr. Avinash Sharma, Assistant Professor, Tanda Medical College, Himachal Pradesh, and Dr. Anil Tiwari, Assistant Professor, PMCH, to start the proceedings.
So, good afternoon everybody. It's my pleasure to invite Dr. Akib Zafar Bande, who is Assistant Professor in the Department of Pediatrics at Government Medical College, Srinagar, Kashmir. And his talk is on treatment of resistant, difficult type of Kawasaki disease. So, as we are running late, so I request Dr. Bande to start the talk. Sir, please.
Okay, thank you so much for the invitation. So I'll try to save a few minutes from the schedule. So I'll be discussing about resistant KD, and this is the latest guideline just published recently, which makes IVIG as the previous guidelines the standard of care, and it is to be administered in all cases of Kawasaki disease. So resistant KD for the most part means IVIG resistant KD. And the definition which has been same across all the previous guidelines is it is persistence or recurrence of fever 36 hours after the completion of the initial IVIG infusion. And what is the most important for IVIG resistance is not the fever, but that it is associated with an increased risk of coronary artery aneurysms. So our objective is to get rid of the fever, and our ultimate goal and the primary goal is prevent the development of coronary artery aneurysms. So there are two things. One is actual IVIG resistance, is that when we give IVIG to a child and he or an adult even, and the fever does not go down or it recurs. So it is actual IVIG resistance. And there are studies and there are scoring systems, especially in Japan, where they predict IVIG resistance. Is that even before you administer IVIG, you know from the scoring system that this child or this adult is at high risk of getting IVIG resistance. But having the opportunity of working with Sir, so as incomplete KD is not equals to atypical KD, similarly actual IVIG resistance does not mean risk of IVIG resistance. And when we use additional therapy for children or adults who are at risk of IVIG resistance, so it is preemptive or primary treatment intensification. So I will not be discussing this part. I will be very briefly discussing the evidence behind treatment for IVIG resistance. So one thing, when we have a patient with IVIG resistance, it is always an opportunity to revise our diagnosis, to revisit our diagnosis. So in our study, we showed that recurrence of fever or the persistence of fever helped diagnose neoplasms in this cohort of children with KD who developed or had malignancy. So the most important thing is IVIG resistance, which helped diagnose an associated or an alternative condition. So similarly, if IVIG resistance is there, we should give a thought that this child may have systemic GIA, this child may have an autoinflammatory syndrome, and as we saw in the MIS-C in the pandemic, so many cases we gave steroids and then they turned up to have tuberculosis or some other infection. So it is a good opportunity to help us revisit and revise our diagnosis as needed. So the treatment options four main treatment options is that we repeat an IVIG, or we give intravenous methylprednisolone, we give infliximab, and then there are other therapeutic modalities. So discussing the best trial in the business first. So this is the KidCare trial, and perhaps this is the best evidence we have thus far for treatment of IVIG resistance. So this is from Dr. Jane Burns and the collaborators in the US. So they had nearly 50 patients in each arm, which they randomized, and it was a block randomization and age and sex-based randomization. So they assigned nearly 50 patients to infliximab and another 50 patients for a second IVIG infusion. And it was a crossover trial, so those who failed either of the treatment arms, they were crossed over to the second arm. So the primary outcome measure here was resolution of fever at 24 hours after the initiation of treatment. So treatment initiation was taken as time 0, and then the primary endpoint was after 1 day or 24 hours, who all became afebrile. And there should have been no reoccurrence of fever for the next 7 days. And the secondary outcome measures were duration of fever, hospitalization, the coronary outcomes, and the changes in the inflammatory parameters. So as we can see, there was crossover. So patients who did not respond to infliximab were crossed over to IVIG, and those who did not respond to second IVIG infusion were crossed over to infliximab. And then, as I told previously, 2 patients discontinued treatment because one was diagnosed with systemic GI. So when we have IVIG resistance, diagnostically we may put some other differentials also. Okay, so in this study, they used 10 milligram per kg of infliximab, and it was used without pre-medication, and it was given over 2 hours. Okay. So what was the primary outcome? As the slide shows, in nearly 3/4 of the patients receiving infliximab, there was defervescence of fever at 24 hours. So the primary outcome was met in it was 77%. And in the IVIG group, it was around about 51%. So there was a threefold higher chance of getting fever defervescence with infliximab. And then, as is shown below slide, so the duration of fever and the duration of hospital stay was lesser in the infliximab arm as compared to the second IVIG arm. However, there was no difference in markers of inflammation and coronary outcomes. And again, when the trial authors looked at the adverse events, so infliximab did better and the risk of adverse events was lesser. So, based on the apparent results of the trial, we can easily say that the boxing match between infliximab and the second IVIG infusion has been won by infliximab. But since this is the best evidence in the business, I would like to have some critical comments also. So one thing, when we define IVIG resistance, we define it as fever persistence after 36 hours of completion of therapy. But here, they defined resolution of fever at 24 hours after initiation of treatment. So infliximab is administered in 2 hours, so infliximab then has 22 hours to act. However, IVIG was given in 10 to 12 hours, then IVIG only had 12 hours to show its effect. So this may have created a bias because we know IVIG takes time in showing its effect. Okay, and again, when they enroll children or adolescents up to 17 years of age, so if you have a 50 kg child or an adolescent, giving 2 grams per kg of IVIG in 12 hours may be a big deal. It may not be possible. And the secondary outcome, and in fact, perhaps this is the outcome we all must look for, is coronary artery aneurysms. So, in one of the 50 patients in the infliximab group had coronary artery aneurysms at baseline, and in the second IVIG group, we had 7 out of 49 patients who had coronary artery aneurysms. So, it seems that at baseline, children in the second IVIG group had a more severe disease, which is reflected in the degree of coronary artery involvement. And then after completion of the study, 5 more developed coronary artery aneurysms in the infliximab arm, And out of 7 in the second IVIG arm, 3 improved, and we had only 4 left with coronary artery aneurysms. So although post-treatment it was not statistically significant, but this is a very important thing to look at. And then this kid who had coronary artery aneurysms and received infliximab, he progressed to have a coronary artery Z score of 15. So he or she went on to develop giant coronary aneurysms. So again, looking deeply into the adverse events, so these were the adverse events which were seen only in the infliximab arm. So we had pancreatitis, color blindness, and DRESS. So imagine giving infliximab to a child and he develops color blindness or pancreatitis. So these were the caveats in the study. So this raises a question that whether a second IVIG was given a fair chance or not. So it could just have been a punching bag, and it was not given the chance to fight infliximab. Okay. So this is another study from the same collaborators. This is not related to our topic, but in this study they used infliximab for treatment intensification. So just 2 things I would like to highlight is that in this study they defined persist. For example, they had to define IVIG or IVIG plus infliximab resistance. So they waited 24 hours after the end of the second IVIG infusion. But in the previous trial from the same group of collaborators, they just timed it from the beginning of the therapy. So the previous study may have created unwanted bias. Again, if we look at the results, the treatment resistance in the 2 arms, in the arms receiving infliximab plus IVIG as the primary therapy versus placebo and IVIG, so the risk of treatment resistance was not significantly different. However, infliximab resulted in a better defervescence of fever. Again, the coronary outcomes were similar in both the groups, although the Z score change difference was statistically significant. So again, since I see a lot of viral infections at my place, so I always have to counsel that fever is a good thing and the child will improve and we don't need to give antibiotics. So here, the important thing that infliximab results is defervescence of fever, which is good. But anyways, if it had to defervescence had to occur after 2 days, it would not be a big deal. It may not be a big deal. As far as coronary artery outcomes are concerned, there is no significant difference. So there is another study this is from Japan. So this has a much smaller sample size. So only 31 patients were enrolled in the study. So nearly half received either of the treatment groups. One was treated with infliximab and second was IVIG. And again, here the different endpoint was used. It was fever defervescence had to occur within 48 hours. So they waited around 24 hours more than the previous trial. So again, as we can see, fever defervescence was fast. It was better in the infliximab arm, and it was faster in the infliximab arm. But again, in this study, they used IVIG over 20 hours. So as we can see, this is 20 hours. So ideally it should have been timed after completion of either of the therapies, but it was timed at the beginning of the therapies, which may have created this difference. However, anyways, at the end, the fever defervescence was higher. But the difference there was no change in the coronary outcomes. So these are the 2 best studies as far as infliximab is concerned, as far as the study quality and the study numbers are concerned. So one thing we can infer is infliximab results in a better defervescence of fever, which does not impact the outcome, which is coronary artery aneurysms. Okay, so next, moving on to the next treatment option, it is intravenous methylprednisolone. So I'll be just discussing 2 trials briefly. So this is a trial from China. They used methylprednisolone 15 mg per kg for 3 days, and they did not give any further steroids. And one important thing which was different as compared to previous trial was that the basic labs were measured before treatment and 1 week after retreatment. So they were sampled again at 7 days. And then they assessed at the long-term coronary outcomes. Okay, So as we can see, the fever duration was lower in the methylprednisolone arm, but the duration of hospital stay was similar. However, there was a higher readmission rate in the methylprednisolone arm because fever had effervescence, but the child had fever again, so they had to be readmitted. And in the long term, the coronary artery aneurysms were significantly higher in the methylprednisolone arm. So methylprednisolone resulted in earlier effervescence of fever, but then there was subsequent recurrence and then a higher risk of coronary artery aneurysms. So this is another study on methylprednisolone. This is just an observational study in which they used methylprednisolone for IVIG resistant KD, and additional IVIG was only given if the patient did not consent. So they did not intend to give second IVIGs, they just intended to give methylprednisolone. And then for IV methylprednisolone resistance, there was no time cutoff, but for IVIG it was within 36 hours of additional IVIG treatment. So the responders were higher in the methylprednisolone group, but then the number of patients who required therapy, third line therapy, was higher. So this again was similar to the previous study, that fever defervescence occurred, but then there was again recurrence of fever meriting third line therapy. And IVIG was given just at 1 to 2. So in some patients it was 1 gram per kg and in some it was 2 gram per kg. And then what they noted was that the days of third line therapy were higher in methylprednisolone arm as compared to the additional IVIG gram. And the ultimate resolution of fever was at a greater duration of time. And then what the study authors had their conclusion was the fever resolved initially, but then it recurred and it delayed the therapeutic decisions and the final resolution of fever. Okay, so I'll only be discussing one more trial. So this is not a comparator trial, this is a safety trial in which IVIG was used in 16 patients with resistant
Dr. Akib, I think you can wind up.
It's the last slide. This is the last slide. So, so they noted that this treatment with anakinra resulted in better coronary outcomes, and in majority of the patients, they were afebrile after institution of. So this is the Kawasaki trial. This is not a comparative trial. This is just safety and efficacy trial for anakinra. So thank you so much for your patient listening.
Thank you, Dr. Akib. You took us beautifully through the logic and the evidence for the treatment options that we have in IVIG resistant KD. For want of time, I think we can have maybe one question if anyone has a question for him. Yes.
But recently I had a case, a 1.5 month male infant diagnosed with KD with coronary aneurysms. Z-score was round about 8.5 or 10, I don't remember. So I gave infliximab. At the age of 5 months, he comes back with hepatosplenomegaly, fever and hydrocephalus. So any
I don't
suggestions from your side, or
two
have
things.
you come
One
across?
was regarding the dose which was discussed in the morning also. So in the trial, the kid care trial, when it was given after IVIG, the dose was 10 mg per kg without pre-medication. But in the other intensification trial, when it was given before IVIG, it was 5 mg per kg with pre-medication. So that is a difference. So IVIG administration affects the pharmacokinetics of infliximab. So you may need to have higher doses. Regarding screening for TB, I think two things in my mind. One is we are giving just one dose, and we may not have the time to evaluate also when we are treating for IVIG resistance. And then I told, if we are having an alternate differential in our mind, it is better to do a TB workup also. And then risk, I am not aware of any study which has evaluated risk of TB reactivation after a single dose of infliximab.
So then I came across some studies wherein some it was an older child, a single dose of infliximab, after a single dose, an IBD child had developed hydrocephalus.
Okay, so I am not aware of it.
Share it.
But again, I told, when we are treating IVIG resistance, we will have to be much more alert.
No. This was not IVIG resistance. It was primary intensification at 1.5 months.
So I don't know, given the burden of tuberculosis, we may encounter such cases, but single case reports or single experiences, I think we'll need much greater evidence to have a conclusion, a clinical conclusion. Single experiences can be very exciting, very strange and eccentric also sometimes, including mine also. It's not, single observations don't make guidelines.
So thank you, Dr. Akib, for that wonderful talk. Thank you so much.
Requesting Patra sir to hand out the mementos to our speaker and chairpersons. Let's welcome our next speaker, Dr. Shikha Agarwal, consultant and pediatric rheumatologist in Navi Mumbai, to deliver her talk on preemptive treatment augmentation of Kawasaki disease. This session will be chaired by Dr. Alka Singh, HOD at NMCH, and Dr. C.B. Kumar, ex-professor, PMCH.
Good afternoon. First of all, I would like to thank the organizers for inviting me to this prestigious 7th National Conference for Kawasaki disease. Since morning we are talking about the awareness of Kawasaki disease, but I think we should be assured, because nowadays there is so much of awareness that our students first think of Kawasaki disease before simple things like measles and other viral infections. So I think that part we have, that stage we have crossed. For this session, we have Dr. Shikha Agarwal as the speaker. She is a consultant pediatrician with special interest in pediatric rheumatology. And can we have the, she is the founder of Pediatric Rheumatology Expert Practice Clinic at Nanavati Max Super Speciality Hospital, Surya Hospital, PD Hinduja Hospital, BJ Wadia Hospital for Children. She has several publications and written chapters in books, and she has been faculty at multiple pediatric rheumatology annual conferences. She was the secretary. She is the secretary of IAP Mumbai 2024, EB member IAP Mumbai 22-23, and EB member Pediatric Rheumatology Society of India 23-24. So, Dr. Shikha, you can start your talk.
Thank you so much, ma'am, for your kind introduction, and thank you organizers for giving me this opportunity to present this important topic, which is preemptive treatment augmentation in case of Kawasaki disease. So I'd like to begin my talk with my first case, which I saw as a resident. She was a 3-year-old girl child, presented like a typical case of Kawasaki disease, had fever, rash, redness of the lips, and the first 2D echo which was done, which showed dilatation of the left main coronary artery and the right coronary artery. So 14 years back, she was given the IVIG along with aspirin. After that, 3 days later, we realized that she had persistent inflammation, and after which she was given infliximab. And later she went on to develop mid-LAD large aneurysm along with thrombus. So this is the child who had a dilated LAD with a giant aneurysm. Okay. So this case, if we see, which I saw 14 years back, leads us to some ruffling questions in our mind. Should ongoing inflammation be reduced early? Could it have been reduced early in this patient? If yes, which subset of patients do we consider where we need this treatment intensification? And if we do the treatment intensification, with what molecule do we do that? Do we have any recommendations now after 14 years that could say us that what has to be done in which subset of patients, and what actually boils down to actual practice? So how the fire within can be fought at this stage? That's the important question, or the burning question that we all have in our minds. So let's see one by one. Why do we really need to act? As already been seen by so many presentations throughout the day, we know that if untreated, 15 to 30% of patients of Kawasaki disease may develop coronary artery abnormalities. But does IVIG give answers to all these? So even if treated with IVIG, 3 to 5% of cases can still go on to develop coronary artery abnormalities. And in infants, even if the 2D echo shows an initial normal coronaries, it has been seen that after 8 weeks, 18% of patients can still develop coronary artery abnormalities. So we really need to act. That's what we understand. But on whom? Can we foresee that these are subset of patients who would need a preemptive treatment? In the previous talk, Dr. Akib clearly showed us that IVIG resistance can develop and what can we do with that. But can we predict beforehand intensification? So there are certain factors. Age. It has been seen that less than 6 months, a case of Kawasaki disease, there are 43% of chances that this child can develop a coronary artery abnormality. Gender. So males have been seen to be more prone to develop a coronary artery abnormality, 23% versus 17%. A delay in diagnosis. So a delay in diagnosis of more than 10 days is considered that there are chances of coronary artery abnormalities. Incomplete or atypical presentation. An initial echo finding when we first diagnose as Kawasaki disease, and an initial echo finding which shows dilated coronaries of more than equal to 2.5 Z-scores have a more chance of developing coronary artery abnormality in the long term. And complicated cases like macrophage activation or Kawasaki disease shock syndrome, they have more chances of developing a coronary artery abnormality. So do all these subset of patients need an intensification, or do we have any scoring systems which can guide us to resistance also, or a preemptive treatment? So yes, there are certain systems. So Kobayashi score, Ekami score are the few scores who have certain parameters. So in Kobayashi we have 7 parameters, a total of 11 points, and if it's more than equal to 5, then the chances of IVIG resistance is more, and these are the patients who can be given a preemptive treatment intensification, which includes sodium values, timing of IVIG given, AST, neutrophil ratio, the CD active protein, platelet counts, and an age which is less than equal to 12 months. Coming to the molecules that we can use, so steroids. It was long believed since the study by Dr. Kato in 1979, where he showed that 65% of patients who received steroid developed a coronary artery aneurysm, but it was a pre-IVIG era. So for decades steroid was not used. But in 2012 came the RAISE trial, RCT, to assess immunoglobulin plus steroid efficacy in patients with Kawasaki disease, which gave us new insights, and our belief got reframed that steroids can be used and is useful as a primary intensification therapy in cases of Kawasaki disease. Subsequent to this, we have had multiple studies which have shown that in Kawasaki, steroid is a potent anti-inflammatory molecule which can be used for treatment intensification, methylprednisolone or prednisolone, and usually what has been used in the RAISE trial is commonly used. So 2 mg per kg in 3 divided doses IV for 3 days, followed by oral prednisolone, which is tapered over 2 to 3 weeks, is being recommended by certain guidelines. The next molecule is infliximab, which has been in detail discussed by Dr. Akib for IVIG resistant, but it has been also seen that it can be used for primary intensification as well. So by the study in 2014 by Tremolo et al. Studied primary intensification with IVIG and infliximab and showed that there was better reduction in fever duration, reduction in inflammatory markers, the LED coronary artery Z-scores, and elimination of IVIG infusion reactions as well. So infliximab can also be used for primary intensification in cases of Kawasaki disease. The dose, as discussed, 5 mg per kg, which was initially used, is now recommended to be 10 mg per kg, a single time dose for primary intensification. There has been other molecules also which have been studied, cyclosporin, etanercept and anakinra as well. So what are the recommendations that we have? There are 3 recommendations. One by the American Heart Association, which says that if you have a high-risk patient, a patient with less than 6 months of age, or if the first echocardiography is showing a Z-score of more than 2.5, you can do a primary intensification of that patient, which can be prednisolone, that is steroid, or infliximab, that can be used at a dose of 10 mg per kg, or prednisolone like it has been used by the RACE trial. The second is the recommendations from the Japanese Society, which again scores the patient according to the risk scoring, and if the risk score is high, you can start the child on steroid starting at 2 mg per kg and tapering off as discussed, or cyclosporin for 5 mg per kg per day for 5 days with a high risk Kobayashi score. They also have recommended that if there is a high risk Agami or Sano score, IV methylprednisolone can be used for primary intensification. The third is the European SHARE guidelines, which says if there is severe Kawasaki disease with Kobayashi score of more than 5, with HLH, Kawasaki-Sox syndrome, infants or initial coronary artery aneurysm, then you can use steroid as per the RACE trial dosage, which can be done for primary intensification. So are we still there? The question still exists. So along with IVIG and aspirin, I think that is the most commonly thing that is still being used by pediatricians to treat Kawasaki disease. So a few weeks back, I had a case of Kawasaki disease which was referred, which was initially given 400 mg per kg of IVIG for 3 days. So this is the patient's just documentation that which said that 400 mg was given with 3 days along with aspirin, and then in view of persistent fever and coronary dilatation, the child was referred to our center. So the knowledge is there, the facts are sound, but are the actions truly profound is still the question that each one of us have in this audience. Thank you. And I think the organizers can thank me for saving their 4 minutes of time.
So nobody.
Question from the audience, please.
Okay. Mic दीजिए वहाँ पे.
Yes. So head-to-head trials between infliximab and steroid, I don't think so. We have enough guidelines to say that. It is in Kawasaki disease very individualized or institute-based practice which happens to choose the molecule that we use. In my practice, if you see, I see more in a government kind of institute, so steroid is very commonly used molecule. If I see in an institute where affordability is not a factor and a lot of things have to be considered, then infliximab. So of course your question is very valid, that there is no head-to-head comparison between these two, and even cyclosporin, which has been recommended, is not used very commonly.
Whether it really has made a difference, whereas from Kobayashi and group, which definitely steroids are
advantageous.
Yes, they have shown their efficacy.
No, so saying that the trials which have used infliximab, they also have shown the efficacy, not
in
as
terms
much
of defervescence, but never in terms of improvement
LAD
of CA.
aneurysms, yes.
Thank you, Dr. Shikha, for your very crisp presentation. I have one question because you are a pediatric rheumatologist. Even joints can be involved in Kawasaki disease, and as far as my knowledge goes, they are most cases IVIG resistant. Then what do you use in such cases?
Ma'am, musculoskeletal presentation is a part of the whole Kawasaki disease clinical symptoms, which can happen later also once we have treated. So usually the same protocol that we use for treatment of Kawasaki disease is used for those patients as well.
Thank you very much.
Thank you so much.
Okay, you have a question? comment actually, Sagar sir. The infliximab trials that they say that the results were very comparable to IVIG, but then if we see the number of patients who had coronary artery aneurysms, majority of them were mostly small. The number who had a medium or large was so few. In our setup, we do have small, but we also have a higher number of medium and small, giant ones which do respond to infliximab. So maybe that needs to be looked into.
His question was head-to-head trials between steroid and infliximab. That's what I understood.
See, my only concern is if we are in a sector where the disease is not in large numbers, that's a problem. Until we do head-to-head studies, we can't come to this conclusion. Second thing is, once we start loving a molecule or a drug, we start using it and patients get better. We are never sure whether the drug made a difference or is it the natural course of the disease. So until you have two groups who have treated it differently and produced different results, I think that question is...
Thank you so much. Thank you, Chairperson.
Thank you, ma'am, for shedding light on such an important aspect of the disease. I'd like to request Dr. Pratap Patra sir to felicitate the speaker and the chairpersons. Now we have a small change in our schedule. Our next program is going to be the open forum on imaging and Kawasaki disease. The speakers for the session would be Dr. Debadatta Mukhopadhyay, pediatric cardiologist, Kolkata; Dr. Amitabha Chattopadhyay, pediatric cardiologist, Kolkata; Dr. Murugan Sudhakar, associate professor, CMC Vellore; Dr. Supreet Basu, assistant professor, Department of Immunology, IPG MER and SSKM Hospital, Kolkata. The session will be chaired by Dr. Suparna Guha, Professor, Vivekananda Institute of Medical Sciences, Kolkata, and Dr. Anupam Bambani, Additional Professor, Department of Cardiology, AIIMS, Patna.
Shall we start? This screen has to be... You should see the screen. So hello and good evening everyone. I think the session has been so this will be an open forum. The main idea will be that we'll be putting forward some questions to the panelists and it will be open to the house. Any question which the house can ask, we are free to it, but we will have some guidelines or outlines as to how we should proceed. We'll start. So I have on my left Dr. Supreet Basu. He is from SSK Medical College, Kolkata, assistant professor. Dr. Murugan, he is also an assistant professor from CMC Vellore. Madam is there, Dr. Anupam Bambani, and she is from AIIMS Patna. Myself from VIMS. We have Dr. Amitabha Chattopadhyay from Narayana Institute, and then we have Dr. Debadatta Mukhopadhyay. She is also from Kolkata. So we start. Can we have the presentation? We have loaded. So regarding imaging, if you have any questions, you can put forward. the audience. Otherwise, if not, we'll set the ball rolling with the first. Okay. Someone controls this. Shall I go there? So we are all aware of the coronary conundrum where 20 to 25% develop aneurysms. With treatment, it's less than 5%, and 5% of acute coronary events in adults less than 40 years of age can be attributed to KD. And in the morning session, we have heard about the stages of the coronary artery aneurysms. So the questions are now to all four of you is how early can we pick up these? Because we all know KD is a clinical diagnosis. When in the morning, Dr. Priyankar was saying that you have to think KD so as to diagnose KD. We do not usually depend upon the investigations, but to Dr. Supreet Basu. So do you think you need imaging to diagnose KD?
Hello. Yeah. Kawasaki disease is completely a clinical diagnosis. There is no definitive test for diagnosis of Kawasaki disease, and echo is a useful adjunct which help in confirmation of the diagnosis or to augment therapy, and it is said that treatment should not be delayed if echo is unavailable, and we should not delay the therapy. We will start the therapy and we will do echo as and when available.
Okay. So in a nutshell, echocardiography definitely helps us. It is a supplementary tool and not the tool for diagnosis of KD. So do we believe that old is gold, that echocardiography is the modality where to diagnose some cases of incomplete or atypical KD? Do you think it holds true?
Yes, of course. It is the first examination that we do to find out the coronary involvement, but at the same time it has its own fallacies. For that, can we have the next slides, please? As you know, a picture speaks 1,000 words. On the left hand side, we can see the still picture of the coronaries that we see on echocardiography. That is, there's a very this was a very small child who had this is a very small child, about 10 months old, and here is the dilated ectatic left anterior descending artery, and the beginning is the proximal part is quite narrow, and I think this part, if you can see again, it's a very profusely ectatic in the color views. This is what I see. But on the right, you can see the extensive involvement of the LAD, as Dr. Singhal had shown. And this is a beautiful coronary CT angio done in PGI Chandigarh by Dr. Singhal, showing the proximal stenosis as well as the extensive involvement of the LAD as well as the left circumflex. So as was discussed in the morning, sometime, the exact time is not known, but sometime we do need to do a CT angio of the coronaries to detect the extent of involvement in case of multi-vessel involvement, as well as multiple involvements in the same vessels if they are not well visible to us. So under these, or maybe when we are suspecting a thrombus. So it is not only to diagnose, but at the same time to prognosticate and streamline the treatment. And I have just, can we have the next slide, please? So over here you can see this was a child who had got fever, febrile illness with a typical rash, but at the same time we are having a very confusion. The child was unsettled despite the, again please, despite the kind of sedation, but we can see there was this web coming out, which we couldn't understand that whether this was a dilatation of the coronaries or not. So you can see there it looks dilated, but on very, very careful examination on color, I don't know why this picture is coming. We had given the other color pictures as well, but yeah, this one. We can see that on very, very close examination, we can see that the color, that actually the coronaries are not dilated, but they are of normal size. So these are certain fallacies which requires a lot of detailed examination. The next slide, please. I think there was one more with the thrombus, but it isn't showing. Yeah. This one, on the upper one, you can see the one with the huge thrombus in the left main as well as thrombus in the LAD. And here again you can see the thrombus in the LAD. So these things are there. But the lower one over here, just at the bifurcation, it appears as if there's a kind of a, very ecogenic kind of a spike coming out of here. So I don't know, the video is not playing, but this spike, it's very suggestive of a thrombus, but we are not sure whether it's a thrombus or not. So these are the fallacies that we encounter, and then we need extensive imaging.
So mainly you are saying that echocardiography, okay, in the acute stage, it helps us, but there are certain conditions where you are in doubt and you need to do a coronary angiography. That is your understanding?
CT angio, maybe further imaging.
Okay. Like if the child has aneurysms in the distal portion, or if you have multiple segments of a single artery affected or multiple vessels affected, those are the places where you would want more imaging. And as rightly pointed out by the American Heart Association 2017, a Z-score more than 2.5 definitely needs to be investigated by other sophisticated imaging modalities. So now we have a basket full of investigations. So Dr. Murugan, do you want to, so you have CTCA, you have MRCA, you have CAG. So for in the acute stage or in the follow-up, which would be your modality of imaging?
So again, as ma'am had emphasized initially, imaging, the angiograms has been recommended by both 2017 as well as 2024 AHA after the 1 year of the diagnosis. However, there are emerging data, including ours from PGI, about the needity of CT coronary angiograms, especially the lower dose one, after the stabilization in the initial phase. So both has its pros and cons. Like we had a discussion in the morning also. If you have done a CT angio at second week of illness and supposedly the aneurysms are worsening further, then there is no chance of a repeat CT in an acute period, maybe in less than 1 year. So in those situations, echo will remain to be the modality to screen about that worsening aneurysms. Then the question will be like where to keep the CT coronary angiogram in the acute phase. Whereas these guidelines have clearly stated that after 1 year of the disease, a baseline CT coronary angiogram has to be done, and that has to be subsequently followed up depending on the initial as well as the current coronary dilatation that is there in the vessels. That's about CT coronary angiogram. Now, the other concern about the dual source CT coronary angiogram is that not so many centers in India as well as across globe has a facility to do so, and they have the risk of sedation as well as contrast. These are the few limitations that we have before thinking about a coronary angiogram, and most important thing is the radiation. So in those aspects, MR coronary angiogram has a dominance. However, the major setback is the time taken to do the MR angiograms and the sensitivity for coronary vessels. It's not as superior as CT angiogram. That's the limitation of MR angiogram. Yes, invasive angiograms we don't recommend unless they have a major coronary event.
So in a nutshell, in the acute stage, echo is the diagnostic modality supplementary which we can use in some cases. Yes, when the child is stable, like as Dr. Manful was saying in the morning, when the child is stable, we can attempt to do a CTCA. In fact, every child with KD should undergo a CTCA once if the child has got some coronary dilatation. And it is unfortunate that many of the centers, we still do not have the lower radiation ones. We still have to use the high radiation. And MRCA, there are a lot of limitations, and CAG we are not doing at present. So, ma'am, do you want to ask?
Thank you. Yeah, that was very nicely discussed, and we definitely have a lot of limitations of echo. But some of these limitations, I think Dr. Amitava will agree with me, can be overcome or maybe reduced at least by making the echo study more elaborate in more views, and then anterior tangential view in the plaques, some inclination, and making it inferior tangential to focus on the circumflex towards the left posterior AV group. Although definitely these are very difficult and technically not possible in children, although children have better windows compared to adults. So some maybe more elaborate evaluations of echo and very structured approach may disclose.
That can be done, as we were discussing. Sorry, as we were discussing in the morning. The main problem with more or less almost 98 to 99% of the children with Kawasaki disease, they become very cranky. They are very irritable. So before performing the echocardiogram, you have to make sure that you have the coronaries are only thin structures of 2 to 3 millimeters in size. So given the fact that nowadays the machines come with very sophisticated and very streamlined visions and streamlined methodologies, but yet the child has to be absolutely quiet. So we turn to the left and you optimize the picture. The two things in echocardiography which you should stress upon is the optimization of the picture, bringing out the picture, and secondly is the interpretation, as Dr. Devdatta was telling. So bringing out the picture, definitely what Madam is telling, that we have to set up our settings in such a way with a beautiful balance of contrast. Last comes the color code, because in coronaries we mainly use the black and white mode, and thereafter we can compare the adjacent parts, the aneurysms if any. The measurements has to be taken by a zoom method so that we can minimize our chances of errors. And obviously, as I was telling, when you stand at the bank of a river, we can only see as much as our vision goes. So we cannot see the river once it goes beyond our vision. So likewise, when the coronary arteries turn round, we cannot see them anymore. That's the reason there's the point. But as we have heard throughout the day, the maximum number of coronary artery aneurysms maximally occur beyond the proximal 1/3 of any of the coronary arteries. So we are lucky in that time. But at the same time, we should not be missing any coronary artery aneurysms or any changes which are happening beyond the distal parts. There comes the role of these things. But as Madam said, yes, we are absolutely right. Echocardiography still forms the first line of attack. And obviously, if a carefully performed echocardiogram, preferably by the same observer, over a period of time, maybe second or third attempt, shot also, that will be of much beneficial.
In addition, as echo has some limitations, so do you think there is a role of stress imaging in these children?
Yes, madam. Stress imaging. Yeah. So this has two roles. Number one is the prognostication, and number two is the treatment part. Now, where do we do a mitral perfusion? We do not do it regularly. We do it only in selected subjects. All the babies who have all the children who have normal coronaries is routinely we do not do them. The role of a myocardial perfusion or stress echo comes only when they have a documented aneurysm on either a CT or an echocardiogram. Now, prognostically or treatment-wise, more or less, as everyone will agree, more or less the treatment-wise is the same, even if the child has a aneurysm or even if it is an established thrombus, then comes the role of whether we should go actively and do something. If it is an aneurysm, then the treatment protocol will be the same, except that the parents might ask, doctor, you are doing this test, now how would this test differ in the treatment of my child? So there comes that whether if it is a 5-year-old child, would I limit the exercise? Would I tell that the child cannot play? Obviously, this is the next one, prognostication, and the treatment, the second part of the treatment. Here we can protocolize our management in such a way that the child may play on it is very difficult to restrain a 5-year-old child or even a 10-year-old child. But they should not be undertaking any sort of deep isometric exercises which can disturb the cardiac milieu
and obviously can increase the afterload of the heart, which can lead to some consequences.
So, what are the investigations which you do to study the myocardial perfusion, and when do you do them?
The first one which we ask is how is the child behaving at home? Because it is very difficult to describe a child if he is having ischemia of the heart. Mostly they will be irritable. We take a very careful history, increased sweating, not feeding well and not feeling well. Secondly, we take them for a 6-minute walk test, which is offhand we can do it in the ward only, in the OPD. 6-minute walk test under supervision. Thereafter, we go for an exercise test if the child can perform it. If not, we go for a chemical, there is a dobutamine exercise test, which can be done if the baby is quiet and is cooperative. Thereafter comes the PET scan. Is it easy to do a PET scan rather than a SPECT? Because the SPECT is not available everywhere. At the CMRI also, the SPECT and CMRI are slightly sophisticated. Not all centers have it, but we have a PET and we can go for a PET study if the child really demands it. In this order we usually go.
So I think this was one of your patients in whom you did the perfusion study.
Yes, this was the patient who actually presented with dilated cardiomyopathy, and we were not finding the coronary artery initially. Thereafter we found that there was a large giant aneurysm completely filled by a totally occluded thrombus. This child underwent a CABG at the age of 7 years because obviously the myocardium was still viable as performed by the stress study, and now he is doing well. He also needed an AICD because he was throwing away ventricular tachycardia at very frequent intervals.
So the take homes is still KD is a clinical diagnosis. You have to think KD when you are diagnosing KD. Your 2D echo, CTCA, all these sophisticated modalities are basically supplementary imaging techniques, and those who have significant coronary aneurysms, multiple distal aneurysms, they usually should deserve a follow-up CTCA. And the future, I think now, is the imaging dual source CT scan, which uses very small radiation. Maybe it will likely become the preferred imaging in the future.
Ma'am, can I add?
Yes.
I just wanted to add that we also check the function, and we have a very basic way of approach to the cardiac function when we see it in the 2D echo. But cardiac MRI and all, they assess the function in a much better way. But when a child has got a very significant aneurysm or even a thrombus, in that case, I think it is important as a pediatric cardiologist that we assess for the regional wall motion abnormality also, which are very typically seen in adults with coronary artery disease. Our eyes as pediatric cardiologists are trained in a different way, but then we have to be aware of that and also check for the regional wall motion abnormalities. And there are other ways also like strain imaging and all, which will be affected in coronary artery disease. And there will be recent machines which are coming up. They have got AIE, and I think that AIE will be giving you very easier ways of calculating the strain and all these newer modalities of assessing, not newer, but more advanced modalities of assessing the function. So I think those will also come up in the recent years as part of assessment of function in these children with abnormal coronaries.
So since this is an open forum, we would like to, yes, Shumantro.
Hello, I am Dr. Shumantro from Kolkata. Once upon a time, a few years back, we knew about the optical coherence tomography in assessing the intravascular status of the coronary arteries. So, what is the status of that OCT? Is it still?
Yes, it is done, definitely. But the lumen, you need a little bit of a higher lumen of the coronary arteries or even the femoral artery from where it is to be inserted. So, in a small child, it is difficult to insert the probe. But I guess in a bigger child, it is easier. It can be done. OCT, it can be done.
Is it really helpful? After all these studies, when are you going to do this?
It is invasive, so probably, as Madam would say, the non-invasive ones will come first.
Is it? Yes, definitely. OCT is a very high resolution image, but there is two limitations actually. Number one, because the images are very high frequency. So as we know from our physics classes, is that wavelength and frequency go opposite to each other. So the penetration depth of OCT is smaller. So if the aneurysm is large, OCT can see the images up to about 3 millimeters. But aneurysms, as we know, that giant aneurysms of Kawasaki are more than 8 millimeters. So OCT may not give a very good image of the walls of the aneurysm, and it may miss if there is a layering of thrombus along the dilated aneurysm. Number 2, OCT is done only when the entire blood is displaced by the large amount of injection of contrast during imaging. So contrast amount will also be a limitation, because we have to give the contrast according to the weight of the child. So for smaller children, definitely OCT will have inherent limitations.
Sir, just wanted to ask, so what is your experience with CABG in children with Kawasaki disease? That case you just reported. As far as I know, there are no publications on this aspect, at least from India. So if you have a large cohort, perhaps it would be a good idea to publish, and maybe if you have patients, maybe refer them to you.
The CABG, we have, see, in my career, I have seen 3 children requiring CABG. Two of them were Kawasaki disease, where there was completely occluding thrombus leading to myocardial infarction, but still the myocardium was viable as determined by other tests. They underwent. The third one was hypercholesterolemia with a significant family history, and she had to undergo again CABG at the age of 4 years. So it's not that CABG cannot be done. Mostly it's a venous graft, but they can be put on arterial grafts as well, like the Lima or the Rima, the left internal mammary or the right internal mammary. They can be put. Now, once you do a CABG in a child, the next question is how to maintain it. That is, obviously the baby has to be given the same medications as in adults. Durability of the graft. The grafts, an arterial graft can last a longer time, definitely, but yes, I haven't come across any cohort of CABGs from India where there has been a totality of the children who have received it. My hospital, I have seen only 3 in a 20-year period. But definitely, when you collect the cohorts, it will be a good study, that much I can say. But until now, they are doing quite well. And we have periodic checkups of the grafts. Our children, we had checkups at 5 years and 10 years. The grafts are patent and they are functioning well.
That's a remarkable finding. I think you should publish it, sir, because even 3 is a big number.
3 is a big number.
Compared to 0.
Yes.
Any questions or any suggestions from the house? Yeah, Arjun, you have a question?
So one thing is calcium scoring in CTCA. So when it should be done, after how many years, or should it be done at initial CTCA if there is giant coronary artery aneurysm? And what are the implications of calcium scoring in CT coronary angiography? And there are some strain tests like speckled. So what are the indications? And I would like to know that regarding the availability of these tests in India. And
So in response to your first question, calcium scoring has good correlation with atherosclerotic burden. But with Kawasaki aneurysms, although we know that when Kawasaki vasculitis heals, it does cause calcifications, but how is the correlation with aneurysms and further ischemic events? We don't know, at least I don't know. So what is the value of calcium scores in deciding the future course of action for Kawasaki patients? I'm not in a position to comment. The second question, that was about strain imaging, speckle tracking and strain imaging. So I think one of us briefly mentioned also. So strain imaging is a very, very specific test for knowing the regional wall motion abnormalities as well as LV function. Because LV dysfunction is also, although less common, it is also a part of the Kawasaki involvement of the heart. That also helps. And maybe in follow-up studies, it is a more specific test for knowing that the function is improving or deteriorating. for that, speckle tracking is definitely a good image, is a good function, is a good test. And as she said, that AI involvement is also now coming up with the Philips has introduced something in their QLab software, that AI-based automatic speckle tracking, so that it is more reproducible. So they, for that also is helping us maybe, and it is available very widely now. I think every institute, every teaching institute, I think, has speckle tracking facility, and most of the advanced machines of major companies, they are providing software for doing speckle tracking.
Can I just mention one thing here? In this context, just from an experience, an anecdotal experience, I had gone to present at the Kawasaki Forum in Association of European Pediatric and Cardiology, AEPC, and there the speaker just before me, she spoke on a paper, not on KD but on MISC. She had done the strains on MISC patients and significantly on follow-up, though it was not like grossly abnormal, but even the absolute values post the disease in the follow-up, the absolute values of the strain had significantly come down. So this was one study which I remember.
They did routinely for all the patients with coronary artery involvement?
Yes, they had done the strain for all the patients with coronary artery involvement in MISC, and they found that on follow-up, they had significantly come down.
Actually, the idea of this test which you are mentioning is to diagnose them as early as possible. So the traditional methods, like to begin with the ejection fraction, fractional shortening, Simpson's method and all these things, they usually pick up the dysfunction a bit later. But speckle track and everything, they will pick up much earlier. Not only for Kawasaki's, like any other congenital or myopathies, for example, say Duchenne's myopathy and all, the patients, they come in batches, they have the speckle tracking done so that the treatment can be modified much earlier.
For detailed analysis, it requires a child to be a little quiet and very detailed analysis, and the temporal profile is more important than the.
So I think we are running short of time. Okay, Sagar, we'll allow you one question.
Yeah, this is from a clinician. A child with aneurysms in follow-up, functional imaging, and we have CTCA. What do you recommend and when?
So regarding this CT coronary angiogram, sir, so the AHA has given a risk stratification into 5 groups. It's not for less than 2.5. For medium to large giant aneurysms, so depending on their status in the follow-up, either they remain as the same or they regress to the medium or smaller one, they have a duration specific. Like anywhere between 2 to 5 years, they are advising for a CT coronary angiogram. Regarding the stress images, they advise if the child is more than 7 years, you go for a exercise and echo. If it is less than that, you may decide on the imaging as it was discussed. However, the duration, again, it is for the giant most favorably than the regressed ones. And the duration, again, it's between 3 to 5 years. But in our setting, I discussed with them also, we are not doing that much of these functional studies till now here in India. So that's what I feel actually.
So basically, as of now, CTCA, Sagar, for all aneurysms more than 2.5, functional if the child becomes symptomatic with a giant aneurysm 5 years or 7 years down the line. Isn't it, Amitav? So I think answers all our questions so far. So we'll wrap up because the organizers are warning me from there. Thank you.
Thanks to all the speakers for such a brainstorming session. It gave us a lot of information to reflect upon. I would like to request Dr. Patra sir to felicitate all the speakers and the chairpersons. Next upon, we have an open forum on diagnosis and treatment of Kawasaki disease. The speakers for the session would be Dr. Jigna Bhatia, Assistant Professor, ICH Kolkata, Dr. Debasis Patro, Rheumatologist, Some Hospital, Bhubaneswar, Dr. Johnson Namayarkapam, Assistant Professor, Medical College, Manipur. The session will be chaired by Dr. Rakesh Pilania, Assistant Professor, PGI Chandigarh, and Dr. Manful Singhal, Professor, Department of Radiology, PGI Chandigarh.
So good evening all. So it was said that session will be chaired by me and Dr. Manful Singhal, but we have reversed the role and we'll be chairing the session by all three young colleagues. And what we have is that in next 15 minutes we'll have 3 case scenario, and these are live case scenario, like real life case scenario, and how the things have unfolded during that time and what are the controversies during the diagnosis and management. We will be able to cover few things only. So I'll start with Dr. Jigna Bhatia. So this is a 1-year-old girl child who had a high-grade fever for last 5 days. And she came with swelling over the anterior part of the neck for 2 days. And as commonly we see as a fever and cervical lymphadenopathy, the first differential by pediatrician would be a bacterial lymphadenitis. So then she received oral antibiotics and fever was still present after 5 days of antimicrobials. And this was the clinical examination which you can appreciate at this point of time. Systemic examination was within normal limit and there was no other features to suggest any other thing at that point of time. So investigation which done at that time suggestive of anemia, counts were little bit higher than some neutrophilic predominance and platelets were normalist type and the C-reactive protein were elevated, which is more than 100. Keeping the point that oral antimicrobial is not working, and I am taking the clue from the Dr. Satish Loganathan. He is a ID specialist who are fighting with IDs as a KD minded person. So they have given several more antibiotics, IV ceftriaxone and IV cloxacillin. Then day 3 of admission, child had developed dysphagia and stridor after IV antibiotic of 48 hours. So the MRI was done at that point of time and was showing that was a retropharyngeal phlegmon and there was an anterior mediastinal mass which was mostly a lymph nodal mass only. Again, keeping the possibility of that is a bacterial lymphadenitis which has anterior mediastinal mass. So keeping possibility that if one antibiotic is not working but cultures are still sterile and hemoglobin has further down and counts have little bit same, but platelets has risen to 5.5 lakhs. And one more antibiotics, which usually I'm not comfortable with these type of antimicrobial. Once I'm like something ceftriaxone, like all these things, and then vancomycin, and then still if it is going beyond, then probably we don't understand all these things. But teicoplanin has been started. So, Dr. Jigna, can you just put at that point of time that will you be adding more like unknown like antibiotics like which we have like teicoplanin, minocycline, and all these things, or you will be thinking in a different direction? So the clinician like thought that this is the time we should invite a rheumatologist, and so they have asked Jigna to look into that. So how will you approach, and like now how would you differently think at this point of time where fever is still persistent? We have given several antimicrobials, and we have changed many antimicrobials, and we have done imaging also, and which is suggestive more of like retropharyngeal phlegm. But so how do you go for that?
Yes, so fever for more than 5 days, it's already repeated quite a number of times today that not responding to IV antibiotics. KD should be thought, and this is something, note first KD, that we should be thinking of fever with lymphadenopathy without any other signs and symptoms. So the pointers here were the fact that the persistence of fever and the rising platelet counts. Because anterior mediastinal mass is still relatively unknown, we know more of retropharyngeal abscess being a mimicker, or like more of lateral side of the swelling, but anterior mediastinitis is quite rare, and the fever also subsided with teicoplanin. We can maybe observe and maybe repeat and see if the platelet count is rising, or maybe and see what the course goes in the next couple of days.
So you are keeping a possibility of Kawasaki disease, which is incomplete, and this is a Dr. Ayusawa has also talked about the node first KD, which we have it's more in older children, typically in more older children, and so which possibility should be considered here. So on day 7, fever had again recurred, and teicoplanin was teicoplanin had just worked for 24 or 48 hours, and then again fever was again coming. So now what should we do? So the investigation suggests that anemia, which was hovering around 8.6, counts has risen now to 18,000, and differential counts are more of neutrophilic predominance, and CRP is because of teicoplanin has increased, or is because of other things like it's working?
Obviously, now we have to come back to what we are discussing here and think of KD, more of KD at this point.
So why at this point of time, what are the features which are more convincing, and you are more sure that we are dealing with?
I think the fever, again, not responded to antibiotics. The platelets have gone up. I think, but if it was an infective cause, the platelets should have gone down. Maybe the CRP should have settled.
So again, the good thing is that we have cultures all the times, and we can send the cultures again and again. So if the cultures are sterile most of the time, possibly we have to revise our diagnosis. So Dr. Akif was also saying that when we think of IVIG resistance, we should revise our diagnosis. So when we treat any fever, we should revise diagnosis every day basically. So it is not that all fevers are including it's sepsis or all fevers are Kawasaki disease, but we have to revise our diagnosis whenever we are dealing with these things. So the fever, persisting, rising platelet, and platelet counts of 8 lakhs is almost, you are touching to the Kawasaki disease. And then echocardiography has done on day 9 of hospital stay rather. So which was on day 9, one more things which was reassuring for the rheumatologist was something has appeared, and it was BCG site reactivation. So again, it is almost pathognomonic, and I will come to that in the next case. So child was started on intravenous immunoglobulin, aspirin was also added. At this point of time, we were sure that we are dealing with Kawasaki disease, and echo was done, which was suggestive of moderate size of aneurysm in left main coronary artery. And at this point of time, because we have heated argument that what should be the second line, whether it is a steroid, infliximab, and we have comfort with some medications like now we have also comfort with infliximab, and possibly they have also given infliximab 10 milligram per kilo. So 48 hours after IVIG plus infliximab, coronary artery abnormalities are there. CRP has decreased, but it's not, still it's like 67. We like now as a treatment intensification, we have given steroids also. So I want to ask question, Jigna, again, that CRP is still high in these situations. So how far you have to go for the like now CRP to come down? Should be 0, or you are waiting just for a fever should be subside? And second, because you can include your answer in this only, that what are the challenges when you diagnosing and treating these types of patients in daily practices, and which will help in tomorrow when they go to their clinics, that how far we can go for that like diagnosing Kawasaki disease in these situations.
Regarding CRP, I think in our institute we make it very case-to-case basis. Sometimes if the child is completely fine, and maybe if it has gone down drastically and not an infant, we would not add anything else. But something like this younger child, we have aneurysms, 69, we would not be comfortable. So there's no harm in giving steroids. So sometimes we've even seen that the fever has gone down, the echoes are normal, but the child still has some subtle encephalopathy, there is some mucositis. Then also we prefer adding steroids, considering that if it's a similar situation that the CRP is still high. So there's no harm in adding something for a short duration than not doing anything. And challenges in this kind of situation is the note first KD. Like, it's like, first of all, is trying to argue with the pediatrician regarding antibiotics. That would be a point of discussion. Like, how long what is the protocol? What would be the guidelines here? Do we at all give antibiotics? Because regarding the imaging also, like the radiologist has to be sure and tell us that it's a retropharyngeal edema, and those the typical findings of note first KD rather than a bacterial lymphadenitis. Something like, I think cellulitis was written here. So the confusion arises. So do we really give the full course of an anti-staphylococcal or anti-streptococcal coverage, or do we just stop it? Do we discharge on oral antibiotics? And obviously the diagnosis, it creates a delay in diagnosis. And again we can keep on repeating that fever not responding to antibiotics, rising platelets, rising CRP. These are some pictures commoner pictures of note first KD, the swellings which come up, and the retropharyngeal edema that is there in the MRI findings. So this should help us in keeping KD in mind, that not responding infant, rising platelets, rising CRP, rising total count in serial echocardiography, and imaging in such cases can help us in diagnosing KD.
So basically what Jigna is highlighted in her complex answer is that at the end of day, KD is a clinical diagnosis, and we have to hunt for all the surrogate markers. Because when fever is persisting, platelets are rising, we have to look for the Kawasaki disease. And one more thing is that fever more than 5 days, the differentials, when we have other differential in our basket, the KD should also be there in differentials. It making the diagnosis is easier. So I'll go with the case 2, which is 2-year-old boy who came to Dr. Patro at day 3 of fever with significant irritability and urine routine examination, which is usually early available, and there was a pus cells 30 per high power field and fever, irritability at 2-year-old of child. That the first diagnosis would be urinary tract infection, which is like when you have pyuria. So that diagnosis of UTI was made at that time, and he was given, baby was given antimicrobial and on OPD basis and sent for 10 days of antibiotics, but again fever was persistent. So Dr. Patro, can you just elaborate that urine examination, if there is a fever and pyuria, this is almost sine qua non to UTI, or there are several other things to consider?
Thank you, sir. As already Dr. Satish sir has already shown in the Nelson textbook that that if there is a sterile pyuria, that if it is a less than 1 year or around that age, everyone thinks of UTI first. And we went ahead and did a urine culture also. But we have to tell the pediatricians that if we are thinking of Kawasaki disease in such a background, the pyuria is due to the urethritis. It is, but if you do a suprapubic aspirate and send the urine routine, you will not get the pus cells. So that is how we need to differentiate between the KD versus the other infectious etiology. And in such scenario, if the child goes to any pediatrician, obviously they will hike up the antibiotic from one to another. So the child was initially treated with amoxiclav and then later on switched on to azithromycin.
So whenever you see a pus in urine, it's not always UTI, because if your cultures are sterile, then think before reaching the conclusion for UTI, and it may be provocative, but the most common cause of sterile pyuria is Kawasaki disease. So, but good part is that sometimes symptoms comes again actually because of the disease only, and on day 12 of illness, there was erythema and cracking of lip, periingual desquamation was also present, bilateral bulbar conjunctival injection was also present. But pediatrician thought that it's a part of scarlet fever and that some skin desquamation is occurring at this point of time, and we will give longer duration of antimicrobial at that point in time, and we will send ASO titer. So can you put some light on that how will you differentiate that between the scarlet fever and Kawasaki disease, whether because peeling will occur in also scarlet fever, so how can you say that this is a features of scarlet fever?
Usually in scarlet fever, the peeling is generalized, whereas in Kawasaki disease is usually perineal or periungual, and usually in the peripheries, it is extremities, it is seen. That is first thing. And in scarlet fever, they usually respond to antibiotics, whereas Kawasaki disease, it doesn't respond. The other mimicker may be a measles, which sir had already shown. We have to see the 3 C's, cough, coryza and conjunctivitis. The other possibility is toxic shock syndrome by staff also, because few pediatricians, they also tell that whether it is a TSS in the background and think of staff and hike up the antibiotic. So luckily they thought, unluckily the child was treated with antibiotics for the course by sending an ASO.
So but by this time, like day 18 of illness, fever was persisting, some peeling was there, but one more feature which was seen here is that early Bose line was also there, but some orange-brown chromonokia. This is a brainchild of Professor Priyankar Pal. He's very happy whenever he see chromonokia when someone discuss, because he is the pioneer in orange-brown chromonokia. And that is a very important sign of during the acute and convalescent phase of the Kawasaki disease, which also give a surrogate marker for diagnosis. So further, there was anemia, neutrophilic leukocytosis, CRP was high, ESR was also very high, proBNP was done, that was elevated, and which is also again marker for your differential to reach a diagnosis of Kawasaki disease, and there are proBNP based diagnostic criteria also available. So, but echo was done, which was suggestive of large coronary aneurysm, which is 10 millimeter in left main, proximal RCA 3.7 and medium RCA. So again, CT pulmonary angiography was done at this point of time. So I'll ask question from Professor Singhal that they have done CT pulmonary angiography. So what are the things which you want to avoid at this point of time, and CT pulmonary angiography, whether it is required at this point of time, and what are the pitfalls and what are the problems with CT pulmonary angiography at this point of time?
I think it was a CT coronary angiography rather than a pulmonary angiogram, because acquisition data in pulmonary angiogram has to be in the peak pulmonary arterial phase. I think this was a coronary angiogram. You know, I was discussing with Surjit Singh sir when to label LMCA as abnormal. You know, in echo, there was an aneurysm in the LMCA, but it was silent on whether it was extending into LAD or LCX. In my considerate view, any abnormality in LMCA usually will spill to the proximal osteoproximal segments of LAD and LCX. So, you know, you can do a CT angiogram in this patient, not upfront, but once a child has stabilized. You know, this is the question that is presently asked to me. Now, you know, I can answer that better. If the child is not deteriorating and stable, do a CT angiogram, during any time, maybe less than 1 year. If during the clinical course or during that convalescence phase, if the child is deteriorating, you can consider CT angiogram at that point of time as well.
Thank you, sir, for, I'm sure that you will be highlighting more things in your talk. So on day 19, because at almost 3 weeks has passed and we have still not treated this child for Kawasaki disease because there were several differentials. We have treated with IVIG. We have thought of giving an injection methylprednisolone also. So my question is just, I'll go to directly to the question. So when should you think a primary intensification at, like now in these patients? Like you will just treat inflammation, or when you have these types of coronary artery abnormality at 3 weeks of illness, you will give a primary intensification, or how should we go?
Actually, the child presented to us on the day 18 of illness to our center. So we went ahead and did this. And ideally, primary intensifications should be done because it is a large aneurysm which is 10 mm, which is showing by echo, done by our ma'am, Professor Dr. Anuspandra ma'am, who is here. And we were lucky that we were able to start, the parents were convincing to start upfront IVIG and steroid. But for convincing them to give infliximab, which is another costly drug, and in such a scenario, we should upfront give primary intensification is what my thought process is.
So because child has a giant aneurysms, like by definition 10 millimeter, so we have to start anticoagulation. So like now, what anticoagulation you would start at during this phase, whether oral anticoagulants or injectables, and how long will you want to continue that, and how can you switch over? That may be given just summarize in a.
We usually start the low molecular injection, low molecular weight heparin along with aspirin, and we usually give it for the initial, try to give it for initial 1 year or more so, before we switch over to warfarin, because if you switch over to warfarin, there are many interactions, drug-drug interaction, diet needs to be changed, and we frequently need to monitor the INR to 2 to 3, which rarely happens, and there are many side effects to it. But low molecular weight heparin is very easy to administer. Now it comes as a pen, and we can monitor the factor 10 levels, and we need to keep the levels at 0.5 to 1, adjusting the dose of the low molecular weight heparin.
So thank you, Dr. Patro. Basically, what he has highlighted is that we have to hit hard. We have to hit hard, and like whenever we are having a risk factors, high risk factors, and the low molecular weight heparin we also give, and usually till 5 years of age, low molecular weight heparin is easy to manage actually, because in less than 5 years age, oral anticoagulants are difficult to monitor, difficult to manage. So typically we give in younger children, and till 1 year age, till 1 year of the diagnosis, it's better to give low molecular weight heparin, which is more of easy to monitor, and also there is some local luminoblastic myoblastic proliferation also. So it also prevents the local act on the local as a local anti-inflammatory side in these patients.
Also the requirement of statins.
Yeah.
We have given statin in the child for the
statins are coming in a big way, and they basically both are in acute phase and a long-term phase. So I'll quickly go to the Dr. Johnson, who is coming from the northeast, and he sees more complicated KDs because somehow that the disease which occurs in that phase, even in Kawasaki disease, they develop more chances of coronary artery abnormality. And I know he would agree with me. So this is a 8-month-old girl, infant basically, and fever for 8 days, and there was a history of red and cracked lips, strawberry tongue on day 3 of illness. There was anemia, neutrophilic leukocytosis, platelets were high on higher sides, and ESR was elevated. C-reactive protein was elevated. Urine routine, again, there was a pus cells, and two complicated thing that urine culture was suggestive of Klebsiella pneumoniae. Klebsiella, and it was sensitive to ceftriaxone. So child received IV ceftriaxone for 5 days, and before coming to the Dr. Johnson, he was managed elsewhere, and the antibiotics were given. But somehow, despite we have a urine culture in our hand and antibiotics, we were giving sensitive antibiotics, fever was persistent at this point of time, and the child was referred to Dr. Johnson in medical college. So can you just highlight one more thing that like now when we are having these types of features but they have disappeared on day 3 of illness, how these things can complicate when the child present after 1 week of illness, like how the features, clinical features of Kawasaki disease evolve?
Thank you, sir. So this child, 8 months old girl, actually she was managed in other hospital, and rightly they have given ceftriaxone, and also luckily they also grew Klebsiella and sensitive to ceftriaxone. But in spite of the right antibiotic, the child persists to have fever. Now this picture was shown to me by her mother. So this was there on day 3 of illness, but it got disappeared by day 5 of illness. So mother was quite educated, and they searched in the Google and told the treating doctor that is my child suffering from Kawasaki disease. The treating doctor didn't agree because culture was already positive and keep on giving ceftriaxone. Mother was not satisfied, that's why she came to me. So in such scenario, what we have to think is that Kawasaki disease can be associated with any form of infections, whether virus, whether bacterial, and when you have a growth in urine or in blood, don't stop thinking of Kawasaki there. So when you have a clinical picture suggestive of Kawasaki disease, in the back of your mind, always think of Kawasaki disease. And this another picture, a blurry picture, was again from her mobile, and she was showing this picture to me that this is a BCG site activation. She was saying to me that this is a BCG site activation. So we have to be, patients are more aware because of this Google that we should be aware that though these are not in the diagnostic criteria of this Kawasaki till yet, these two pictures, periangual dry desquamation of the skin and BCG site activation, they should be considered as the pathognomonic of Kawasaki disease. And already Japanese guideline has already, and diagnostic criteria has already put the BCG site activation, and it's already time for us also that this should also be included in the criteria for diagnosis of Kawasaki disease. And so definitely we should think of Kawasaki disease much earlier.
So how common is infection triggered Kawasaki disease? And like they have culture positive things, and because AHA writes that it's a diagnosis of exclusion, and if you have some sensible thing to in your hand, how can you say that he is wrong at this point of time? Because so, your all the features are non-specific.
Yeah. So when you have infection, but if you have one or two soft pointer towards the Kawasaki disease, that's the time we should think of Kawasaki disease. And infection trigger or infection associated Kawasaki disease is a well known. It's occurred in around 8 to 10% of the cases. So we should not stop our mind. We should not be when we have some organisms, we should not be quite complacent that we have got the organism, we are treating the organism. So look into the, we have to follow the cell, and one clinical signs may get disappear when you really seeing the cell. So they come in a sequential way. So you have to keep on asking whether such things really occurred or not. So infection trigger KD is a well-known phenomenon.
So there are 2-3 things basically when you have these types of features like perineal desquamation and BCG site reactivation. These are very more specific things for Kawasaki disease and to be considered as a pathognomonic. So basically we have to stick our neck that this is a Kawasaki disease. Second thing is that collection of urine in 8 months of old at child is always a problem. So when you collect the urine, because pyuria can be occurring due to the Kawasaki disease also, and at that is also a problem. So again highlighting the things of Dr. Johnson, which is saying that if you have some other things but features are suggesting of Kawasaki disease, don't stop thinking about the Kawasaki disease. So he rightly did that, and then echo was done at that point of time, which was almost normal except that left anterior descending coronary artery was like touching 2.23. And child was received IVIG 2 gram per kilo and aspirin. Because it was an infant, he he was not satisfied at that point of time, and he has although child has improved at that point of time, and he was worried for that because there is a urine culture which is positive. So how far we can go for further immunosuppressive therapy? But again, he has given oral prednisolone and aspirin and called for follow-up after 1 week. But somehow parents thought that we'll go after 2 weeks because child is fine. What can be the problem? So, but child, they came after 2 weeks because of recurrence of fever, which was for 1 or 2 days, which can be just simply said that inadequately treated UTI or something like KD is causing. But what happened at this point of time is that echo was now LMC is 3.2 mm, which is a G score of +8, and left anterior descending coronary artery is a +10 G score. So what happens in last 2 weeks is that, and how can you highlight that, and in context of the recent AHA update also, they have clearly written few things. So can you highlight that how frequently we have followed these children and during the acute phase, so that we should not miss these types of disaster?
First of all is diagnosing and treating the case of Kawasaki with IV agent aspirin and follow up with plus minus prednisolone. Now, if we follow strictly the guideline says LED dilatation or RCA dilatation more than 2.5 or male sex. Now, this child is not among those, but guidelines are guidelines. Particularly in the infancy, I should say that we should strictly follow them up with echo and the inflammatory markers, particularly CRP. So if the CRP is not falling or is not falling, then or you have to do echo, and the recent guideline has already said that we have to repeat echo every second day or third day, and until and unless it stabilizes, we should keep on doing echo. So we should not be complacent that fever has subsided, some inflammatory markers has subsided, but if your echo has not been done at the time of discharge twice or thrice, then you should not be complacent. So such scenario can come up if we discharge the patients early.
So what two things are there, that echo has to be done more frequently, and it cannot be overemphasized that, because you can see the real examples. And second thing is that infantile KD is something which is a different different altogether, because more than 50% of infants can develop coronary artery abnormalities. So something which is 1 out of 2 children, infants can develop in coronary artery abnormalities. We cannot stop at just an IV agent aspirin. So we have to give treatment intensification in this setup. So rightly done at that point of time, infliximab was given discharge on prednisolone and low molecular weight heparin. So how should we follow up these children in long-term follow-up, Dr. Johnson?
Yeah, so first, when there is giant coronary aneurysms, we should follow, first it has to be stabilized, whether that there is no increase in the size of the aneurysm. Then once it's stabilized, we have to keep on following at least every weekly till around 6 weeks. Then from 6 weeks, if it is not increasing, then of course every 3 months, that is after 3 months, then 6 months, then 9 months, then 12 years, then every 2 to 3 years. So the echo is the first modality, and if we have those dual source CT coronary angiography, then of course we have to do a baseline CT coronary angiography, and that's how we have to follow them up.
So thank you all the colleagues for the doing these 3 complicated cases, and with the permission of organizer, I can take 2 or 3 questions, which is, I know that there will be several of these.
So statins, what is the lowest age that you have used and how long to use? And in cases of only giant or aneurysm or moderate, giant, and so.
So studies said that Dr. Akib, I think he showed that that study of using of statins, that is above 2 years. But we have been using even in infants also, but we have to monitor the lipid profile, because lipid profile should not be quite low because cholesterol are needed for the brain development. So we are using statins for the because it helps in the remodeling of the coronaries. So statins can be used much earlier as also, and there I think we have not found any adverse effects of statin. I have found one adverse effect. There is transaminitis, and the another child had diarrhea. When I stop statins, it actually lose to resolves. That's one scenario which I had with statins.
How long to use till the resolution of aneurysm?
So statins usually used for around 6 months by the studies, but I think we all have been using for more than a year or so.
So the role of statins is coming in two ways basically. One is for long-term endothelial dysfunction and all these things, but now it's coming as an anti-inflammatory also during the acute phase. So during the acute phase, there are one trial from the Dr. Edina Trimolit, and one ongoing trial is from Japan also. They have published their protocols. So that suggests that it can act as an anti-inflammatory also during the acute phase. The long term, how long do we continue? We continue for longer duration when they have a coronary artery abnormality, specifically in giant coronary aneurysm or medium-sized aneurysm. We'll continue because that has several other factors like endothelial dysfunction, anti-lipidemic actions, and remodeling and all these things. So still the guidelines are not very clear at how long to be continued, but we in PGI continue for a longer duration till the time they are on antiplatelet therapies, and maybe we can have one more.
Yeah. So I am Professor Arun Prasad from AIMS Patna. So nicely presented all the three cases, I must say. A small comment. There is one more information in your case one. That is, there is no neutrophilic predominance. So initial neutrophilic count was 51%, and on repeat this was 62%. So this is not explaining the bacterial infection. So this becomes another evidence to think more towards rheumatological disorder. So neutrophil count not explaining bacterial infection, platelet count is high. In presence of course, these inflammatory parameters, you should think about rheumatological disorder. Thank you very much.
Dr. Yamini?
Any experience regarding the direct acting oral anticoagulant? And second question, any experience, I want to know more about the pulmonary manifestation of Kawasaki disease, how it is different, and what is the prognosis in such cases?
I shall take up the first one. So I have in the child which the case 2, the parents were reluctant after 6 months. They were reluctant to they were switched to warfarin, but they were reluctant for frequent pricking. So in discussion with the PGI team and with Sagar sir also, he had put up a doses of apixaban in uses. So I consulted the hematology, and we started on rivaroxaban, and by touchwood the child has got good response with rivaroxaban. And regarding the second one, I can hand over the mic to Dr. Manpreet sir.
Pulmonary manifestation. She's asking pulmonary
manifestation of Kawasaki.
Pulmonary manifestations. We've recently seen one case who would actually come with pneumonia, was in PICU, managed as pneumonia, but then it was an infant, like 4 months. The child suddenly developed intense mucositis, and there was BCG scar reactivation. And I think there was another case also. It is a possibility that there can be pneumonitis also, and we should consider KD if we have other signs. Even if the BCG scar reactivation is not there, but then similar things like fever not responding and rising platelets, it's a like clinical scenario. You have to like make it a case-to-case scenario.
So, here's a pertinent question. Now I understood. You know, Professor Jane Burns once asked me how common you see pulmonary lesions. They can be seen. They are non-specific. They are of unknown relevance till yet. So he asked me, can you put a needle into that? So we discussed that. But in PGI, we haven't sent much of pulmonary lesions. I've seen only one. I don't know what kind of lesions they are, what is their significance, and how they respond to treatment. Still an enigma.
Sagar, last question. I meant.
No, just completing that comment, apixaban, I think there is a role. We have had one child with giant coronary and axillary aneurysms, and for practical purposes, we had to start apixaban, and then I had written to Dr. Jane Burns. As I see in December 2023, Jane Burns group has published a paper on apixaban for thromboprophylaxis in pediatric heart disease, and I think that paper also mentions the dosages based on the weight. So I think definitely with this publication, we are more safe to use direct oral anticoagulants, and giving LMW heparin for months together is a challenge in young children. So I think there is a role for apixaban.
So there is a literature to emerge on direct oral anticoagulants, but the studies are only one, which is like Dr. Jane Burn has last year published. So the problem with direct oral anticoagulants is the efficacy and safety has not been proven in long run in children. That is an issue, and sometimes the bleedings and all these things can be a problem in these patients. So the data is emerging, and we have to just follow the data. Long-term safety is still not like we don't know. So till the time, like when the situations are like when parents don't want that pricking and all these things, possibly like still in AHA statement also, recent AHA statement also, they prefer low molecular weight heparin. They have just mentioned that direct oral anticoagulants are coming in directions. So possibly we have to see the years to come about that DOACs. And about the pulmonary manifestation, we have published from our institute about the pulmonary manifestation. These can be varied, including the pulmonary nodules and interstitial pneumonitis and other like associated because of the infection triggered Kawasaki disease like pneumonia, pleural effusion and all these things. And these patients, because of the inherent delays in the diagnosis, they have higher chances of coronary artery abnormalities. So pulmonary manifestation is very, very important aspect of the Kawasaki disease, and when they occur, that chances of development of CALs are very high. So with this, I will thank all the colleagues for all the efforts in making this presentation, and thank you.
Thanks to all the speakers for such a brainstorming session. Up next, we'll be hearing from Dr. Avinash Sharma, Assistant Professor, Tanda Medical College, Himachal Pradesh. He'll be presenting to us about controversies regarding echocardiography in Kawasaki disease. The session will be chaired by Dr. Shaji Philip, Pediatric Cardiologist, Kochi, and Dr. Arun Prasad, Professor, Department of Pediatrics, AIIMS Patna.
Is supposed to finish including general body by 6 p.m. So Dr. Avinash has done DM pediatric clinical immunology and rheumatology from Chandigarh. He will be presenting the controversies in coronary artery evaluation.
Good evening, everyone. I thank the organizers for giving me this opportunity and to discuss this topic regarding another controversies. As Dr. Satish has highlighted the definition of controversies which make people think and, so I'll not be discussing exactly the controversies, but it's a debate whether 2D echocardiography is the optimum imaging modality, and is it the only modality which should be used, and what are the times where echocardiography is used in cases of Kawasaki disease. I'll try to be brief. We all know that 2D echocardiography is the imaging of choice, and there are many reasons for it, as being discussed in open forum as well. It is relatively easily available. We can repeat it as many times as one would like. We know this modality of imaging is being used since the coronary involvement in Kawasaki disease has been described. So it is in use since 1980s and still remains the imaging of choice. We all also know that it is not required for diagnosis, as has been highlighted in the open forum as well. For making a diagnosis of Kawasaki disease, we do not need a 2D echocardiography. So there still remains some doubt in practitioners' mind whenever sometimes we get a call that the child is fulfilling the criteria, but echo is not possible or echo is not showing any abnormalities. So that should not take us away from the diagnosis of Kawasaki disease. And similarly, a normal echocardiogram does not rule out the possibility of Kawasaki disease. We all know that usually done in the early stages, echocardiography is often normal. Regarding the timing, we have been debating for quite a long now, but traditionally speaking, it is usually done at the time of presentation. The traditional teaching is it is repeated at 2 weeks and then at 6 weeks. And if 6 weeks echocardiogram is normal, we stop aspirin and we follow up the child. So there is the role of 2D echocardiography cannot be overemphasized. If you look at this flow chart of the incomplete KD, you can see we need either 3 of these laboratory criteria. Out of a list of laboratory criteria, we either need 3 of them or only an abnormal echocardiogram. So echocardiography has got its own role in the diagnosis of Kawasaki disease as well, when one is in doubt if the underlying condition is Kawasaki disease or not, especially when the diagnosis is not clear. So we know that it must be done as soon as diagnosis is suspected, but treatment should not be withheld if echo is not available or if echo is normal. So it must be done as soon as possible, but the challenge is, as we are discussing the challenges, in our setup, it is not always possible to get the echocardiogram done at the earliest possibility. And there are many reasons for it. The biggest challenge, I would say, is the non-availability of trained pediatric cardiologists. Pediatric cardiologists are few. Then the priorities of cardiologists who are looking after children may be some others like congenital heart disease. Someone told us about rheumatic heart disease, rheumatic fever. So it may not always be possible to get echocardiography done when we would have liked or the audience would have liked. Because for us, the priority is looking for evidences of Kawasaki disease. And as already discussed, it is nearly always normal in the first week. There are other challenges as well. In young children, we know the young children are often irritable because of their age and the underlying disorder that is Kawasaki disease, which makes them more irritable. So they are likely to be uncooperative. There are no standard protocols for sedation to be used in echocardiography. And we know that in grown-up children, the echocardiographic studies are suboptimal. So these are few challenges. So I came across this paper, which is a retrospective study from the national surveys conducted in Japan, and they looked at more than 100,000 children who had Kawasaki disease. And they looked at the initial echocardiography. So they found more than 3,000 children in whom they picked up abnormalities at initial visit. Initial cardiography picked up the abnormalities, where we are discussing that in the first week of illness, you are likely not to find the echocardiographic abnormalities or coronary artery abnormalities. Interestingly, if you see this chart, we can see even on day 1 of illness, there are children who were found to have coronary artery abnormalities. And the risk factors they have identified are more interesting. Children less than 1 year of age and children more than 60 months of age. So we all know young children, that is less than 1 year of age, are likely to have more coronary artery abnormalities. They found that children who were more than 60 months of age, more than 5 years of age, were more likely to have coronary artery abnormalities at the initial visit. Also, another interesting point is those who had 3 or 4 signs of Kawasaki disease were more likely to have coronary artery abnormalities compared to those who have 5 or more signs. So those who had fewer signs were more likely to have coronary artery abnormalities in the initial echocardiography. So they are speaking only of the initial cardiogram. So basically, this highlights the importance of doing echocardiography at the earliest possible, where we are likely to pick up coronary artery abnormalities, and more so in those who are young or a bit older and those with incomplete Kawasaki disease. Then the value of serial echocardiography. We just heard from Dr. Rakesh the value of serial echocardiography. Even if you find normal echocardiography first, there are no standard protocols as to how often should it be repeated. But this group looked at the value of serial echocardiography in diagnosing Kawasaki disease, not for following up, but diagnosing. So this adds a challenge that when they were suspecting Kawasaki disease, they were repeating echocardiography 2 times, 3 times, and even 4 times. So basically, this may be a group of people like those who are sitting here, eager to find a diagnosis of Kawasaki disease. When you are suspecting Kawasaki disease, you are bent upon finding the echocardiographic abnormalities just to prove that it is Kawasaki disease. So these people repeated echocardiographies, and after 4 echocardiographies, they found some abnormality and diagnosed Kawasaki disease. So this paper highlights the role of serial echocardiography in diagnosis, not just for follow-up, but diagnosis of Kawasaki disease. Some more challenges, as we all know. These are the conventional or traditional challenges which we all face in doing 2D echocardiographies. We all know that it is not the modality of choice to evaluate the distal coronaries, and it is only the proximal coronaries which are visible. Even when we know that it is easily available, easily can be repeated, but these challenges we usually face. It is highly operator dependent. We all know we have experts sitting here who have been doing the echocardiograms in patients with Kawasaki disease. So we all know the importance of precise measurements of the coronary artery so that we get the exact Z-score values. A minor change in the measurement of the internal diameters can result in significant changes in the Z-scores, and that makes interpretation difficult. So it is highly operator dependent. One operator may differ from the other. The challenges and importance of Z-scores, I believe, will be discussed in one of the subsequent sessions, so I won't be going into the details. Then another point is other features on echocardiography. We were listening in the open forum. It is not only the coronary artery measurements or coronary artery diameters, but there is something called other features on echocardiography. So there is no standardized format as to the other features of echocardiography. We know that there are features like lack of tapering of coronaries, pericardial effusion, then valvular abnormalities, and there are many more, regional wall motion abnormalities. But there is no standardized format. In our institute, I can tell you, when we send the patients for echocardiography of Kawasaki disease, we never get a report on these features. Once we have discussed, we have had many meetings with cardiologists. Now we have started getting few of the features. Initially, even the measurement of the coronaries were standard. The standard reporting format was 3 millimeter. LMCA 3 millimeter, RCA 3 millimeter, LAD 3 millimeter. 3 millimeter is absolutely not normal for a young child. So after we have had many meetings with the cardiologists, now we get the exact measurements and we calculate the Z-scores. So the other features of echocardiography is not standardized, and it's a challenge in itself. Another important point is the normal coronaries do not rule out, as already highlighted. So we can even find the reducing size of coronaries on serial echocardiograms. So if the size has decreased from initial, that again raises the possibility of Kawasaki disease. The limitations of 2D echo, we all know. We cannot, evaluate the distal coronaries. Conditions like thrombosis and stenosis are not optimally studied. varied reporting formats, as already discussed. So there is no uniform reporting format for this. Other findings on echocardiography I have already discussed. So because of these reasons, maybe we are now having more discussions on the alternate modalities of imaging, including the CT coronary angiograms. So there are some questions which remain unanswered still: how frequently to perform, and how to report a patient of the abnormalities on echocardiogram. What should be the ideal reporting format? So we know that 2D echo remains the imaging modality of choice in Kawasaki disease. Challenges exist in performing echocardiography, in interpreting and reporting the echocardiograms. Guidelines, though, exist but are still evolving and need further refinement. Thank you.
Thank you, Dr. Avinash, for further enlightening us on this echocardiography. Here, my comment would be, as we showed in the morning workshop today, that basic echocardiography and imaging coronaries is not a very difficult skill. This can be easily learned, of course, with repeated practice. So, any questions?
As you said, I strongly agree. As long as when you diagnose the cases, immediately you have to do one echo. Not only for coronary, you have to see for the valvulitis also can be associated. And before epicardial coronary arteritis occur, myocardial also can be involved. 80 to 90% myocarditis can occur. So the LV function also can be studied, and the coronary size also will be noticed. So then subsequent follow-up, definitely we can pick up if coronary artery is involved or not. So definitely the distal portion circumflex and the aneurysm between the marginal and the PDA, everybody cannot. The expert people sometimes, I used to go a little more the apical area, distal area also I used to take up. So it is possible, but everybody cannot.
Thank you.
So any doubts on the floor, please?
One doubt, sir. What are the Z scores, Z scores, whatever you use regularly? What? Okay, next session.
Next session is on Z.
Fine, we'll go on.
Yeah.
Sir, could you elaborate upon the fact you mentioned that a reducing size of coronaries should also prompt one to think of the diagnosis?
So
I mean, to begin with, wouldn't the dimensions would have been a little dilated and then only the reducing size would be relevant?
So even if they were dilated, you're absolutely right. They will reduce only if they were dilated in the initial place. So even if they were dilated, but were within the normal Z scores, and now they have reduced, so that shows that there was some coronary artery involvement. So that may give us a clue that probably this was Kawasaki disease.
Since we are short of time, I think we will move on to the next
Thank you,
session.
sir.
Thank you, Avinash Sharma.
Thank you, sir, for shedding light upon such an important aspect of the disease. I would like to request Dr. Manoj Kumar, sir, to felicitate the speaker and the chairpersons. Up next, I would like to call Dr. Ankur Jindal, pediatric rheumatologist, PGI Chandigarh, to share his insights with us about the basics of coronary artery Z scores. The session will be chaired by Dr. Amit Kumar, Additional Professor, IGIMS, and Dr. Pradeep Kumar, Additional Professor, Department of Pediatrics, AIIMS Patna.
Okay, good evening all. So moving to the next session, Dr. Ankur Jindal, he's assistant professor in pediatrics, clinical immunology and rheumatology, Allergic Immunology Unit, Department of Pediatrics at APC, PGI Chandigarh, India. And he has major achievements like he had Head Angioedema Center of Reference and Excellence. And he is also the founder, member and joint secretary of Indian Society of Kawasaki Disease. So stage is yours.
Okay. Thank you, sir, and good evening, everyone. I hope you're not tired, bored, or still willing to listen to more Kawasaki disease and echocardiography. So thanks to the organizers, Dr. Pratap, for having me here. So my topic is ABC of the coronary artery Z scores. And you must have seen Dr. Pratap on purpose left this part of discussion from his talk on echocardiography, which I'll be covering. So when I started thinking about coronary artery Z scores in patients with Kawasaki disease, these were the 6 questions that came to my mind. And I'll be very disappointed if you have a 7th question related to coronary artery Z score, but because I'll cover everything in this particular talk. So the questions are, should Z scores be used for assessment of coronary artery abnormalities? If yes, then which Z score? Are there any specific Z scores for Indian population that you can use? What is the clinical significance of Z scores in relation to Kawasaki disease? And I'll be highlighting very important aspect of importance of changing coronary artery Z scores during acute stage of Kawasaki disease. So we've been hearing for last few talks that echo cannot be used to diagnose Kawasaki disease. Yes, it can be used to diagnose Kawasaki disease as well in the acute stage. And I'll be talking about this, some literature related to that as well. And are there any Z scores for assessment of coronary artery abnormalities in CT angiography? So just to start, this is how a standard bell curve of normal distribution looks like. What are we interested over here in this, figure of +2 and +2.5. So when Z scores are derived, you should understand, about 1.7% of healthy population will have a diameter above +2 Z score. And about 0.5% of the healthy population will have a diameter, a normal population will have a diameter above 2.5 Z score. That will be about 0.4%. I mean, it's something that you should know when you are evaluating Z scores in patients with Kawasaki disease. So coming to the question of should Z scores be used for assessment of coronary artery abnormalities, there is absolutely no doubt that we should use Z scores for assessment of coronary artery abnormalities, because it gives, there is no rationale of saying that, okay, to me this coronary artery appears dilated, this coronary artery looks aneurysmal. There has to be an objective way of saying that yes, this coronary artery is dilated, small aneurysm, medium aneurysm, or giant aneurysm. So there has to be an objective way. You can't just label coronary artery diameters based on their absolute diameters. So this definitely gives a quantitative assessment of luminal dimensions. And we'll discuss in this talk that the case definition of coronary artery abnormalities, despite using these Z scores, still remains a little imperfect. And over here, this has been the classification as proposed by American Heart Association. The Z score, if it is always less than 2, it's no involvement of coronary abnormalities. Dilatation when it is 2 to less than 2.5, small aneurysm 2.5 to 5, 5 to 10 is medium, and giant is more than 10, or any absolute diameter more than 8 mm is giant aneurysm. One aspect that I highlighted over here is if initially the Z score is less than 2, a decrease in the Z score during follow-up for more than 1 is significant. Now, over here, I'm talking about decrease in the Z score on follow-up, not during the acute stage on 1 or 2 days. I'm talking about, for example, if you have a patient who has a coronary artery Z score of 1.8 at the acute stage, and 2 weeks of follow-up, your coronary artery Z scores comes down to 0.7. Now, that's a change of more than 1, and you can then say that, yes, the coronary artery in my patient was dilated in the acute stage, which is kind of normalized on follow-up. So this is very important, aspect of assessment of coronary artery abnormalities using these scores. So this is by the Japanese Ministry of Health, and they used to classify, previously used to classify coronary artery abnormalities using absolute dimensions. So it really makes no sense to use just the absolute dimensions to assess coronary artery abnormalities. We have to use Z scores, and it has been shown in many studies that if you just use the absolute dimension, you tend to underestimate the coronary artery abnormalities in these patients. So yes, we should definitely use coronary artery Z-scores. Now, which Z-scores should be used for assessment of coronary artery abnormalities? This is the table from 2017 American Heart Association guidelines. Over here, I want you to focus on these two Z-scores. There have been several Z-scores proposed since 1998, but the one that has been proposed by Kobayashi and one that has been proposed by Dallaire are the ones which are most commonly used, for the reason because they have used standard calculation method for body surface area, and they also include measurements for left circumflex coronary artery, which is not included in many other Z-score criteria that have been proposed. So over here, I think Dallaire is the one which is extremely important, and that is the one that we use in our clinical practice. So if you look at the Google, this is how the calculation of coronary artery Z-scores look like. So if you open the Google coronary artery Z-score, that is how it looks like. So over here in the red that I have highlighted, you can actually choose which Z-score do you want to use. And over here I have proposed a hypothetical case, a case who is about 6-year-old, has a left main coronary artery of 3.6 mm, left anterior descending artery of 2.5 mm, and so on. And you can see the interpretation of coronary artery Z-scores using Dallaire criteria and using Kobayashi criteria. So a lot of difference. If you use, for the same patient, same dimension, if you use Dallaire criteria, it says that the left main coronary artery is coming out of about 2.34 mm, which is dilated. But in the same patient with the same dimension, if you use Kobayashi criteria, it says that the left main coronary artery has small aneurysm. If you use for the same patient, same dimension, if you use the very recently proposed criteria by Lopez in 2017, it says that the left main coronary artery is normal. On the other hand, left anterior descending artery, which was normal previously, is now into the dilatation category. So you have to be very, very careful which Z-scores are you using, and the same Z-score you have to use prospectively in each patient and ideally in the entire cohort that you've been following up. How these Z-scores are derived, this is one which has been derived from Canada, and this is the one that we mostly use in our clinical practice. The evaluation has been done on more than 1,000 echocardiography studies. This is the one that has been proposed by Kobayashi from Japan, evaluating coronary artery Z-score in more than 3,800 studies. This is the one recently from multi-center experience, evaluating more than 3,500 studies. So what they do is, because they're cardiologists, most of these are cardiology-based studies, they evaluate patients who come to them for screening echocardiography for other reason, and they found that the echocardiography is normal, and then they take their coronary artery Z-scores to derive these complicated equations, which are not easy for me, which are not easy for you. I'm sure we don't understand. We definitely need help of a statistician who can actually derive these Z-score equations for us. What we really need, we do not have any published data on these Z-scores for Indian population. We have some unpublished data from Chandigarh, but every part of the country has different race, different ethnicity. Something that has been done in Chandigarh cannot be extrapolated to West India or East India or South India for that matter. So over here I'm looking at my cardiology colleagues. We really need their help to develop body surface area appropriate, gender appropriate, and race appropriate coronary artery Z-scores for Indian children. I mean, we need to include thousands of such patients to derive these Z-scores. So till then, we may continue to use the Z-score criteria that has been proposed by Dallaire et al. A few important tips. As has been mentioned, it is important to use the same Z-score criteria every time. And over here, you can see these two coronary artery imaging. On the top of the image, you see a right coronary artery aneurysm. The lower image shows the left main coronary and the left anterior descending artery aneurysm. So if you give this image to 3 different clinicians or cardiologists, I'm sure you're going to get 3 different the coronary artery luminal dimensions. And a small change in coronary artery dimension can actually lead to a huge change in coronary artery Z-score. So you have to be very careful when you're analyzing the coronary artery dimensions. And it's also very important that you use weight and height at every visit. So a patient who has come to you now is come to you for follow-up after 1 year. You cannot use the same weight and height that you used 1 year ago. You have to use, you have to check weight and height and calculate body surface area at every visit when you're doing the echocardiography, because that will make a huge impact on coronary artery Z-scores. Coming to the next question, what is the clinical significance? So if a patient has a Z-score of 10 versus 20 versus 30 versus 40, does it make a clinical difference? Let's see how the literature suggests. So this is a study published from Japan in about 1,000 patients. You can see, if a patient has small aneurysm, the rule is that most small aneurysms will regress. If a patient has medium aneurysm, most again will regress, but a lot of them will not regress. But if you have a patient with large aneurysms, they are very, very unlikely to regress to normal. Over here, it is also very important to see that there is no significant difference in the groups with or without IVIG resistance and with or without use of corticosteroids in terms of resolution of these coronary artery abnormalities. What really matters is what is the maximum Z-score that the patient has attained at the diagnosis or in the first few weeks of the illness. This is another study involving 1,600 patients, a multi-center study based at Canada, 1,600 patients, no complications seen in patients with small coronary artery aneurysms, only one patient who had medium CAAs, but involving all the 4 coronary arteries developed complication. Over here you can see, so the figure on the right is more important. I think it's not visible, but I'll tell you what exactly is written over there. So you can see on the left side you see RCA, LED, LCX, and LMCA. So what this graph shows that if the aneurysms is in RCA and LED, the risk of complications, be it thrombosis, be it stenosis, or be it myocardial infarction, is much more than when the involvement is in LCX and LMCA. The further right shows that the risk of complications are much higher if your score is more than 40 as compared to when it is 30 to 40, as compared to when it is 20 to 30, as compared to when it is 10 to 20. So it's not just more than 10 Z-scores. The further classification into 20, 30, and 40 is extremely important because the risk of complication increases as your diameter of the coronary artery or the Z-score increases. Now, another study from Dr. Suda group, and I want you to focus on the lower panel. Over here you can see that most small Z-scores will regress while most medium Z-scores will not regress, and it's almost a rule that the large Z-scores will not regress on follow-up. So I still have 2 minutes. I think I'll finish it. So there are very important management decisions based on Z-scores, and we've seen these through guidelines. I'm sure we're seeing this since morning. So we classify the risk categories based on Z-scores. So anything small aneurysm goes into 3, medium aneurysm goes into 4, and large aneurysm goes into 5. And then we have sub-classification 3.1, 3.2 based on whether these aneurysms are persisting or whether these aneurysms have regressed. So these are some of the guidelines, and these are some of the other guidelines from American Heart Association 2017. I don't think we need to go into detail, but yes, of course, if the Z-scores are persisting or if the Z-scores have not regressed to completely normal, you need to keep these patients on long-term aspirin. It's important that if you have a large or giant aneurysm which is persisting, you have to give them oral anticoagulation, either warfarin or LMWH. And it's also important that if you have a patient with large and giant aneurysm which is regressed to medium aneurysm, you need to give these patients dual antiplatelet therapy. And then there are certain indications of use of statins based on these Z-scores and the beta blockers. So let's not go into details. This is the American Heart Association 2024 guidelines that have also proposed direct oral anticoagulant agents for use in these patients. Now this is what I was talking about, importance of coronary artery Z-scores during the acute stage. So there have been 2 studies at least, both by colleagues from Germany, and what they've seen that if you have a patient with Kawasaki disease who is being evaluated for Kawasaki disease versus a febrile control, it's very important that you do echocardiography daily to see how the coronary artery diameters are changing or the Z-scores are changing. It has been observed that in most patients with the Kawasaki disease, the coronary artery Z-score change at least in the next 24 to 48 hours, and that changing Z-score, the increasing Z-scores give us very, very important clue for the diagnosis of Kawasaki disease in these patients. So yes, echocardiography in the acute stage can actually be used to diagnose Kawasaki disease. This is another study which was published in 2022 from the same group when they compared patients who were ultimately diagnosed to have Kawasaki disease versus who were actually febrile control and they were not Kawasaki disease. What they observed that none of the patients with Kawasaki disease had decrease in the Z-scores during the acute stage, while all patients who were febrile controls had decrease in the Z-scores during the acute stage, while all those patients with Kawasaki disease had increase in the Z-scores during acute stage, but none of the patients with febrile controls had increased Z-scores during the acute stage. So it's important that we do echocardiography daily in these patients who are being evaluated for suspected Kawasaki disease. So this is the last slide. Are there any coronary artery Z-scores for assessment of coronary artery abnormalities? Of course, there are none, because it's difficult to derive Z-scores for coronary artery abnormalities in coronary artery diameters in normal population. But we can use the same Z-scores that we use for echocardiography. But keeping in mind that application of echocardiogram-derived Z-score formulas to CT measurements would result in a lower risk stratification in most of these studies. So we started with these 6 questions. These are my answers. Should just Z-scores be used? Yes. Which one? We can use Dallaire et al., but we definitely need to develop our own Z-scores which suit to our population, our race, our ethnicity. There are no standard Z-scores for Indian population. Higher the scores, more are the risk of complication. A changing Z-score during the acute stage may really help in making a diagnosis of Kawasaki disease. And there are no Z-scores for assessment of CAs in CT angiography. So with this, I wish to thank. And we can take
thank you, Dr. Ankur. I'm sure you all would agree that when it comes to making a confirmed diagnosis of KD, monitoring the treatment, or even the long-term prognosis, it usually boils down to these scores of coronary arteries. And I must thank Dr. Ankur for enlightening us on this difficult topic, but making it so simple. And I think that there were a few questions on these scores. If organizers allow, we can take 1 or 2 questions.
Can I have one question, please? Yeah. Thank you, Dr. Ankur. I'm here, for very informative talk. 2 questions. First is, what is the basis that you are suggesting Deleuze's criteria to be used for our setting? And the second is, in this corollary, what percentage of children were of Asian descent in the Kobayashi and this particular group of Z scores being proposed, so that we are probably sure that we are using a score which is more valuable for us?
Okay. So I think the reason why I am proposing Dallaire score is because we've been using it, and I think most people in India, I think they're using Dallaire score. There is no harm in using Kobayashi score. But it's important that you use the same score for every patient and also for the entire cohort that you've been following up. So that is very, very important. I'm not sure about the Asian people who were in that study. I'm definitely not very sure about that. I don't think the studies have even mentioned about this, but I don't think it makes a difference whether they had Asian population or not, because it has been observed that the coronary artery diameters are very, very sensitive to the race, age, ethnicity. So I think even in India, if you do the studies, I believe that if you do a study in North India, it would be different from the study that you did in South India or West India or East India.
We have not looked into what percentage of Asian descent. Okay. No. And second question is the very important point that you bring up as the serial echocardiography. And you mentioned that in KD patients, the serial echocardiography patients will have increase in Z scores. But you and me know that, and that most of those who are doing rheumatology know that in inflammatory conditions like systemic GIA also show on keeping these Z scores. So if the Z scores are more than 2.5, it's fine, we are comfortable that it is Kawasaki disease. But what's your thought if the Z score is not below 2.5, but still we are struggling with this condition?
So I think it's a very important question, and I don't think we will be able to differentiate between Kawasaki disease and other inflammatory conditions. But over here, the question is about differentiating between Kawasaki disease and infectious conditions. For example, especially the viral infections, especially some of the bacterial infection, and these changing Z-scores hold very, very importance in those conditions. But I don't think it will be able to differentiate between inflammatory conditions such as systemic GIA. But I think you would agree with me as well that differentiating between KD and systemic GIA into clinical practice is not that a big challenge as compared to differentiating KD from infectious conditions. So I think, although we not often, but we occasionally encounter cases wherein we are struggling, is it Kawasaki disease or is it systemic GIA, especially when the illness is a little prolonged. But those are very relatively uncommon conditions as compared to differentiating Kawasaki disease from acute infections.
Rightly you have pointed out that the same score should be followed up in the next subsequent but most of the pediatric cardiologists, they don't mention which score they have used. And as a pediatrician, should we ask them
to
write which score
in capital letters? Which score have they used?
So that standardization we should require.
Yes, we should.
That is the thing.
That is extremely important, because as I said, if you use a different Z score, the classification will change. So they have to use same Z score every time they do echocardiography.
But different centers are using different Z score, I think.
So I'm not sure. I mean, we are using
how could we,
Delair.
standardize that?
So we are using Delair, and I'm not sure about others. We can ask about the experience from others, what score they have been using. But it's okay to use any of these scores, but it's important that prospectively the same score is used by the same center. But I think the need of the hour is to develop our own Z-scores.
May I ask a quick question? Yeah. Nice talk. Very interesting statement and important statement. You mentioned that regression rates of giant coronary aneurysms depend on the Z-score, the severity, and not on the initial treatment. Yes. I would want to reiterate that fact. One thing, I would like your comments on that again. Second thing I wanted to ask was, I think more than regression rates, cardiac events in future should be looked at, because even if there is regression and if there is a cardiac event, I would possibly take that as significant rather than the number of the Z-score.
Okay, so to both your questions, I think I'll answer the second one first. These studies have not only looked at the regression, they've also looked at the stenosis, they've also looked at the risk of myocardial infarction. I think it was not visible in the slide, so it was not really interpreted that way. But it also looked at the complications, including death. Now, to your first question, yes. So the question about the initial treatment. So in that study, at least, they only evaluated steroids and not really evaluated infliximab or any other forms of treatment. So they've only looked at the risk of complications between patients who received steroids in addition to IVIG versus those patients who did not receive steroid, and there was no difference in the outcome.
Because that also brings into the difference between primary intensification and secondary treatment. That means these two cohorts are not really the same. Once you develop a giant aneurysm, your prognosis is going to be altogether different if you hadn't developed it. That's what it also possibly tells. That means the larger is the size, your prognosis is always going to be poor, whether you receive the treatment or not.
Yes, I totally agree with you, but I think we definitely need more data on this aspect, especially when the use of infliximab and cyclosporine has been increasing over last few years. So we really need to see 5 years, 10 years down the line, how has been the outcome of those patients who have received intensification with steroid, infliximab and cyclosporine as compared to the other cohort who hasn't received intensification. So I think this is something that we really need to see. But as far as the steroid is concerned, I think based on that study at least, it doesn't seem to change the outcome. But I think what is very important is steroids used for IVIG resistance versus steroid used for decreasing the risk of coronary artery abnormalities or decreasing the coronary artery outcome. I think these are the two different outcomes, and as was discussed in the last session as well. So I think the most literature on steroid is in terms of decreasing the IVIG resistance rather than actually looking at the final coronary artery outcome in these patients.
Thank you, Dr. Angu, for a wonderful session. I think we can discuss during dinner. So let's put an end to this. Yeah. Thank you.
Thank you, sir, for presenting such complex ideas in such an accessible way. Next, I would like to call upon Dr. Manful Singhal, Professor, Department of Radiology, PGI Chandigarh. He would be presenting to us about CT coronary angiography, a new imaging modality in Kawasaki disease. The session will be chaired by Dr. Rajiv Priyadarshi, Professor and Head, Department of Radiology, AIIMS Patna, and Dr. Upasana Sinha, Additional Professor, Department of Radiology, AIIMS Patna.
Good evening, everybody. I know this is the last session. It's my proud privilege to invite our next speaker, Dr. Manful Singhal, sir, who is pioneer in cardiac imaging, and he is well-known cardiac radiologist both nationally and internationally. Right now, he is a professor and lead cardiac imaging, radiodiagnosis and imaging in PGI Chandigarh. And his major achievements are ICMR International Fellowship for Young Scientists in CMR in 2017. He has been awarded many honors, certification and orations. He has represented IRA at ASR 2023 Vienna. And he has received Dr. N.J. Godekar Oration of Indian College of Radiology Imaging 2022, Dr. Ram Rishi Oration of MP State Chapter of IRA in 2023, and BNS Swalia Fellowship Grant from PGI Chandigarh. Sir, I think although it's a last session, but everybody is eager to see your all beautiful coronary imaging. So without any delay, sir, please, the stage of yours, sir. Please start.
Thank you, Upasana. So Upasana was our very dear radiologist from PGI, and we always wanted to retain her, but she is in AIMS Patna now. It's very satisfying. So, the topic that was allotted to me is CT coronary angiography. Is this a new imaging modality in Kawasaki disease? So, this topic will be a blend of science and how the science has evolved, how the disease has evolved, how, things have changed, and how, one need to embrace the emerging techniques into our daily practice. So it will be a mixture of everything, and I hope I will be able to do justice. The time allotted to is 15 minutes, but I don't think so I will be able to complete in that 15 minutes. So, I may be pardoned if I exceed time, which I will be. So, new guidelines, if you see, recently released in a few days back, update on diagnosis and management of Kawasaki disease, is a scientific statement from American Heart Association. So what does, this guidelines comments on the CT coronary angiogram? It explicitly says that it allows visualization of all segments of coronary tree and reliably assess the coronary artery abnormalities and thrombosis and stenosis if it's more than 50%. It has a superior spatial resolution, and CTA is better in detecting distal CA than echo. And I'm happy to tell you here that this paper cites two of the large publications as far as this comments on CTC are concerned. And it says and recommends that seeing the advancements, especially the optimization of radiation and the fast examination time, this modality can be used and should be used when you have a giant CAZ during hospitalization, and you should do once the patient is discharged. And this is a contemporary question that is being asked to me wherever I go, especially in this forum as well. I will try to answer at least my perspectives. And it says that when echo imaging is difficult during the acute phase, though proximal and segments are easily assessed, and luckily disease involves the proximal segment, so that makes sense. But sometimes it may be very difficult when there are suboptimal windows or a child is very sick. And this is during the acute and the convalescence phase, and during the long-term follow-up, it is a CT coronary angiogram, which is the way forward. So I have no doubt, and unambiguously and unequivocally, yes, it is a new modality. There is no doubt about that. Now, in this 15-20 minutes, what we are going to discuss is, we are going to see what are the imaging modalities are in Kawasaki disease. We'll see how they had evolved and what are their rationale. And primarily that we are going to discuss an echocardiography versus catheter angiogram. We'll see what was the limitations of this standard imaging modalities that prompts or that compels primary caregiver to think that he needs another imaging modality. And we'll see how that thoughts or that need gets integrated with the emergence of new imaging modalities. And we will see how these imaging modalities, newer modalities can be integrated in the management of Kawasaki disease. So in the center point of discussion will be the CT coronary angiogram, and we'll try to see and try to explore is it's a new modality. So if we see, since morning we have been listening, and this is the facts that I could get it from the history, and history of any disease, or for that matter on any subject, is very important because it tells you how the things have evolved over time. So in 1961, it was the first case which was seen by Professor Kawasaki. In 1974, it was described, it took around another decade to know the link between the Kawasaki disease and the coronary artery vasculitis. And this was possible on the large autopsy series. That was fine.
in late 90s, I think it's Professor Kato who started using the catheter coronary angiogram, and that's how that gives into the actual picture how the coronary arteries are involved and how the coronary artery abnormalities will behave over time, or how the lesions goes into complications. And during this time, the echocardiogram or the ultrasound was coming up, and the echocardiography became or got integrated into the prime management of the coronary artery disease. So when we talk of echocardiogram, we have listened, and this is not something new, but to reiterate, it is the investigation which is used at baseline in the acute phase, and it will keep, and irrespective of the innovations, I think the echocardiography will remain in the center stage. It is the standard of care for follow-up, at least in select patients. This is a statement can I make now. It is convenient, you can use it bedside, non-invasive, radiation-free. But if there are so much advantages, so what are the various things that that demands we need some other investigation? The most important disadvantage is that it is an operator dependent. It's an operator dependent modality. Whatever the measurements you take in single hand, if you do the same investigation by another operator, you will have different measurements, not only at that point of time, but during longitudinal follow-up as well. It can delineate, or it only delineates the proximal segments in majority of the hands. Left circumflex evaluation may be difficult or challenging. The status of collaterals cannot be displaced, and it has a poor sensitivity for intra-arterial thrombus. If I remember, Dr. Debrata was showing some cases in which she has difficulty in seeing whether it's a thrombus or it is something else. See, if it's a thrombus, then the treatment management totally changes. If it's not, then treatment is different. And this was during the acute phase or in the convalescence, but on follow-up, it is very, very difficult to see those arteries because of the limited acoustic window, and more importantly, maybe at that time that aneurysms may have remodeled or they have calcified. So I always say that it's the air and the calcium are the killers of ultrasound. So you cannot see those arteries. Now, what to talk of catheter angiogram? It's a gold standard, no doubt about that, but it is invasive. And it is with the high radiation. In India, it may not be that costly, but if you talk of the developed world, it is very, very costly. And you require hospital admissions, and our hospitals are already full. And you cannot do catheter angiogram during the acute phase because the arteries are inflamed, and there may be chances of local site puncture complications as well. Now with this was still 20th century. If you see in the 21st century or the late the 20th century, we had the liberty, or we had the opportunity of having the advanced imaging modalities, that is MR and CT. So when we talk of cross-sectional imaging, it is primarily MR and CTCA. When you talk of MRCA, it has a high diagnostic accuracy for coronary artery abnormalities, but trust me, it requires lot of expertise. I have tried myself, but I have not gained the good images till yet. I've scanned 68 patients as of now. Probably the MR is probably restricted for the assessment of myocardium. And if you talk of coronary artery abnormalities, it is to be done only in select patients, and probably there are two indications of using MR coronary angiography. Is once you have a thrombosed aneurysm, so you can follow up with MR, that will tell you better. So these are the images that was generously shared to me by Dr. Suzuki, who was a leader in the MRA. And if you can see, or patients having aneurysms have a coronary artery event, you can use the plaque ruptures and the plaque characteristics on MRCA very well. Now somebody can ask, what is CT coronary angiogram? So it is a technique of assessing or imaging the coronary arteries with the CT scan. Okay, it was possible only when the isometric or isotropic imaging was possible after the advent of 64 multi-detector CT. So what this does mean, 64 MDCT, this I need to tell you about that. There will be a single X-ray beam, and there will be 64 detector rows. At that time, the resolution was around 0.6 millimeters. But this was 64 when MDCT came into practice, is revolutionized the assessment of coronary artery disease non-invasively. So it was mainly restricted for the adult population. And when these generations, of the CT scanners, became more advanced with the advent of more detectors. The more detectors means larger area coverage. Speed of the scanners also increases. And integration of two tubes, or which is orthogonally placed, or the dual source CT, it has furtherly, exponentially rose this temporal resolution. When I use temporal resolution means just how fast you can do and scan. It has done that. So in 2013 we had a dual source, second generation dual source CT, and I approached Professor Surjit Singh कि we should be doing more of CTCA. So his pertinent question was how much was the radiation, and I confess here, I'm going to shoot up time. That's you have to pardon me. So we started using CTCA, and the radiation at that time used to be 2 to 3 millisieverts, and subsequently we changed our protocols to the adaptive ECG gating, and most of the scans now are done at less than 1 millisieverts. So what are the various strengths? So when we bring something new, it has to be seen under lens of the established imaging modalities. What are the established imaging modalities? Are echo and catheter angiogram. So what are the strengths of CTCA if you have to compare both? It is non-invasive, it is day care, and you don't require anesthesia. It allows the comprehensive evaluation of coronary arteries during the entire course and these branches, which is the main limitations of echocardiogram. It will show both mural and intramural abnormalities, which may be in the form of thrombus, calcification and stenosis, which may be limitation of both. It is radiation optimized, and probably in the times to come, or the time has come, that it will be the modality of choice for longitudinal follow-up. And more importantly, it will guide us for the further functional imaging and need for catheter angiogram. So there was a discussion on open forum. So we can discuss for hours altogether about the role of CTCA, but in the interest of time, I am going to touch only some pertinent issues. So if we see when the CTCA came into the picture, especially its role in the adult coronary artery disease patients. So CT people, researcher might have tried the role of CTC in KD patients. So at that time it was limited only to case reports and short series, and there was none on 64 MDCT, and first was on the first generation dual source from China. In 2010 there was another study from, this is the same study that was that concluded that dual source CT scanner derived CTCA is an accurate, non-invasive and valuable technique. Then 2012 we had another paper. 2015, Ankur has just showed whether when we have a new investigation, whether that correlates with the established modalities. So there was a good agreement with the catheter derived angiography versus CTCA. And then another paper came in which they had compared CTCA with echocardiogram. So both diameters were in agreement, and we are having our own data. In 2015 again you had a paper on this in Insights of Imaging, that on the cardiovascular imaging in children, and that also advocates using of CTCA. So here what the CTCA will come in. So you have a low dose CT angio or invasive catheter based on the clinical context. So slowly CTCA was finding space into the guidelines. Then in 2018 we had a paper in JCCT, and during that time we also started publishing our work. So these are the major publications of CTCA, and recently we had publications in Rheumatology Oxford on distal segments and the assessment of the LCX. So what are the CTCA's strengths? Is that it will show you comprehensive evaluation, not only the restricted to proximal but the entire course. You can see LCX, it correlates very well as far as diameters are concerned on cath and echo. It will tell you about the aneurysm morphology. If I talk of aneurysm morphology, it has a meaning. It's the fusiform aneurysms that are more prone for complications as far as secular aneurysms. It will tell you about extension and the complications, and it's the investigations of choice for follow-up. So should I show you some cases as well, or just about the CTCA and its role? I will show you some example. I showed this in morning. It will tell about the anatomical variations. Another case, it was an L-kappa. On distal segments, you see this is in Pythonus RCA, which is fusiformly dilated during entire course. Echocardiography will definitely pick up the RCA, proximal RCA, but it will never tell you about this distal extension. Similar, another case, have 3 discontinuous aneurysms. Proximal RC is normal. If you struggle enough, you can see the proximal one, but the middle and distal you will not be able to pick up. You see the extension of this aneurysm into the diagonal one arteries, and these are the aneurysms which are likely to get stenosis in the follow-up. You see a distal aneurysm in the posterior descending artery. This is another aneurysm which was never picked on echocardiogram. The CT angiogram picked on during follow-up. LCX, it may be difficult, but you can see it very nicely. You can see this bunch of grape appearance seen in one of the obtuse marginal branches. You can never imagine seeing that on echocardiogram. Then again, a giant and fusiform as well as secular aneurysm involving the LCX as well as the LAD, and the LCX beyond this is thrombosed. Very difficult to pick up, and the beaded appearance, if you see the recent literature, it can tell about the intensity of or the of the disease process. Beaded appearance will tell you the disease is very intense. It is, and you can see all the arteries and the branches are getting involved. So recently we, curated our data and published in the Lancet Regional Health about the assessment of LCX on CT angiogram. Then thrombus you can pick up, this small thrombi which is very difficult to see on echocardiogram, you can see very well on the CT coronary angiograms. Calcified aneurysms you will never able to see on follow-up, and you can see explicitly seen on CTCA. And more importantly, you can see the complications as well. This is an aneurysm which is thrombosed. You can see collaterals, and this is an LV apex aneurysm. You can see on that, and you can see the RCA. You have multiple discontinuous aneurysms. You can see the morphology as well as extension into the branches. Then this is then on longitudinal follow-up. I think the way forward and what to tell about, and this CTCA is now coming as a goalkeeper to when to do a catheter angiogram, when to do perfusion studies. Myocardial perfusion studies, as were discussed in the forum, has to be done under 2 conditions. If it's a giant aneurysm, patient getting symptomatic, then only perfusion has to be done during the acute or the convalescence phase, and in follow-up phase if you see a significant stenosis or patient is symptomatic. But for that you need a good CT angiogram. You see this patient on follow-up 3 years, the RC aneurysm has more or less remodeled, and you can see a persistent aneurysm in the LAD which is showing some calcifications. Again, this patient I showed you which expired very recently because probably he was not I think the patient did this strenuous exercise of its own. 2 segments of stenosis in the D1 segment, calcifications. This case I showed in the previous one has remodeled, now it's showing heavy calcifications, and you can see stenosis in the diagonal one artery. So this is going to act as a gatekeeper, not only follow but recommending the other investigation as far as perfusion studies are concerned. So same case, you see so much of calcium, it is very high calcium scores, and more importantly, as an adult, as a cardiac radiologist, sometimes you see abnormal coronary arteries. So you see this one patient who has aneurysms. Whenever you see the skip aneurysms, you see on this artery which is an RCA, this is an aneurysm over here, the aneurysm in the LAD, you have to think of Kawasaki disease. As an otherwise a radiologist, I will write it is no coronary artery disease. It doesn't mean no coronary artery disease, that patient doesn't have a disease of another disease. So this patient, we called their patient, asked about their histories. So, on this subject we had published one, and before that it was published from Dr. Jane Newberger group, but these were on cath angiograms. So we extrapolated that information into CT angiogram, and the paper is ready and we are going to submit it very soon. Another paper, this patient came for coronary artery disease evaluation, and you find an aneurysm which is calcification, no other diagnosis other than Kawasaki disease. So this was about the the present status. Now I feel what is the future of KD is that coronary artery affected by KD may be anatomically normal, but they are never functionally, or they are not functionally normal all the time. And it may be the time might have come, or we may get the answer that we have to move ahead beyond the anatomic information, so that now we are trying to extract the hemodynamic information from the CT data, which is very much possible. And every patient is different, trust me. and we have to individualize treatment strategies for each and every patient. So this is how you get all this hemodynamic data. So if I have to conclude, I will say CTC is a non-invasive investigation that explicitly demonstrate coronary artery abnormalities during their entire course and their branches, including mural abnormalities. CTC delineates the temporal change of coronary artery abnormalities. This is a very significant statement, and it can tell you about how that aneurysm has behaved over time in the form of resolution, stenosis, thrombus formation, mural calcifications, remodeling. The term that was being used as regression. I will not use the word regression. In fact, I will use the word remodeling. Remodeling will take care of all the things, whether it has size has reduced or its morphology has changed or whether it has complicated into stenosis. And there is excellent correlation beyond doubt as far as measurement of echo with catheter angiogram is concerned. And there is, I can say that it has emerged as a supportive modality for evaluation of select children in KD, both at presentation as well as in follow-up. I think with this I conclude. If there are questions, I want you to grill me on this subject.
Thank you so much, sir, for an excellent talk and for some excellent images. Sir, we are also performing coronary CT here in our institute. So I would just like to ask, what is the criteria for heart rate that is kept for heart rate control in children while performing coronary CT, because they generally have a higher heart rate?
When we do this CT coronary angiograms, I never look at heart rate because we have, fast scanners.
Okay.
But I always give beta blockers. I give beta blockers not to reduce the heart rate because children have inherently high heart rates. So that heart rate control, you cannot do even, irrespective of, until unless you use a very high dose beta blockers. So my intent to give beta blockers is to stabilize the heart rate because I use adaptive ECG gated protocols in which the heart rate do matters. If the heart rate suddenly changes, may it become low or high, then it can kill the examination. On that front, Upasana, I called you yesterday because I wanted to invite you and sit on this chair to know which scanner you have.
So we have a Siemens, sir.
Siemens, which one?
So 128 slicer and dual source.
You have a dual source CT scanner, 128. So, sir, these people need to be punished if they are not doing CT coronary angiograms for Kawasaki.
No, sir, we are doing CT. So they have children coronary CT usually, requisitions do not come in children. So mostly for congenital heart diseases it is done.
That's fine. I'm telling you, we need to create an imaging hubs in the country. Why a patient from Patna should come to Chandigarh, okay? When we have facilities. If you need support, because during initial days it may seem tough, I tell you, if you just let me know you want a support, I don't need anything except for an invitation. I will support myself. I will come by phone, I will stay and make arrangements of my own. So at least when we have these facilities, when we have these scanners, we need to do something. So, I think Dr. Patra, you were sending 3 patients that need to be scanned. I think by that time we can have video calls and we can discuss with them. Yes. Or if not, tomorrow morning is a Sunday, I can go to that hospital, to the AIMS Patna and to see their scanners and fix some protocols.
Definitely, sir.
Sure, sir.
If not, I can tell the Siemens engineers to visit your place and, we can establish their protocols as far as CT coronary angiograms are concerned.
Definitely, sir.
So you need not to worry about that. You have a scanner, and yes, I tell you, Upasana was too good when she worked with me in cardiac imaging, and she can do that.
Yes, sir. Thank you, sir.
So at least we need to have some, imaging hubs. So what you need? You need 2 things. You need equipment. You need expertise. You have you have equipment and expertise. It will come with time. Okay. It is only matter that it is your intent, attitude, and aptitude that you want to do something new and to help the patients and society. So that definitely is possible. Sir, I don't look at heart rate.
You mean the heart rate is like 80 or 90?
I don't look at heart rate. No, I don't like to look at heart rate. Blockers has to be given, because you know, I always say, we say if the heart rate is 90 or the heart rate is 150, but it has to be stable heart rate, because my switching of the X-ray tube depends on the RR interval. Say if there is sudden change in the heart rate, my system, CT system, gets confused, and you will end up getting a poor quality images. That I can.
Just move the hand itself to 120,
130. You know that's so. When we give midazolam, before that we give metoprolol, and metoprolol has a half-life of 3 hours. So we give around half an hour before, and by the time the patient is on table, the heart rate is stabilized. And when you give midazolam, it is further controlled or further stabilized, and you get a very good quality examination. On this front, honestly, I tell you, we have hardly any examination. We have done more than 350 now. There is not even a single case in which we have done a repeat examination.
Thank you so much, sir.
Okay, thank you, Basma.
Thank you, Single sir. And I thank our chairpersons who were Dr. Upasana Sinha ma'am and Dr. Srishti ma'am from the Department of Radiology, AIIMS Patna. I would like to request Dr. Pratap Patra sir to felicitate them. With this session, we have come to the end of today's programs. Now I would like to inform that we'll have a general body meeting of the Indian Society of Kawasaki Disease, following which I would like all the delegates to be back by 8:15 to 8:30, where we'll have a dinner along with live music. There's one more announcement. Speakers who are here and will be speaking tomorrow, I would like to request all of them to submit their presentations today so that it would be easier tomorrow. Thank you.